Good evening, everyone. I'm Dr. Sreeni Edakhlon, Chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons. I welcome you all to the 17th module of Kerala Society of Ophthalmic Surgeons Scientific Committee CME series. We have been doing it for the past 1 year and a half. So as soon as we took over, along with Dr. Arup Chakravarti, so what we have been doing is to have one virtual CME with one district ophthalmic club, so that we'll cover all the districts over the period of 1 year. We have already completed one cycle. This is the second cycle that is going on. Our idea is basically to involve the local ophthalmic clubs, as there are some ophthalmic clubs which are not really active. But TACO, COC, Kozhikode, Kannur are exceptions. This program is being done with TACO, the Thrissur team. And if you talk about the TACO, they're one of the best ophthalmic clubs in Kerala. Or if you take any ophthalmic club across India, that it will come among the top 3 or 5. But as you know, Kerala is the best state ophthalmic society. It's basically because of the a lot of activities done by all these district ophthalmic clubs. This CME is basically focusing on neuro-ophthalmology. Neuro-ophthalmology, if you take any, at least in Kerala state meetings, this is one of the most popular topic. And I'm really thankful to Dr. Latika for planning these sessions and planning the topics. And Dr. Jyoti Matalia from Nystagmus was really kind enough to talk to all the speakers. And because I know most of the speakers, but I'm not really involved in neuro-ophthalmology. I didn't know who would be good for which topic and all, but Dr. Jyoti selected the speakers, contacted them, and she was very helpful. And Nystagmus, even otherwise, it's a wonderful, vibrant organization. I'm thankful to Dr. Jyoti and Nystagmus for all the help. And this is basically on today's program. It's on neuro-ophthalmology. We have a few of the best speakers from across India. And to take it over from me now, I invite Dr. Roland Gottlieb, who is the president of TACO. Dr. Roland, please.
Good evening, all. And thank you, Dr. Sreeni. Myself, Dr. Roland Gottlieb, President, Thrissur Academic Club of Ophthalmology. So, warm welcome to each one of you to this 17th module of CME on neuro-ophthalmology, organized by Kerala State Ophthalmic Society and Thrissur Academic Club of Ophthalmology. So, very happy to welcome all the dear ones, especially the eminent faculties who have already joined. Some of you have already joined. So, I'm sure that this evening, that all the talks in neuro-ophthalmology will be beneficial for each one of us, and especially the topics on the clinical skills, investigations, and different diseases that we are going to discuss today evening. So I wish all the best for the CME, and just want to add one more thing. Thrissur Academic Club of Ophthalmology is very happy to host the 50th annual conference of Kerala Society of Ophthalmic Surgeons this year, and we are planning to have it in the month of November from 24th to 26th at Thrissur. So we would look forward to meet you all during the state conference, which is going to be the Golden Jubilee Conference of Kerala State Ophthalmic Society. So that is it. So our first session, the chairpersons are going to be Dr. Latika VK, Professor and HOD of Ophthalmology, Amala Medical College, and Dr. Radha Ramanan, Director, Eye Vision Eye Hospital, Chalakudi. So I hand over the session to the chairpersons. Thank you, Dr. Sreeni.
Dr. Latika?
Yes. Thank you,
Yeah,
Dr. Sreeni and Dr. Roland. It's indeed a privilege to be part of this great webinar on ophthalmology. And we are indeed in the midst of a stellar panel and stellar faculty. So I think the first session we are beginning with the basics, rather the clinical evaluation and the tips to ace your clinical diagnosis in your ophthalmology. So our first speaker is going to be Dr. Manju Bhate. She has completed her postgraduate education in ophthalmology from Pune, followed by an advanced training in comprehensive ophthalmology and a long-term fellowship in pediatric ophthalmology from Sydney, Australia, followed by a short-term training from Akron Children's Hospital in the USA. So Dr. Bhate brings along a vast and varied experience from different hospitals across the world. And she had been a consultant in the New South Wales and also a strabismologist later as part of a voluntary project. She was instrumental in setting up the pediatric eye care service at Myanmar in Southeast Asia. She is very keen in teaching. She's very passionate about teaching and also a member of various prestigious ophthalmological societies. She has also presented widely at various international and national conferences and has many publications in peer-reviewed journals. She's also currently a reviewer of for many journals, including the IGO Seminars in Ophthalmology, Asia Pacific Journal of Ophthalmology, and Current Eye Research. Her main areas of interest are pediatric cataract, complex strabismus, genetic eye diseases, pediatric neuroophthalmology, and ROP. So we welcome you very warmly, Dr. Manju, we welcome you very warmly to this session and your talk on the basics of pupillary evaluation.
Thank you so much. Thanks a lot for the invitation, and I'm really thankful to Kerala Society for this warm welcome. So can I just begin? I'll try and share my screen. Okay. Are you able to see my screen?
Yes.
Yes.
So let me know when you'd like me to start. Good evening, everyone, and a very happy. So I'm going to begin this session by talking a bit about the pupil importance and evaluation of pupils. So as we know, the pupils is more like a window to the brain and to see what exactly neurologically is happening. So the normal size of, the normal pupillary size in bright light is about 2 to 4 millimeters, whereas in dim light it's about 4 to 6 millimeters. And when we look at pupillary assessment, we need to look at the pupil size, the reaction to light, the near response, assessing the pupillary dilatation, and also looking at relative afferent pupillary defect and for the light near dissociation. And once we evaluate that there is either an isochoria, if it is present, then assessing whether it is physiological or pathological. Sorry. Can you hear me?
Yes, yes, we can.
Yeah, we can hear you.
Yeah, sorry. Okay, so the so as I said, the importance of the pupil is more in determining whether it is more of the afferent input, and also we come to know about the autonomic inhibition drug effect, the wakefulness, and it determines the retinal illumination depending on the size. So when we look at pupillary responses, we need to see the direct response, the consensual, and the near reflex. And the prerequisites for this includes a dim room or a semi-darkened room. The examiner needs to be actually pretty well versed with the procedure. The patient needs to be fairly relaxed with relaxed accommodation and looking at a distance target. So the gadgets that we can use for pupillary responses include a pen torch or an ophthalmoscope light, commonly an indirect ophthalmoscope light. Sometimes objective pupillometry can be done with the help of a pupillometer. I'll discuss a little bit later on in that. We can also assess with a slit lamp, a pupil gauge, and also nowadays with smartphones. So when we are testing, we also test both for the normal way, that is aim the light at the center of the cornea to assess the pupil size, and also aiming it from below the patient and asking the patient to look straight. So the angle of visualization is also important in these cases. Now, this is a video which shows a direct response. As we can see, the light is shown on the right eye, and we're looking at the brisk response, that is a brisk constriction of the pupil. This is both to the eye where the light is shown and the opposite eye. So in this subject, this is a normal subject where we're showing a normal direct and a consensual response. With the consensual response, we're actually trying to use an opaque occluder to block directly the passing of light from one pupil to another. So here, as we can see, we'll shine the pupil in front of the right eye and look for the response in the left eye. So with a brisk constriction of the left eye, there's an intact or a good consensual response. Similarly, when we shine the light in front of the left eye over here, we are able to assess the pupillary response of the right eye. And we can see over here in this video that there's a good consensual response. So these are the basic responses that we need to first test. Next is testing for the near response. So the near response is a very important test, especially when we do not get a good light response or a right reflex. So here we ask the patient to first look at the distance target. Now she's looking at this object which is situated near, and we can see that there is a constriction of both the pupils. Very commonly in cases where there is light near dissociation, as we can come through some of the examples later on, like ADs, there will be a light near disparity. So there will be no response to light, but there will be an intact response for near. So when we look at the right reflex pathway, there's an afferent pathway, then there is the internuclear fibers, and then there is an efferent pathway. So when we look at the light being shone, it's actually an upside down image. So when we look at the light being shone on one eye, so there is the optic nerve which will carry the fibers. So this yellow and orange that we are seeing to both sides. And when it will go through the lateral geniculate body, from there into the Edinger-Westphal nucleus, and then the efferent fibers, that is the green ones that you can see coming through the oculomotor nerve to the sphincter pupillae or the iris constrictor muscles. So also when we look at the consensual pathway, what's important is this round red circle which I've drawn, where there is crossing over of the fibers. So essentially what I'm trying to say is that if light is shone into one pupil, because of the crossing over and the fibers being on same and opposite side, we will see a consensual response as well in the other eye when all these fibers are intact. So this is just a little schematic representation of what I showed in the initial 2 slides of how the pupillary responses from the afferent will go on to the pretectal and the Edinger-Westphal nucleus, and the efferent through the oculomotor nerve into the short ciliary nerves and the iris sphincter muscle. So next we come to is some of the responses which are involved in near response. So in this, there is constriction of pupil, there is convergence, and there is increased accommodation. So all these 3 are important to have an intact near response. And then also what's important is that the autonomic pathway. So in the autonomic pathway that we have the parasympathetic and the sympathetic pathway. And as we know, the parasympathetic pathway is the one responsible for meiosis, and the sympathetic causes mydriasis. The other important thing which we often in clinical practice come across is the relative afferent pupillary defect. So when we talk of relative afferent pupillary defect, it is the response of one pupil as compared relatively to another pupil. So especially in cases of unilateral or asymmetric optic neuropathies, the response of one pupil is going to be less with regards to the brisk constriction. So this is when we need to assess for the relative afferent pupillary defect. So I've listed a few of the causes that we can see here. Most of these are asymmetric or unilateral optic neuropathies. So this is a little video which is going to depict the relative afferent pupillary defect in this child of the right eye. So here, when we see, when we are trying to shine the light, you can see the dilatation of the right pupil as compared to the left pupil, which is still fairly constricting briefly, whereas the right pupil dilates. And the test which is used to check for the RAPD is the swinging flashlight test. So in this, we swing the light from one pupil to another to assess the pupillary responses. And once we do that, the relative afferent pupillary defect, so here this is just a schematic representation of what I showed was the RAPD. So here we are swinging the flash, the light from one to the eye. On this side is the normal, where here it shows the relative afferent pupillary defect with this dilated pupil over here. So here this is showing the light shining, and the right pupil on this side is the dilated pupil, which is showing asymmetry. And in this also we have different grades that can be assessed both clinically depending upon how is the constriction or the dilatation of the pupil, and also with the help of neutral density filters, which are another relatively objective way of assessing the pupils. So sometimes we can be like students can get confused between HIPPIS, as well as there can be other causes where there is maculopathy or amblyopia, where there can be sluggish or some degree of RAPD present. This is just an example of a neutral density filter or how it looks. And this is a very useful tool to also assess or gauge the pupil and the pupillary responses. Now I'm just going to skip to this because it's going to be a fairly long presentation, but I'll come to a little bit about pupillometer and anisocoria. So this was an in-house gadget which has been built in LV Prasad Eye Institute, and this is actually a pupillometer wherein we have a set LED light focus, and this device measures the diameter of the pupil, measures the anisocoria, measures and quantifies the RAPD. So this is essentially how that little gadget looks. It has been further modified and it's got a new headset as well. So it is having improvised versions, but this is essentially the output where it shows the size of the pupils in light, in dark, and the grade of RAPD. This is just the raw data which shows some of the graphs which were taken, which are used, which are then extrapolated to give us the final results. After this, I'm going to come to a little bit about anisocoria. So as we know, sometimes anisocoria can also be physiological. That is, in this, typically the anisocoria is equal in dim and bright light. And the difference is like close to 1 millimeter, in fact, less. More than 1 is a little bit rare. And it can be seen in some percentage of normal individuals as well. What is more, and this is an example of a pupil gauge which we can use. It's a very simple ruler when we're actually measuring the pupil size to just hold it against, so we can exactly come to know what is the pupil diameter in millimeters. When we talk of pathological anisocoria, this is something which is more interesting. In this, it can either be the smaller pupil that is affected, and I've given some examples of this, of which I would say the most sinister one is the Horner syndrome, which we really should not miss, and also old ADs, where AD's pupil constricts over time, and when the larger pupil is affected. Again, in this, compressive third cranial nerve palsy is very important. So also is ADs and use of mydriasis. So just coming to an example of Horner syndrome. So this is something I give particular importance to because I remember very clearly, this was in my fellowship days way back in 2006-07, where I'd seen a small little baby, just about 6 to 8 weeks old, who the parents brought with a small degree of ptosis and anisocoria. So in Horner's, it's important to remember that the small pupil does not dilate well. There's a dilatation lag. So the anisocoria is greatest in the dark. And then we need to look at all the extra signs that may be present, like ptosis or decreased sweating or heterochromia. So this was this little child who presented with this, and the parents were doctors. They brought the baby with this slight droopy eyelid, and there was the anisocoria with the smaller pupil on the right side. And actually the baby had a neuroblastoma, and only after doing an MIBG scanning. So that, if you can see in this small little picture here, where the scan actually reveals a hotspot, that we came to know that there was a cervical neuroblastoma which was causing the Horner's, and then the patient underwent further neurosurgical intervention and follow-up. So this was a really important case, and very often when we want to confirm, we don't actually have cocaine in clinics here, unfortunately. But what's important is that the Horner's pupil does not dilate, whereas it will dilate. An apraclonidine test, which may be far more commonly available, this is something which dilates the Horner's pupil. So actually trying to localize the lesion or the site of the lesion is important. So next, as I said, is the AD's pupil. So this is an important cause of light-near dissociation. It's a common cause of unilateral involvement. More or less, it seems to affect females more, and is typically a big pupil which does not constrict well, and there is a slow response to near. So ADs is another important cause of anisocoria. And again, pharmacological testing with weak pilocarpine will constrict the sides of the pupil, and this is one of the confirmatory in-office tests that we can offer to the patients. Next is the Argyll-Robertson pupil, which is another important cause of light-near dissociation. And again, this is a small, irregular, poor dilating pupil. I know I'm going to fall short of time. I'll wrap up in 2 minutes, but I'm just coming to the last few slides. So the third cranial nerve palsy and the midbrain pupil, that is a mid-dilated pupil, is another very important cause of anisocoria. This is very important mainly because of compressive third nerve palsy, which can be because of any aneurysm. And so this is important to diagnose and not miss. So this kind of pupil is the one which will have no response to light or near. And if it could be painful, associated with diplopia, ptosis, and limitation of ocular motility. So as we can see here, the left pupil of this patient is mid-dilated. He also has a ptosis, and he had limitation of extraocular motility. In this 9 gaze, as you can see, there's limitation of elevation, adduction, and depression. So basically, this patient underwent an MR angio and an MRI, which was ordered on an urgent basis. And this showed the presence of a posterior communicating artery aneurysm, which you can see over here, which needed instant coiling so as to not rupture and cause any further catastrophe in this patient. So again, pupil many a times can be one of the first signs, and the ptosis can be quite subtle, and the motility limitation can evolve. So if such a patient comes to an emergency, assessing his pupils are very important before dilating such patients. This is just one last slide, which I'll talk of benign episodic pupillary mydriasis, in which there's a unilateral dilated and unreactive pupil. Half the cases may be associated with a history of migraine, and sometimes it's seen when there is previous trauma, intraocular surgery, or inflammation. So with this, I hope I could give you in a nutshell some of the assessment of pupil, how it is important, an objective pupillometry, and some of the important causes of anisocoria. And I hope that this will help in your practice with regards to assessing pupils better. Thank you so much.
Thank you, Dr. Manjushree. It's wonderful presentation. It's like a revision of whatever have. It'll be a big, not just for practitioners, and I'm going to share it with a lot of PGs also. It'll be extremely useful to them also. See, Latika, do you have any queries? I just see when it is a light iris, it's quite easy to assess the pupil and all. And see what about when you're checking the consensual?
Yes.
So if it is a really dark pupil, how do you actually look for it? Because yes, sometimes I do struggle to see what when I might be missing out somewhere, but it's not quite easy for me to check the consensual in very dark iris.
Yes. Yours is a very practical question, and I'm sure all of us go through that. So I think the main thing is not to have a very dark room. It still should be a dimly lit room, and probably have some sort of a light source either below the patient or above the patient, so as to give us adequate view of the pupil. I think that is quite important when we're trying to.
Actually, what we do is I instruct my residents generally to shine an ophthalmoscopic light, the minimum illumination of the ophthalmoscopic light onto the cheek, so that I get a reflected glow only, not falling on the pupil. So if I'm looking at the consensual in the left eye, for example, I would ask my resident to shine a small, very dim illumination onto the cheek and get a sort of reflected glow, not on the pupil, but maybe in the inferior part of the eye only. That is one way. And these days, I also would like to, sometimes when I am in doubt, I do use the loop when I look for a consensual, or if I'm in really doubt about an RAPD, I use the loop. Loop is very, it helps me a lot. That's something personal that I have, it has helped me in finding subtle RAPDs and defects of the pupil. So that's what I do.
Definitely useful tips. But yeah, again, I mean, the room there has to be enough of dim illumination in that room for us to be able to assess. And the other thing which I spoke to you of, the objective pupillometry, which is a lot coming into vogue now. So just putting that little gadget on the head will give us a good idea, that because that gadget will have a bright light coming to both eyes, one at a time and at the same time. So that will give us an objective measurements as well of the pupil. But definitely clinical age-old device methods are always the gold standard.
Yes, very impressive.
Some amount of ambient light level in the room, I think.
One more thing I would like to ask you, madam. Sometimes we get bilateral affections, and we have bilateral affections to the pupil where RAPD is not very easy to elicit. Yes. And so, do you think that, in your opinion, for the resident, we don't have access to the neutral density filters too much? So, pupil cycle time, I think, is a good clinical method there. So I sometimes use it in the OPD, and
that's of course, I agree with you, totally agree with you. That's also very important piece of armamentarium we would have.
Just one point I'd like to make here. When we talk about RAPD, we're talking about a relative afferent pupillary defect. So it's relative to the other eye. So in case you have a bilateral optic nerve problem, an RAPD which is in one eye disappears. So you no longer get an RAPD, you get both eyes sluggish. So sometimes just the pupillary reaction showing that it's sluggish is good enough to know that it's a bilateral. So if there's a unilateral optic nerve problem and the patient suddenly has a RAPD disappearing, then expect the other eyes also got involved. So at that time, this is for the resident, there's nothing like bilateral RAPD, it doesn't exist. It's a relative to the other eye. So if one eye is affected, you'll get an RAPD. If the other eye also gets affected, then the RAPD disappears, both eyes work sluggishly.
It's mainly for asymmetric optic neuropathies, where one is more affected than the other when we look at them in a relative thing. But when we see the other eye also being involved in that, brisk response which was present initially is also going to diminish, and that is also going to be slow and sluggish. Totally. Any other questions?
Yeah, Latika will go to the next speaker, and then we'll have the discussion later at the end of all the three talks.
Thank you.
So
thank you.
Thank you, Dr. Manju. Next we have Dr. Nikhil Chaudhary with us. He's a very illustrious and senior consultant in Center for Sight, and he has been associated with, he has been a consultant in glaucoma, neurophthalmology, and cataract in Shankar Nethralaya and the various campuses of LVP. And his areas of expertise include management of various disorders of the optic nerve, including complex glaucoma, surgeries for glaucoma, and cataract surgery in patients with cataract and glaucoma. So he has been a part of certain landmark trials. In landmark, he was a co-investigator of a major population-based glaucoma studies, including the Chennai glaucoma study and the Andhra Pradesh eye disease study. And he has presented his work at various national and international conferences and has nearly 100 research publications in peer-reviewed journals to his credit. He is also the co-author of Shankar Nethralaya's very famous Atlas of Neuroophthalmology. He has won several awards, the most important of which would be the GSI Pfizer Best Paper Award at the 4th CGIC International Glaucoma Conference. And very interestingly, he has established a model called the Diagonal Model of Glaucoma Care to implement tertiary level care for complex and advanced glaucoma at the rural in the rural population and in the underserved locations of the country. And this model is being advocated as an international model by the International Agency for Prevention of Blindness. He's also a core group member in the development of a toolkit for glaucoma management in the sub-Saharan Africa by the Light for the World and the ICO. So over to you, Dr. Nikhil, for your talk on tips and tricks in optic nerve head evaluation.
Thank you for inviting me. And I also thank you for giving me an opportunity to present in front of my mentors, like Dr. Naveen Jaikumar is here and Dr. Rashmin Gandhi is here. So thank you very much. Can you see my slides and hear me?
Yes, Dr. Nikhil, we can see.
Thank you. So I believe there are postgraduates here and practicing ophthalmologists. So I start with little basics and then go to some complex cases. Here I put some optic disc photographs, and yes, their magnification is different. But what is also striking here is their appearance of the discs is variable. And this is the real scenario. The discs may vary in their size, and if the size is different, certain conditions are more likely to happen. The shape of the disc may vary. The angle by which the disc is inserted on the globe can vary, and that can vary across any axis like X, Y, and Z. And at the same time, the processes which are affecting the optic nerve can also vary. Say, for example, a patient who has glaucoma can also suffer with AION. And likewise, there are so many processes which can affect the optic nerve. So I believe that optic disc is optic disc, and we should not classify that into a glaucomatous disc and a neuroophthalmic disc and so on and so forth, because when a patient comes, the patient doesn't say whether he has glaucoma or no glaucoma. It is we who have to find out what is the type of optic neuropathy or what is the underlying process that might be working in the given patient, and then go ahead with your management. So therefore, I thought I would talk briefly about optic disc examination techniques, and then I want to present a template to examine the optic disc. Now, this is irrespective of the process that is affecting the nerve, whether it is glaucoma, whether it is neuroophthalm, you can fit the same template. I would say you should fit the template in every patient that you are seeing, so that we don't miss anything and make a sense of the complete clinical picture. And optic disc drawing is also an important tool in this regard. And then you come to your management process. But at the outset, I would like to say that optic disc examination is a component of clinical reasoning process. And this is the foundation of medicine, that you assess the patient right from his or her demography, his history, the entire clinical picture, and then make conclusion. Otherwise, you see people seeing enlarged cup in a patient or pallor in a disc and just come to the conclusion that the patient has glaucoma or AIOL. That's not correct. So we have to take complete clinical assessment and then come to the conclusion. Optic disc is one of the component of this process, and it also has several components, and we have to follow all that when we see a patient. So these are the three ways in which we see the optic disc, and earlier days, or even in some practices even now, the direct ophthalmoscope is used very often to see the disc. and it gives a very magnified image of the disc. You can even count the number of small vessels on the disc, to count their number, to see whether we can predict if there is any optic atrophy happening. We can look at the laminar pores. We can look at how the vessels are coming out of the disc. All that we can do. But the most important problem is that it is a non-stereoscopic image. And as the understanding of the optic nerve evolved in the recent time, we realize that the most important thing when we see a disc is the perception of depth. And that's especially true for glaucoma. We need to see where is cup, where is rim, how the course of the rim is, what is the contour of the rim. And there are so many other things like what is there on the surface of the disc. Is there any pulsation in the disc? Can you induce a venous pulsation? These all, we realize that these all are important. And then that's how we realize that the stereoscopic view of the disc is very important. That can be obtained by an indirect ophthalmoscope also. But there the magnification is quite less. So the best, I would say, is to do a slit lamp by microscopy using one of the three lenses. 78D is a balance between 60D and 90D. But you use one of the lens on a slit lamp and take a good view of the disc, and that's the beginning. And not just that, I would also like to say, what is a normal optic disc? When I ask this to postgraduates, somebody says 0.3, 0.4, pink rim. That's not the description. And normal optic disc, very important, has a well-defined margin. There is usually presence of cup, but that may be absent in some cases, especially when the disc is small in size. And then the vessels have a particular course. In majority of patients, you should see venous pulsation, and the nerve fiber layer has a particular kind of reflection. Like you see, when we put a light on the nerve fiber layer, the light is reflected back, and that is a normal nerve fiber layer. So this all comprises a normal optic disc, and you may also see venous pulsations on the disc. And if they are not there, or if more importantly, if you saw them earlier and then they disappear, it carries some important significance. Now, when you look at an abnormal disc, there are so many things that one should see, and the list is very long. Especially when I say it is irrespective of whether it is glaucomatous or non-glaucomatous, then the list is very long. So what I do is I put a simple template. It's a 4-point template, and that you can apply at any optic disc that you are seeing. And I'm sure that you will get a good reasoning in that given patient. So the first thing that you see is you look at the size, the shape, and the margin of the disc. The size is defined by, you can put the slit lamp beam across the horizontal and vertical meridian of the disc, and you can get size. You can also measure the size and then look at the shape and margin of the disc. So these are small discs, and being small, they are at risk of ischemic optic neuropathy like this one. And here you see there is no cup, there is heaped up nerve fiber layer, and this is very prone for getting ischemic optic neuropathy. And hyperopic disc may also look like that. And if they get ischemic optic neuropathy, then you see a classic pallor in the upper segment of the disc with a corresponding visual field effect. You may see luxury perfusion in the other half in the acute phase, and that is what is ischemic optic neuropathy. If the disc becomes larger in size, then the cup is also larger, and this has a lot of significance when we talk about glaucoma. These are the examples where the shape of the disc is different, like this is a colapumatous disc, this is a tilted disc. And the first look at these discs on the top was a glaucomatous process, but actually the shape of the disc is abnormal. Actually, the rim is pink, uniform, and the nerve fiber layer is healthy. And this is a non-pathological disc. And this disc has ill-defined margin. And not just that, there is a hemorrhage here. There is hyperemia on the surface. There are folds in the retina. So this is a patient who has papilledema. So that's the margin of the disc. The next is you come at the neuroretinal rim, and the neuroretinal rim means the contour of the rim. If there is absence of rim at a particular point, like a notch in this patient, that goes more in favor of glaucoma. I'm saying more in favor, not necessary that every notch is only glaucomatous, but most probably it goes in favor of a glaucomatous process, whereas the color of the rim is very important when we look at neuro-ophthalmic conditions. Not just the description of pallor, it is also important that we look at what is the location of pallor. See, here it is a sectoral pallor in the superotemporal region. Here it is predominantly temporal pallor, and here is the pallor of the entire optic disc. Now, all this, the differential diagnosis is different. Or the things which we go top and which we go towards later vary when we look at each of these scenarios. The next is we come to the surface of the disc, and then there we look for any hemorrhages, or we look for any hard exudates. We look at the venous pulsations. These are all happening on the surface of the nerve. And then we go to the peripapillary region and the retinal nerve fiber layer. The peripapillary region may have different pigmentation, and that is important more for glaucomatous processes. So as the classic slit or wedge-shaped nerve fiber layer defects, but that's not the only case. You can have edema of the nerve fiber layer. You can have folds in the nerve fiber layer, and these are all parts of the nerve fiber layer. So here is the template. We first look at the size, shape, and margin of the disc. Then we come inside, we look at the color, we look at the contour, we look at the cup, we look at the rim, then we go to the surface, and then we go to the peripapillary region and the retinal nerve fiber layer. So this template will work for any type of neuropathy. Say, for example, we are looking at non-glaucomatous discs. Then what is important here is to look at the margin of the disc, to look at the color of the neuroretinal rim, to see whether cup is there or not, to look whether pulsations are there or not, hard exudates are there or not. And some of the features are common to both glaucomatous and non-glaucomatous, and some of them go more in favor of glaucoma. So going ahead, I will put predominantly examples of neuro-ophthalmology because this is aimed at that. But the point is that the same template can work for any type of optic neuropathy. So let us see at these discs. Now the margin here is blurred. This is a moderate size disc. The rim is pink in color. The margin is blurred in both the discs, and actually you see that there is edema. There is edema of the retinal nerve fiber layer. On surface, there is one exudate here. And this line we see because the nerve fiber layer is edematous and elevated here. And this opacity is the most important thing. We see that nerve fiber layer surrounding the disc is opaque. That's the key word. In contrast to this disc, where the nerve fiber layer is not opaque, this is a case of pseudo-disc edema because the disc is inserted obliquely, and because of that oblique insertion, this nerve fiber layer has to climb to reach to the surface of the disc. But the nerve fiber layer is not opaque. Opacity is seen here, and that opacity is because of axoplasmic stasis. That is because of raised intracranial pressure, and that is responsible for all the changes that you see in a true optic disc edema. So what I am talking or where I am leading to you is when you see a patient with optic disc edema, the first thing is you should see whether it is a true disc edema or a pseudo disc edema. And the key feature is the exoplasmic stasis that is causing obliteration of cup here, the swollen appearance of disc, obliteration of vessels as they are crossing the disc. But all this you don't see here. This is a patient of buried optic disc drusen and pseudo disc edema. Then there are other signs which may help you to decide what could be the likely process. Like this patient, there is bilateral disc edema. You see scattered hemorrhages, you see scattered exudates all around, but they are scattered all over the fundus. And when they go one disc diameter beyond the disc, the first differential is nothing else but hypertensive retinopathy. Look at this patient. Again, this is a disc edema. Margin is blurred. It's a moderate sized disc. Margin is blurred. No hard exudate. No hemorrhage. But there is a nerve fiber layer defect. And there are folds in the macula. And you look at the field, there is a nasal step. Now, all this, when we put all this together, if you just see the disc edema and not pay attention to the nerve fiber layer defect and this fold, then you are missing something. All this, when you put together, it points to that this is a patient of glaucoma indicated by this nerve fiber layer defect and the field defect. And this patient has undergone trabeculectomy that has caused hypotony, that has caused disc edema. So just look at the disc and you know what is happening. This patient, the first impression was myelinated nerve fibers. Yes, they are there. But in addition, the disc is large, cup is large. Next thought came to the mind that it is glaucomatous, but not. It's a large disc, large cup, rim is uniform. There is no localized or generalized loss of rim, but the rim is pale and the nerve fiber layer is generally lost. So this is a patient who is in his third decade, male person, gradually progressive vision loss, and that goes in favor of autosomal optic neuropathy, especially when he said he has hearing deficit. So don't go carried away by just this first impression and put the entire template and then see. These are examples of additional examples of associated signs. This is pale disc with edema and hemorrhages, no cup, goes in favor of ischemic neuropathy. This was a middle-aged lady who had chronic renal failure and venous sinus thrombosis. There is bilateral asymmetric disc edema. Pallor has set in. So this is papilledema. There are hemorrhages, hard exudates. And when you take even closer look, here you see these dots. These are exudation. These are called pseudodrusen, and they indicate chronic nature of disc edema, that is papilledema in this patient. And you can also see these lines. These are called Peyton's lines, and these come when there was disc edema that has gone into optic atrophy, and then the edema has resolved. So this tells us about an old disc edema. Similarly, you may have a prominence in the disc at one particular location, and this is a buried drusen, which was confirmed on neuroimaging. Another example where what is most prominent here is there is a temporal pallor and there is darkness of the papillomacular bundle. Okay, normally what you see is there are two bright zones, superotemporal and inferotemporal, and that's why we say that this is the nerve fiber layer is classically bright, dark, and bright. But actually, this is not dark. This is relatively less reflective. Say this is a normal eye where the papillomacular bundle is as reflective as the nasal retina, less compared to superotemporal and inferotemporal, but as similar to the nasal retina, but here this is dark and this is abnormal. And this has a set of differential diagnosis. And this particular patient has centrocecal scotoma, and it was found out to be vitamin B12 deficiency. So this is the importance of putting the template. This is another patient who is diabetic, has surface capillaries, hyperemia of the disc, and later on that evolved into development of pallor and ischemic optic neuropathy. And in the end, I would talk briefly about optic disc drawing. This I give a lot of weightage because apart from the first 2 points, it will ensure that you have looked at the disc completely. Otherwise, you may miss certain things. So there is no well-defined way to draw the disc. There is no standardization. So what we do is we draw a disc like this, and then we label that this is a temporal side, this is nasal side, this is the cup, and in between is the neuroretinal rim. And then you can show if there is a pallor or if there is a notch. You can even look at the relationship of the vessels to the notch, and that can indicate a progression. You can also look at the relationship between the vessels and the nerve fiber layer defect and the notch and correlate it with the visual fields. This patient has advanced glaucomatous damage, and this has optic disc edema. This is way to show the optic disc pit, and this is the pallor. So to conclude, the two most important things when you look at the disc is please have a stereoscopic disc assessment and ensure that you are looking at the disc in a total manner. Look at entire components and then put this into the clinical reasoning process to take your further decisions. Thank you.
A wonderful, comprehensive presentation, Nikhil. It was great. Which lens do you prefer for disc evaluation in slit lamp biomicroscopy?
I prefer 78 diopter because if you use 90 diopter, then you can use 90 diopter even in a small pupil, but the magnification is less. And 60 diopter will give you a good magnification, but you need pupillary dilatation. So I prefer 78D, and I mean, I myself have a 78D which I carry, and the hospital luckily has 90D. So I get both depending on the pupil size. But if you look at one single lens, then I ask my PGs and fellows to buy a 78 diopter lens.
If somebody who's used to a 90D lens, he can just have to take care of the magnification factor, right?
Yeah, they can continue using, but I mean, when we use the same lens every time, then we also form mental images. So when we change the lens and the magnification, initially you may have some difficulty, especially regard to the size of the disc or our comfort level. So I recommend you have one lens and use the same lens for every patient. So I carry my own lens.
And then for the nerve fiber layer assessment, you just would you prefer a red-free fundus photograph or just do it red-free on turn to the green filter and do it on the slit lamp? Well, that's the most practical one. But I mean, if you really you're given a choice between these two.
I see with red-free filter because fundus photograph is a very good tool. But what I have seen is the quality of image of photograph has large variation with different company cameras. And if it is a good image, then yes, because when we see a patient in reality, there may be difficulties like the media may not be clear, or patient may not be cooperating, or patient may have dryness of eyes and so on. And it needs some amount of experience to start picking up nerve fiber layer defects. But with time, we start picking them up. And so the thing that will work at most of the situations is clinical examination with a red-free filter. But if you have a good quality fundus photograph, then it's a good, important way.
Thank you. Dr. Latika?
Yes, I mean, it was a very wonderful presentation, full of practical points. Just about this green, the red-free filter, I find it a very useful tool, not only for fundus, the nerve fiber examination, but also for the disc proper and to see where the margins or the contours, to define the contours of the cup. The red-free filter is very, very useful. And the PGs also find it very useful, especially in the early stages. But once you put the red-free filter, one thing is that the illumination should be made maximum, because unlike in the usual in the usual visualization, that much of brightness we don't need. We usually put the slit lamp in the mid illumination, but once you are going over to red free, especially in cases with slight medial opacities, it helps to increase the illumination. And one more thing is regarding the photographs. Even if you have the facility to take photographs, one of the commonest mistakes we find is that it is generally, even when we send for a color fundus photo for a glaucomatous patient, the optic disc, the mode has to be switched on to the optic disc mode if it is actually the cup that we are going to focus on. The macular mode is not enough most of the times if you need to follow that patient up with the fundus photograph. Then regarding that very interesting point about that buried drusen, we do get patients very often, and we have a suspicion of a buried drusen. Dr. Nikhil, which investigation would you prefer these days? Because earlier we used to order an ultrasound as the first line of investigation because of its economic advantages and because it was very much available. But in a situation where we have the CT, optic disc, the ultrasound and the OCT, now which would be your single investigation of choice in a patient with suspected optic disc drusen?
It depends on availability. If you have OCT with which has good penetration, then you can do that. I still do ultrasound. If in case of doubt, you may have to do CT scan. But first thing I do is clinical examination, visual fields, and ultrasound, and if available, OCT.
Okay, thank you. Regarding the temporal pallor of the disc, I have a little small point to add there. This temporal pallor, many of us see in our practice, and as very rightly pointed out, visual field examination is a must, and also the history of addictions, especially tobacco, alcoholism, etc. We have to go back in that history, and in that patient we have to pay particular attention and go into the detail of this tobacco and alcohol addiction, because this type of toxic and nutritional neuropathies are what we are thinking about. But one point here is we always make it a point to send a neuromedicine consultation here, because I think it's equally important to rule out a compressive optic neuropathy in such cases before we, label it as a nutritional or a toxic, even though he may be an addict. So it's always good to have a neuroimaging done in such cases before, making a diagnosis of nutritional toxic.
Dr. Latika, we'll go to, just running short of time, we'll go to Dr. Jyoti's presentation. And thanks once again, Dr. Jyoti, for helping me out with the CME. I can introduce Dr. Jyoti. And
welcome, Dr. Jyoti, to your presentation now. So we are indeed honored to have you here after her basic medical postgraduate training and MBBS training was in Mumbai, and then she had a fellowship training at LV Prasad Eye Institute, Hyderabad, and an ICU fellowship at the Wilmer Eye Institute, USA. And now she's the head of the Department of Pediatric Ophthalmology, Nystagmus, and Neurophthalmology at Narayan Nethralaya. for the past 18 years. She is in charge of postgraduate training in her institute and is very passionate about teaching. So, she's actually a teacher for the volunteer faculty of Orbis International to teach and train ophthalmologists in developing countries. She has presented extensively, more than 300 lectures at various conferences and various award-winning videos also at several national and international conferences. So we welcome you, Dr. Jyoti, and over to you for your presentation of a very complicated topic usually in the open Nystagmus.
Thank you very much for the invitation and for organizing such an excellent feast for the neuro-ophthalmologists. You can hear me?
Yes, yes.
Yeah. So basically, to make it simpler, I had made a teaching video on Nystagmus, and that's what I'm going to really play, to try to cover up all the aspects, try to make people understand what is basically Nystagmus, what it is, and what are the possible treatment options, so that I know it's very difficult. You can take one whole day just talking about Nystagmus alone, but I'll try to summarize everything in 10 minutes. So just let me know if the video is audible so that I can just move on. Get past the jerk. Decoding Nystagmus. Nystagmus is a repetitive involuntary movement of the eyes. Evaluation of nystagmus might seem like a Herculean task even for experienced ophthalmologists. So let's get the terminologies right. A slow drift followed by a rapid saccade is a jerk nystagmus, whereas a sinusoidal oscillation with slow phase without a saccade is a pendular nystagmus. Nystagmus occurring in one eye is unilateral, whereas in both eyes, if present, it's a bilateral nystagmus. Nystagmus occurring when one eye is covered is latent, where it beats towards the fixing eye. However, when present all the time, it is a manifest nystagmus. Nystagmus symmetric in direction, amplitude, and rate between the two eyes is conjugate, and if asymmetric between the two eyes, it is a disconjugate. Amplitude is defined in terms of excursion as fine, medium, and coarse. Frequency is number of to and fro movements within a second. Both of them together decide the intensity, and that's minimum in the null zone, like in this patient in the right gaze. Jerk nystagmus is defined in terms of the direction of the fast phase, whereas pendular nystagmus can be either horizontal or vertical. Pendular nystagmus is not characterized by right, left, up and down, as there is no fast phase, but jerk could be right, left, upbeating or downbeating. The nystagmus is evaluated along these lines. In this video, we will provide a systematic approach to simplify its evaluation. It's either physiological or non-physiological. Physiological includes optokinetic, vestibular, or endpoint. Whereas non-physiological could be congenital or acquired. In congenital, it is congenital latent or latent manifest or a spasmus nutans. Whereas acquired could be any of these from gaze-evoked, vestibular, upbeat, downbeat, seesaw, or periodic alternating. Let's understand the types of nystagmus. These are the physiological. Optokinetic is a jerk nystagmus in which the slow phase follows the target, whereas the fast phase is the eye when it fixates on the new target. Vestibular, physiological one, is an altered input from the vestibular nucleus, a rotatory nystagmus due to stimulation of the vestibular labyrinth or the nerve due to rotation. The congenital nystagmus is horizontal, but also could be vertical or elliptical. It's jerky or could be pendular, and 90% associated with visual sensory disorder. Nystagmus evaluation needs a thorough history taking, as mentioned. So you need to look at the time of onset, whether it's constant or intermittent, the aggravating or relieving factors, presence of photophobia, night blindness, where you know it's going towards a retinal dystrophy, oscillopsia, indicating it's an acquired. So you have to immediately get a neurological evaluation. Otherwise, those are congenital, need not need a MRI or a neurological. And hence you have to look for other neurological issues, and family history is important. Followed by a detailed ocular examination that includes binocular vision, then monocular vision with fogging, which should be done in primary position and with the abnormal head posture, after giving full optical correction for the smallest font that can be seen for distance and near. The anterior segment should be thoroughly evaluated for any abnormalities, as mentioned, and also a detailed posterior segment evaluation. Now, absence of any ocular problem rules out a sensory nystagmus, and then we are looking at a congenital motor. So what are the management options? First and foremost, the objective is to improve the visual acuity by diminishing the amplitude and frequency, transfer the nystagmus blocking position to a frontal position, improve the abnormal head posture, and correct the strabismus if any. For that, we can either use prisms, bilateral base out prisms stimulating conversions. This can correct a small head posture, apex pointing towards the null zone. Then contact lenses, which help to increase the foveation time, and tinted can be given in albinism. Now, surgical management is basically reserved for those with an abnormal head posture, and the principle is to shift the null zone to the primary position and improve vision, to reduce the amplitude by weakening the muscle force on the recti and increase foveation time by tenotomy. Now, for horizontal face turn, the Kestenbaum's procedure, where you resect all the 4 recti as shown, along with augmentation. You can also use a Parkes modification, the 5-6-7-8 rule, but it doesn't correct more than 10 to 15 degree. Anderson is bilateral recessions. For example, null zone to left, weaken the levoverters. Now, nystagmus along with squint, like in this patient with left face turn, having left esotropia. The nystagmus surgery is done in the right eye, and the left eye, the strabismus surgery is done, and you can see the face turn corrected and the squint as well. For a vertical head posture, that is chin up or chin down, you tackle the vertical recti. So surgery designed to improve vision are artificial diversions using the bimedial recession, the unilateral resect, or a 4-muscle retroequatorial recession, tackling the MR and the LR. Coming back to the other forms of congenital non-physiological nystagmus, spasmus nutans, which is a triad of head turn, head nodding, and nystagmus, as you can see in this child, with monocular and asymmetrical shimmering, typically develops in the first year, resolves by 10 years, but need to rule out CNS tumor, that is a glioma. Now, coming to the acquired vestibular nystagmus, it could be central or peripheral related to the vestibular organ and the nerve. In case of the central one, we are looking at unidirectional or multidirectional, and peripheral, which is the unidirectional, the fast phase towards the normal ear. Central can be suppressed with visual fixation and has brainstem or cerebellar signs, but peripheral will not be suppressed and has other findings. Downbeat nystagmus is a jerky nystagmus with an updrift followed by corrective downward saccade. Look at this child having a downbeat nystagmus. Commonly seen at pontomedullary junction and flocculus of the cerebellum. Upbeat, on the other hand, as a fast phase beating upwards. In this child, note the upbeat nystagmus with a site in the superior cerebellar peduncle or a pontomedullary or a pontomesencephalic junction. Seesaw nystagmus is an intorsion and elevation of one eye and a simultaneous extorsion and depression of the other eye. Note the seesaw in this patient. As is seen, affecting either a diencephalic midbrain or unilateral midbrain or the lateral medullary lesion. That is a hemi-seesaw. Periodic alternating nystagmus is a horizontal nystagmus that predictably oscillates. A single concentrated effort of observation for at least 3 minutes is needed. Note the right beating here changes to a left beating. Note in this patient initially a left beating, eventually shifts to a right beating. So watch him for 3 minutes to detect if this changes. And the site is a nodulus and uvula. Torsional nystagmus is a rotatory movement of the globe about its antero-posterior axis. As is seen, the upper pole beats away from the site of the lesion. It is a pontomedullary junction or a cerebellar or a midbrain involvement. Gaze evoked, on the other hand, is the most common nystagmus when it's present only in a particular gaze and it's associated with cerebellar signs. Internuclear ophthalmoplasia is a disorder of the conjugate lateral gaze affecting the eye, shows impairment of adduction. When attempt is made to gaze in the opposite direction, the contralateral eye shows horizontal nystagmus. Left iono with an adduction of -4 and an abduction nystagmus. Convergence retraction nystagmus is a part of the dorsal midbrain syndrome with an upgaze palsy, defective conversions, eyelid retraction, and a light near dissociation. Note the conversion and retraction on attempted upgaze. The horizontal movements are perfectly fine, but the patient cannot look up. This is a classical convergence retraction nystagmus. So let's understand the pathology behind each of these. Dissociated nystagmus like an INO, expect the lesion at MLF, downbeat nystagmus cervicomedullary junction, upbeat nystagmus posterior fossa, seesaw nystagmus paracellular, monocular childhood nystagmus anterior visual pathway, periodic alternating nystagmus posterior fossa, convergence retraction nystagmus dorsal midbrain. Drugs are known to inhibit the excitatory neurotransmitters in the CNS. Commonly being used are baclofen, gabapentin, and acetazolamide, mainly for congenital nystagmus, seesaw, and acquired pendular nystagmus associated with multiple sclerosis. Botulinum toxin A alleviates symptoms in acquired nystagmus, that is the oscillopsia, to improve foveation time. 2.5 to 5 units can be given in all 4 horizontal muscles, or a single dose of 25 to 40 units in the retrobulbar space. So in summary, evaluation of nystagmus is multidisciplinary. Appropriately evaluate any neurological nystagmus. Try to improve the quality of life with drugs and optical devices and even surgical procedures to correct any abnormal face turn. No single procedure has shown to be consistently predictive of success, but this does not mean we cannot try. I hope this video has given an insight into what are the various types of nystagmus, what are the possible options of differentiating them, and what is the best treatment you can provide to a patient to improve his quality of life. Thank you.
Thank you, Dr. Jyoti, for making that the video. I don't think without the video you would have been able to cover it in total. Dr. Latika, we are almost through with the session time.
Yes.
Any questions to Dr. Jyoti, and then we'll move to the next session.
Actually, it was in a very excellent nystagmus capsule. So we need to swallow it and read it further. That is our job.
People can actually go back, revise it, see it again, and it's absolutely comprehensive, wonderful.
As mentioned earlier, it'll take a whole day to talk about it, but whatever is important, what is there, especially congenital and acquired, at least the tips which people can follow, so that when you see a patient, you should just know when to refer, when not to refer. So that is the idea of making the video.
Thank you. Dr. Latika, we can conclude this session and hand over to the next.
We thank all the 3 speakers for their excellent talks, and I'm sure all of us, not only the residents and the PGs, all of us benefited enormously from this session, and we look forward to the further sessions in this webinar. And let me conclude this and hand it over to Dr. Roland for the further.
Thank you so much. It was a great presentation, Jyoti.
Thank you for joining us. Thanks a lot. Dr. Andrews and
okay, good evening.
Good evening, sir.
Welcome, Dr. Sreeni, Roland, and Taco and KSOS. So, it's Dr. Lydia, wonderful presentation, the section 1 clinical examination. Now we go to section 2, encounter the enigmatic clinical roadmaps. So this is just more details about nystagmus and subismology. The first speaker is Dr. Jenil Sheth. He is from Sendilal Shanghai Eye Hospital, Mumbai. So he was in charge of pediatrics, subismus, and neuro-ophthalmology service of that hospital. He has a UG from Nayas Hospital, Bombay, and PG from LV Prasad, and he has a fellowship from UK in FICO. Then he has undergone fellowship at LV Prasad in neuro-ophthalmology and pediatric ophthalmology. Then he joined there as a consultant and worked there as a faculty for about 4 years. Then he shifted to Bombay, his native place, and in charge of the strabismology and neuro-ophthalmology. Today, I think he will be talking on the transient visual obscurations. So over to Dr. Jenil, and welcome to Dr. Jenil.
Thank you so much, sir. Thank you to the organizer. I hope I am audible and my slides are visible.
Yes, sir.
Yes, I would also like to thank Dr. Jyoti for extending this invitation and for this talk. So, transient visual obscurations, a very highly specific topic and a part of a bigger spectrum, which we shall see today, what all are inclusive of this. So, the moment we hear this term, and the first thing from our residency days, we were taught that what to think about is bilateral disc edema, or often called as papilledema due to raised intracranial pressure. But is that so, or there are many things within the spectrum? So unlike transient vision loss, transient visual obscurations are actually gray outs or blur outs. They aren't blackouts. Like there is no complete loss of vision, and the patient often says that the details are very fuzzy. But the most important here, apart from the pattern, is the duration. So these terms are very specific and very often loosely used in our clinics. But if we go back to our textbooks, they are very specific for certain conditions. For example, for visual obscurations, they only should range from 5 to 15 seconds. So possibly only a few seconds. If they last for minutes, then they would fall under transient vision loss, which has a different spectrum completely. Very often they are binocular, but there are also cases which are monocular. So they sequentially go into binocular or present monocularly also. And also one peculiarity of visual obscuration that they are precipitated by postural changes or eye movement. So if there is a sudden change in the posture of the patient, the obscurations would either precipitate or sometimes they actually even get better with certain positions. So like I was saying, transient vision obscuration belongs to a wider spectrum with the umbrella term of transient vision loss, which also constitutes classic migraine and amaurosis fugax. So for the next few minutes, we will go into focus on transient visual obscuration, and what it essentially means and why it essentially happens is because of the transient ischemia of the optic nerve head, and it is most likely due to raised intracranial pressure. So there is a change in the translaminar pressure across the subarachnoid space in the perioptic space and the intraocular pressure. And if there is a raise in the subarachnoid space, so there is a difference in the translaminar pressure, which causes ischemia and axonal death, which could cause a transient blurring of vision, which is suddenly recovered because it normalizes. There are certain conditions of the optic nerve head which would precipitate or exacerbate transient visual obscurations, like a very small or a crowded disc, presence of an optic nerve head drusen, often where patients are otherwise asymptomatic but present with visual obscurations. Optic nerve head edema is often present in such cases where patients usually present with obscuration, that is where they present for blurry or blur outs for lasting for few seconds, like 5 to 15 seconds, what I mentioned in the previous slide. So before we go into the details, let's see very two peculiar cases where patients present with such complaints. So case one is where the patient complains, my vision goes blur intermittently. This is a classical case where a 47-year-old male came to us with very typical complaints of visual obscuration which lasted 20-25 seconds. A doctor by profession was very observant about these findings, and he was otherwise, ocular examination was normal except when we do a fundus examination, and we saw this fuzzy margins of the disc and increase in the capillary density of the optic nerve head of the right side compared to the left side. And left side, like we saw in Dr. Nikhil's presentation here again, the margins are fuzzy, but we look at the vessels, they are very typically seen very clearly. And also there is some mild tortuosity that this could be a nerve head drusen in the left eye. A closer look of the disc, I think we can confirm our findings that there are vessels which are actually much buried. So likely there is a edema in the one eye and an optic nerve head drusen in the other eye. Now comes to the question of confirming our diagnosis. We did firstly the visual fields because the patient otherwise is normal and has a 20/20 vision in both eyes. And we can see enlargement of blind spot in either eyes, and the right eye, typically which we suspected of having edema over a possibility of underlying drusen, also shows a kind of a nasal hemifield incomplete concentric field defect, whereas similarly we see a superinasal field defect in the left eye as well. Autofluorescence clearly shows a superficial drusen in the left eye, and here because of edema possibly we can see some hyperautofluorescence here, but because of the edema possibly is not as bright as we see in the left eye. So possibly the diagnosis what we could make is bilateral disc drusen buried and superficial, and right eye possibly underlying disc edema. For further confirmation, an OCT of the optic nerve head again confirms our diagnosis of optic nerve head drusen, which was very evident in the left eye, of course, and we see this ovoid spaces which is surrounded by an hyperreflectivity, typically what an optic nerve head drusen is defined. However, in the right eye, we don't see such spaces, but we see certain hyperreflective spots which could possibly be PHOMS. Again, B-scan ultrasound, I believe, is a very sensitive test to pick up, but should be rightly done with a very low gain, and it shows an hyperechoic at the optic nerve head, and we see the spikes still maintained even at the low gain, which is very likely confirmatory of the optic nerve head drusen. If it is very evidently seen on the autofluorescence, of course, sometimes you might want to avoid it also, but B-scan still remains a very reliable test to pick up buried drusens as compared to the superficial drusen. I believe the best way to know a disc change is if you have the old records. And in this case, we were very lucky enough. For the past 10 years, the patient did complain intermittently of TVOs, which was, again, not very much taken into consideration the reason for it. And it was always considered that the patient had a drusen, so possibly he's complaining of visual obscurations. We look at the left eye disc and compared to what our presentation, it almost looks the same. But the right eye definitely shows a visible changes compared to the previous records here. The angiogram done again shows a very late stage staining, but there is no obvious leak, suggests that there was no disc edema prior. Similarly, these records are almost more than 5 years old as compared to when patient presented to us. Again, confirms the findings on the ultrasound. We see that hyperechoic bright spot on the ultrasound B-scan on either eyes, confirming a drusen being existent since a very long time. The field, unlike what we see right now, was completely normal when the patient was initially presenting with transient visual obscurations. Also, we were very lucky that there was already a neuroimaging which was happened, and it definitely the sagittal scan does show a partial empty cella, but not very obvious findings of the raised intracranial pressure of very bulbous perioptic space, or there is a globe flattening posteriorly. However, we do see some enlargement of the lateral ventricles, but not very consistent findings of the raised intracranial pressure. MR venogram does show the transverse sinus, which is obliterated on one side, but no definitive occlusion otherwise. In this case, our neurologist felt that it was not necessary to do a CSF opening pressure, which is very essential here, I believe, to complete the diagnosis of raised intracranial pressure or a primary IIH. We did start the patient on Diamox of appropriate doses, and in many weeks, you could see the right eye definitely showing resolution of the edema. We can see the surface capillary vessels also reducing as compared to the first presentation of the patient, and the left eye essentially remains the same. So there was hardly any edema in the other eye. Coming to the functional aspects of it, we definitely see an improvement in the visual field. If you just look purely at the grayscale as well as the pattern deviation, there is improvement in the left eye. Right eye, definite improvement in the foveal threshold. However, the field effect still persists, but the patient more or less is stable over the period of time. Let's quickly go to the case 2. It's slightly different. This patient initially complains of blurring intermittently or TVOs intermittently, and now it's all gone. The vision is completely gone. This patient comes with a very exaggerated response here of no perception to light in the right eye and a completely normal vision with a normal color vision in the left eye, which has a profuse vision grade 5 disc edema. Very unusual for us, and we almost think she's a middle-aged girl presenting suddenly with painless vision loss in the right eye, and such an asymmetrical disc edema could be anything. But neuroimaging is something which would make us more confident of our diagnosis. To our surprise, it showed all the evidence of a raised intracranial pressure. You can see the cuff of the perioptic space very nicely enlarged. There is a completely flattening of the globe at the posterior part. You can see nicely expansion of the perioptic space, also of the suprachiasmal space, which causes compression of the pituitary, so a partial empty cella. Typically, the transverse sinus here completely is obliterated on the left side. So this was very evident of raised ICT, and the neurologist thought deemed enough to directly go for a CSF opening pressure. And to our surprise, it was 93 centimeters of water, which is very unusual. But essentially, the other CSF composition was normal. So a diagnosis of asymmetric disc edema with a fulminant IIH because of very profound vision loss, sudden onset, which was preceded by episodes of transient blurring of vision. To understand why it could be a asymmetric disc edema, we also tried to analyze the optic canal diameter in the previous MRI images, and we thought that it could be one of the reasons for asymmetric disc edema, but in this case, they were essentially on both sides, the optic canal diameter was normal. The patient underwent a thecoperitoneal shunt and also was supplemented with oral acetazolamide, and 3 weeks post shunt surgery, we could see that the disc edema is nearly resolved in the left eye. And the right eye, the vision has drastically improved, but we can see an obvious pallor. We did get a repeat MRI done, and here you can see very typically the reversal of the findings of the raised intracranial pressure. There is no distension of the perioptic space. You can see the globe flattening is now reversed, and the empty sella, which was there previously, now you can see that the pituitary gland is much enlarged. And very typically of the MR venogram showing the left transverse sinus, which was previously obliterated or narrowed, we can see the beautiful filling here of the MR venogram. So complete reversal of the finding, of course, with the thecoperitoneal shunt confirms the diagnosis of this unusual presentation. So how do we approach such cases, which often when the terminology refers to as bilateral disc edema? First and essential is to know whether it is monocular or binocular. And often, like we said, the term transient visual obscuration refers to a binocular process of blurring of vision, or gray outs will last for only few seconds, like 5 to 15 seconds approximately. It should not last for many minutes. The next step is to differentiate from a transient visual loss, which is very important. So the history is very essential to ask the right questions and to understand, because often the patients are always worried and will not be able to explain completely how the vision loss was there. So the pattern of the vision loss, the duration is the most important. So a good history is very essential. A complete ophthalmic examination. Our visual fields is must. And the most essential test, if there is papilledema, or even in absence of papilledema or disc edema, a visual field is the most important thing to do in such patients to understand if there is any abnormal findings we could find. And of course, a neuroimaging, even in absence of disc edema, sometimes is very essential if you look at the visual fields and to support our findings and to confirm the diagnosis. To emphasize the history again, because the patient cannot describe always the type of vision loss which they have suffered through. Firstly, most commonly to differentiate whether it is monocular or binocular, the onset and the pattern of the vision loss, how long did it last? It was for a few seconds, or it was really for a few minutes, or sometimes even hours, whether it was painful or painless, and what is the quality of the visual disturbances. And often a migraine with aura would have a different kind of visual disturbance as compared to those with transient visual blur-outs. Were there any provoking factors or the other factors which would palliate the symptoms? Were they associated with any non-visual symptoms? What are the other comorbidities, as well as whether the patient is on any medications? These all are the essential history points which need to be asked proactively to the patient to determine that how the vision progressed. Now, at the very important time, as a neuro-ophthalmologist, one would always run behind looking at the disc and looking at the MRI images. We must not forget our comprehensive skills. So very often in the clinics, we would note that patient complains of this typically of blurring vision lasting for seconds, and this goes on for many months. And we have a normal complete examination of the optic nerve head, extensively examined by somewhere else, extensively examined by us. So again, going back to whether monocular or binocular, irrespective of that, is very important to look at the anterior segment. Dry eye is a very common complaint where the patients do complain of this transient monocular or binocular visual obscurations. Fuchs endothelial dystrophy needs a very careful examination, and these patients do come once in a while where they complain of blurring of vision intermittently, where we think of an underlying neuro-ophthalmic cause, but a simple slit line examination would have confirmed otherwise our diagnosis. Glaucoma again is a very important cause. Like we saw in the history of asking about medical history, topiramate-induced angle closure glaucoma again would cause a pseudomyopia and transient intermittent blurring of vision. So very essential to know the history of the patient. Pigment dispersion syndrome again would be responsible for transient blurring of vision where patients would present similarly. So to sum up, one spectrum of condition of visual obscurations, there are other two spectrums. Amaurosis fugax, again, it's a very typical classical terminology, again, very used loosely by the physicians. But what it means is amaurosis to darken and fugax fleeting, also called as TIA or transient monocular vision loss. It again belongs to a spectrum of transient vision loss where it is usually painless, but often can be painful also. usually lasts for 2 to 30 minutes or much longer as compared to the transient visual obscurations. And typically the patient complains of a curtain of darkness descending in front of the eye. And very often this is an etiology of vascular origin. It is very alarming both to the patient as well as to the physician managing it. Essentially, there are 4 things when it comes to amaurosis pupillans or transient vision loss monoocularly. Retinal ischemia, an impending CRA or CRVO or retinal vasospasm, a thromboembolism causing occlusion of the carotids or a stenosis of the carotid due to atherosclerotic plaque. A giant cell arteritis should be of very big suspicion if there is an older patient complaining of a monoocular transient vision loss lasting for minutes. And very unusual finding, but often described in literature, is a retinal migraine. So how do we work up these patients? Typically, the workup is threefold: the eye, heart and vessels, and the brain. A complete eye examination from anterior to posterior segment. Retinal imaging often needed when you do not find any typical findings, and fundus fluorescent angiogram would be very useful in such cases. Like I explained, as a neuro-ophthalmologist, visual fields is almost always necessary in such cases, irrespective of any abnormal findings or not. Heart and the vessels, a carotid imaging, which includes a carotid Doppler, a 2D echogram to look at any abnormal rhythm, as well as the presence of clots, which is causing a transient occlusion of the carotids, causing transient vision loss. When you suspect giant cell arteritis, of course, the first blood work you do is complete blood count, ESR and CRP. Again, MRI brain is very essential. In this case, when you suspect a transient ischemic attack, you always think of doing an MR angiogram to look for occlusion. DWI will definitely help you in certain cases if there is any obvious ischemia of the posterior visual pathway. Coming to the last part very quickly, which is another spectrum, classic migraine. Again, classic migraine, we all know how do they present, very typically called as a scintillating or shimmering scotomas. They begin from one corner of the eye, and the patients who are very much aware described as beautifully that how it progresses from one corner and completely engulfing the vision, lasts for a few minutes, much longer than a transient ischemic attack. It usually precedes the onset of the typical migraine symptoms, and patient will know that the patient is going to have a typical migraine headache and the visual symptoms come before. Essentially, the visual field examination remains normal in such patients, but it is very important to differentiate from other possible etiologies, which is occipital ischemic attack, also called as progressive reversible encephalopathy syndromes. In this case, it is due to vasogenic edema in accelerated hypertension cases or post-pregnancy, where there is vasogenic edema of the posterior visual cortex causing transient vision loss intermittently, which lasts for a few minutes and it is recovered very rapidly. Usually it is reversible if picked up early and managed at an early stage. Occipital seizures, again, is a very rare phenomena, but it is often described in literature, and the presentation is very different. They usually have a very brief episodes, not as longer as in transient ischemic episode of few seconds. But the visual phenomena is very different. They usually present with something like phosphines or bubbles they see in one corner of the eye, which suddenly increases. They're usually not progressive. They are often associated with other types of seizures, and often they would have an occipital AVMs if a neuroimaging is done. To summarize, in case of transient visual obscurations or transient vision loss, essentially the first question to ask ourselves whether it is monocular or binocular, because it essentially differentiates the etiologies behind it. If it is monocular, likely to eye is the cause. It could be vascular due to embolic or thromboembolic or stenotic. Retinal migraine, again, an unusual cause, is actually a diagnosis of exclusion. When it is binocular, we know the reason that it usually involves the posterior visual pathway. So, but again, a very good examination of the eye, like we saw that example of topiramate-induced angle closure glaucoma, which causes a pseudomyopia, intermittent blurring. So history is very important. Look at the findings of the eye. If essentially it is normal, imaging definitely helps us in certain cases. Papilledema, specifically the blurring of vision loss, is typically for lasting for a few seconds and what essentially is called as transient visual obscurations. Thank you for your patient listening.
Thank you, Dr. Jenil. Wonderful presentation, nice presentation, a difficult topic of transient visual obscurations. So I think lack of time, one question: what's the role of fluorescent angiography in a disc edema? Your autofluorescence already explained. Any role of fluorescent angiography to migraine, papilledema, or ischemia, or drusen?
Yeah, one of the best ways, if you say it's an invasive way, though now we have non-invasive tests that differentiates a true from a pseudodisc edema, is a fluorescent angiography where it shows a disc leak versus a late stage staining when it comes to distrucin. So essentially it differentiates true with pseudodisc edema. My purpose of retinal imaging here is in case of impending CRO where there is increase in the arm to retinal time, which also is a clue to some vascular event where the patient is complaining of transient intermittent loss of vision. So to differentiate from true and pseudo disc edema, now we have different modalities. I don't think invasive test FFA would be so useful. B-scan and OCT are now good non-invasive tools to diagnose them.
Sreeni, okay. Yes, sir.
Yeah, we'll move to the next presentation, sir. We're just running a bit short.
Madam, Madam.
The next presenter is Dr. Varshini Shankar. Dr. Radha will introduce.
Madam, unmute, Madam. I think Madam is not able to unmute. She is from Saraf Eye Hospital, New Delhi. She has her fellowship in pediatric ophthalmology, strabismus, neuro-ophthalmology at Natalia, and she has done a consultant at Natalia for many years. Now shifted to New Delhi and head of the pediatric neuro and ophthalmology. So over to Madam Varshini. So Madam will be talking on unexpected visual loss.
Thank you so much, sir. I'll just share my screen now. Thank you so much for inviting me to be a part of this session. I wish to thank Dr. Jyoti as well for involving me in this session. Dr. Jenil had an excellent presentation where he explained a lot of things which are overlapping with my topic as well, especially the importance of history taking in case of unexplained vision loss in order to determine what may be the possible causes. And I'll discuss a series of cases similarly. So when we are talking about unexplained vision loss, generally we are looking at this group of cases where the external eye is nearly completely normal, the retina appears normal, and perhaps there may be neurologic associations which may be causing the vision loss. And as Dr. Jenil already detailed in great detail, the first step is always a detailed history and examination. So we ask questions targeted towards what may be the cause of the vision loss, which will be whether it is unilateral, whether it is bilateral, what is the duration of vision loss, what is the rate of progression of vision loss, or is it non-progressive, is it associated with any pain as well, what is of course the age group of the patient, and what are the systemic features which the patient may have. Doing this, then we identify a category of visual disorder, by which we mean we try to localize what may be the site of the where the vision is getting affected. Is it the anterior segment? Is it the optic nerve? Is it the retina? Or is it more posterior in the brain? Once we make a rough clinical diagnosis as to what is the possible cause or site of vision loss, based on the specific constellation of clinical features which the patient may have, then we look at a targeted investigations including imaging, electrophysiology as well, and evaluating any systemic diseases which may be associated. I would first like to emphasize that when we are looking at causes for vision loss, we need to evaluate the person as a whole. So the vision may be 6/6 in some patients, but the patient may be stumbling and not even be able to make out furniture because of extensive field loss. So we need to look at the patient as the patient walks in. Like this child, we can see the child has a nystagmus, the child has an obvious oculocutaneous albinism, which would explain the vision loss. In this case, we can see that the child has an oculodigital sign, which may be indicative of what the cause of vision loss may be. Once we are done with that, as Dr. Jenil said, the first thing which we do out is rule out the obvious causes of vision loss with a very detailed eye examination. Very commonly, patients with dry eye, with SPKs, and especially early nuclear sclerotic cataract in young myopes are referred for evaluation for blurred vision, and occasionally even monocular diplopia. So these causes need to be ruled out first. Coming to optic neuropathies, I think the typical optic neuritis is easy enough to diagnose, but sometimes you have long-standing or old optic neuritis where a residual field defect may still be present, just a small central scotoma which the patient may come complaining of, which you're not very sure of whether it's new or old. Um, as mentioned earlier, toxic and nutritional optic neuropathies essentially are diagnosed based on the history, because when the patient presents, the examination is near normal except for field effects in a lot of cases. Leber's hereditary optic neuropathy, which is frequently confused with optic neuritis, and compressive optic neuropathy can be an extreme challenge to diagnose. Coming to the retina, again, fresh retinal conditions, especially since we have OCTs, are easy enough to diagnose, but long-standing venous and arterial occlusions, especially post a CRAO, may just present with a mild disc pallor with attenuation of vessels when the cherry red spot has gone. Similarly, old CSR may leave a small macular scar, lamella macula holes, toxic retinopathies in their early stage, hydroxychloroquine toxicity, retinitis pigmentosa, sign pigmento, or in early stages, the retina looks nearly normal and can be diagnosed only on electrophysiology. The bony spicules often appear much later, as well as rarer conditions like cancer-associated retinopathy and retinal inflammatory disorders. All need to be kept in mind. Finally, coming to psychogenic or functional visual loss, most patients with unexplained vision loss are referred for evaluation as malingering or functional vision loss. This needs to be kept completely as a diagnosis of exclusion. Visual symptoms which are long-standing, progressive, and non-fluctuating essentially suggest an organic etiology and not a functional etiology. So multiple evaluations as well as a detailed testing along with imaging is required before labeling a patient as functional. Malingering is uncommon in children. When seen, it's generally seen in girls in the age group of 9 to 11 years, generally tends to be bilateral and resolves with reassurance. Adults who may have more to gain from malingering, it's more common, maybe unilateral or bilateral, and recurrence tends to be more common until the underlying causes are dealt with. Now coming to a few cases which are often mistaken where the cause is difficult to determine. Coming to toxic or nutritional optic neuropathies, these patients, as I mentioned, essentially present with bilateral loss of vision, and the ocular examination is completely normal in the early stages. This was a 27-year-old lady presenting with blurred vision in both eyes for 1 month. She was very forthcoming about her history of addiction to cough syrup, sleeping tablets, and extensive consumption of both alcohol and smoking, as well as resulting eating disorders. She presented with vision of 612 in both eyes. The fundus showed, as Dr. Nikhil described, just this blurring of the nasal disc margin and a very characteristic central secocentral scotoma in both eyes, which is diagnostic. So we cannot, profile a patient and expect that we will know who will be have a toxic optic neuropathy and who won't. A detailed investigations, including consumption of all toxins, is must in all patients where you suspect this. This patient I am presenting because the incidence of ethambutol toxic optic neuropathy has increased many-fold in our OPDs. So this was a 43-year-old lady, 35 kgs, wheelchair bound because of TB spine, on ATT for the past 17 months with complaints of bilateral painless progressive vision loss for the last 10 months. By the time she presented to us, her vision was already counting fingers in both the eyes, but the correlation between ethambutol and vision loss had not been made. So by the time she presented, she had already developed disc pallor and extensive RNFL and GCC loss. I am just presenting this case to emphasize that every patient with bilateral vision loss now, we need to very closely ask them for history of antitubercular treatment, because it is extremely common and growing commoner by the day. So leaving aside toxic optic neuropathy, this patient was a puzzle. He was a 75-year-old gentleman, known case of glaucoma for many years, about a decade, had been on regular management. Pressures were well under control. These were his visual fields with an arcuate field effect in one eye, nearly normal in the other eye. Now complaining of gradual progressive loss of vision for the past 2 months. When he presented, his vision was 6/9 and 8 in one eye and 6/18 in the other eye. Pressures were normal, and the optic nerve essentially showed glaucomatous scupping. But when we repeated the fields, this was remarkable. This is a 10-2 with a near total loss of field in both the eyes. Now, this led us to panic, and I immediately thought that I'm dealing with a bilateral, maybe an atypical optic neuropathy of some sort. And I immediately ordered an imaging. But to my surprise, when we did the imaging, this is what we found. The patient had severe fusiform enlargement of the extraocular muscles. We can see here in the coronal section the enlargement of the medial rectus, inferior rectus, even the lateral rectus, superior oblique, and the superior rectus, compressing the optic nerve. And this is when you realize the importance of looking at the patient on the whole, because what I had missed when I saw the patient again, when he brought the report, is although the patient did not complain of any diplopia, any chemosis, any proptosis, you can see this mild proptosis in both eyes with the lid retraction and mild chemosis and congestion. Although the oculomotility was nearly normal, patient had no diplopia. So this just serves as a reinforcement that Graves' disease can present primarily with vision loss. Patients can be euthyroid as well, and this can be very rapidly vision threatening with very minimal anterior segment signs. This patient was immediately taken up for IV methylprednisolone, did not respond very well, and was then taken up for orbital wall decompression in order to salvage further vision loss. Coming to our next patient, this was an 11-year-old child who had been diagnosed elsewhere to have bilateral optic neuritis, was investigated extensively for the same and treated, and was then referred because vision did not improve after a course of intravenous as well as oral steroids. When we saw her, the patient had bilateral vision loss definitely, and a consideration, they had been referred to consider functional loss of vision. But when you look more closely at this patient, there was definitely an RP alteration, over the fovea, and coupled with a GCC thinning. If you don't look at just the RNFL is normal, but if you look at this extensive GCC thinning, you do have to consider a macular pathology as well. And when you evaluate further for that, the diagnosis is confirmed by a simple autofluorescence test. So, serving to emphasize that an extensive ocular examination is required to rule out all optic nerve and retinal conditions before subjecting a patient to extensive evaluation and management. Stargardt's is one of the most common conditions which is missed, mainly because the retina appears absolutely normal until the visual acuity drops significantly. This is a child presenting with a visual acuity of 20/40, again serving to emphasize the necessity of a careful clinical examination. The patient has a mild pendular nystagmus in both eyes, and when we look closely at the retina, you can see the complete loss of the foveal reflex, as well as these small vessels almost running across the fovea. And again, the diagnosis is confirmed on performing an OCT, which is an isolated foveal hypoplasia. Generally, we tend to think of foveal hypoplasia when it's associated with other systemic conditions like oculocutaneous albinism or aniridia, but can be present as an isolated condition as well. As now we move more posterior after finishing the anterior segment, optic nerve, as well as retinal conditions which can be easily missed. This patient was a 7-year-old girl, had already been on treatment for amblyopia for a couple of years. Her vision was 6/18 in the right eye, 6/9 in the left eye, not improving despite regular patching, and she also had a small right exotropia. On careful evaluation, especially in a red-free photograph, you can see this, perhaps this mild temporal pallor. It's difficult to, When it is symmetrical, it's difficult to know whether temporal pallor is true pallor or is that merely the appearance of the patient's optic disc. And with the easy availability of OCT, we usually tend to perform an OCT. And then if you see a thinning, that is more confirmatory. Patients presenting like this, especially these days, as we have become better at evaluating for cortical visual impairment, generally tend to have sequelae of hypoxic ischemic encephalopathy with mild RNFL thinning, which may present with mild vision loss and field loss. However, in this case, because the optic nerve thinning, temporal pallor was noted, MRI was done, and to our surprise, this patient had this huge supracellular tumor, a craniopharyngioma compressing the chiasm, which was the cause of the vision loss, and was then referred for surgery. So craniopharyngioma, especially when it presents in younger children, are frequently misdiagnosed as retrovulvar neuritis, psychogenic visual loss as well, or in our case as amblyopia. And finally, I will wrap up with my final case, proceeding even more posterior, coming to cortical vision losses. Now, cortical vision losses generally doesn't present as a central vision loss because the central vision is preserved till late and they usually present as a field loss. However, when only the posterior circulation is affected, very commonly the patient may have only visual symptoms or may have other non-specific symptoms like a transient headache or vertigo, dizziness, as well as other behavioral changes. And it's only on imaging that it actually gets diagnosed. A lot of times patient may present with bilateral vision loss, which is usually the second stroke affecting the other side. So if you have a bilateral infarction of the occipital lobes, this may then cause cortical blindness. Even in these cases, sometimes if the pole is preserved, then the central vision is many times preserved, but they may have extensive field loss. As we can see in this patient, you can see this right homonymous quadranopia and a left homonymous defect as well, which was caused after a second stroke. So I will at the end conclude my talk by saying that a careful history, a very detailed ophthalmic evaluation and tailored imaging is required, which helps us in picking up many causes of unexpected causes of vision loss. And when the diagnosis is uncertain, it is necessary to go back and look at the history. And as Dr. Jenil pointed out, the past evaluations when present, if the patient has old photographs, if the patient has old imaging, to reconfirm the diagnosis for us before proceeding with the management. Thank you so much.
Thank you, Dr. Varshini, for the nice presentation and the good slides. And let me remind the postgraduate students that a thorough knowledge of the neuroanatomy is very important for diagnosis of the lesion, site of lesion. And one thing you said, Dr. Varshini, for children, you don't get malingering usually. But if there is any malingering suspicion, how will you know about that case?
Yes, ma'am. So again, in any case of malingering, we suspect it only when the vision and the ophthalmic examination are not corresponding. So first of all, I would say we take a very careful vision examination and see if there is any variability in the vision, first of all. If we are thinking of malingering, there are many tips and tricks which are taught to us in post-graduation to do a visual examination with a pinhole, to check other forms of visual acuity like color vision, stereoscopic vision, which will be present and which a patient will respond to only if they have reasonably good vision in both the eyes. Variability is very important because even sometimes, even by using small refractive corrections like a 0.25 or a 0.12, the patient starts to read and the vision tends to vary between different visits. The pupillary examination tends to be very brisk and normal. And of course, the ophthalmic examination, the nerve, the disc, the OCTs all tend to be completely normal. We do a VEP examination if you are thinking about malingering. And a normal VEP is also suggestive that you are thinking on the right tracks, as well as a detailed history to elicit if there may be any underlying reason why the child may be malingering.
It's very important in children because we have to find out whether the child is having real visual loss. So the mother, parents should be always alert and they notify immediately. Otherwise, it will be late when we discover that. I think for lack of time, I will conclude. Thank you very much for the nice presentation.
Thank you, madam. I think we are running short of time. We go to the third topic that I might introduce my friend, Dr. Rashmin Gandhi from Center Foresight, Hyderabad. He is holding at present a various posts like a consultant and director of Neuro-Ophthalmology, Center Foresight, Hyderabad, editor of Neuro-Ophthalmology Society, adjunct professor of University of Hyderabad, managing director of Foresight Worldwide, so many posts. And previously, I think I know him for many years at Sanganathalaya for 13 years. And he was an adjunct faculty of the IIT Madras, various posts like that. And he has a number of presentations and publications in various national and international conferences and many awards. That's a long list. I am not going to the details because Rashmin Gandhi is very popular among all the ophthalmologists and my good friend. So over to Dr. Rashmin Gandhi to talk about the visual hallucinations. Are they diagnostic? A very difficult topic, I think.
Thank you. Thank you so much, Professor Andrews. First of all, let me thank KSOS, TACO, Dr. Sreeni, Dr. Matalia, and the entire team for giving me this honor. This is a wonderful topic that you have chosen and a lovely bit of speakers that we have. So as Professor Andrews, you mentioned that visual hallucinations is a little complex topic. And there are a few hallucinations which may be relevant to us as ophthalmologists, and we may be dealing with them either as a first presentation, or maybe we would be contributing towards a diagnosis. And I'll be restricting myself to most of those hallucinations. I'll start with a couple of stories. One is of Mrs. J, a 75-year-old widow who was referred to a psychiatric clinic by her physician, whereas the relative said that she has been behaving abnormally for the last 7 months. Initially, it started where she started seeing deities on various walls of the house, and she started praying to those walls, which was taken as a divine intervention by her relatives because Mrs. J had quite a poor vision, just the counting fingers in the right eye and 20/400 in the left eye. She was suffering from glaucoma, and on top of it, she started getting ARMD. But slowly in her course, the story changed. She started seeing people instead of deities, and then she started seeing males and females who she did not know from India and from abroad. She started seeing some explicit acts by these males and females, sexual related activities, and that's where the caretakers got worried, and that's where she came to a psychiatrist. She said that though she could see these people very clearly, but she never spoke to them. She did not hear them. And down the line, she was aware that what she was seeing was not really true. Similar story of a 71-year-old man, again a widower, who was again referred to his family physician because he was complaining of a disturbed sleep for the last 18 months. He said that morning when he wakes up after a brief sleep, he is quite okay. But then as the days progressed, he used to see some images, and in the night, he could clearly see a group of men, generally 3 or more, at his window and also around it. They all were pleasant, they all were smiling, they were giving pleasant gestures, but it did not allow him to sleep. However, his daily routine was not affected by this problem, and his mental state examination score was normal. So these two exemplifies few features. We are dealing with Charles-Bonnet syndrome, which one of the syndromes where we contribute to the management of the patients. A lot of times these patients are taken as suffering from a mental illness, though what they have is Charles-Bonnet syndrome, which is, and these are the features generally seen in elderly people suffering from visual impairment, from any cause. It can be ocular cause like cataract, glaucoma, or ARMD to the visual pathway lesions. Generally, they would have these hallucinations which are very well formed. They will describe that they can see the hallucinations or these images much clearer than their routine vision. They're very rarely disturbing. Whatever they see does not really disturb them. They are very rarely, they are disturbed, or generally these hallucinations are not really very aggressive for them. And it may have some element of a social isolation. So in 2015, we wrote a paper based on these two patients that we had seen in psychogeriatrics. Those times it was believed that the triad of Charles-Bonnet syndrome is complex or formed visual hallucinations, visual deterioration, and preserved cognitive status. Now it has changed a little bit, where you say that we still say that the hallucinations in Charles-Bonnet syndrome is clear and detailed. It can involve people, faces, animals, or even inanimate objects. Generally, over a period of time, the patients start getting that insight that whatever they're seeing is not real. It is associated with bilateral visual impairment with declining visual acuity. Patients who have a chronic visual impairment, once they lose vision because of their problem, generally it takes few months to up to an year to develop this problem. While patients who develop acute bilateral visual impairment, they can get Charles-Bonnet syndrome or these hallucinations quite early, within a matter of few days to weeks. Now it is believed that Charles-Bonnet syndrome can have an impact, can be precipitated by early cognitive decline or dementia. It also can be affected because of social isolation, sensory deprivation. So the reason why we come into picture is that a lot of these patients, they present late, as you saw in two of our patients. One patient presented 7 months after the onset of problem, the other one 18 months. So they don't report these symptoms because they fear that they'll be taken as mentally disturbed. And that's what happens a lot of times till they are told that their problems are real because of their visual impairment, and it's not, there's nothing really wrong with their mind. And we recently had a patient who was relieved when, and his relatives were relieved when the diagnosis of Charles-Bonnet syndrome was given to them. Another syndrome relevant to us, we can say hallucination, are the patients with cortical blindness. And these are the patients who deny that they are suffering from vision loss. Generally, these patients are patients who have infarction of primary visual area. It's not very common, a series where they were 50 patients with cortical blindness were checked for the presence of Anton syndrome, and 3 of them denied the presence of blindness. They can also have an associated memory impairment. It is believed that maybe the memory impairment is contributing to them denying blindness. However, the other explanation is that maybe they have synesthesia, where the input from the other senses, it translates into a mental image which patient starts perceiving as vision. So Charles-Bonnet syndrome and Anton syndrome, these are the 2 syndromes with hallucination which are of relevance to us in neuroophthalmology. There are retinal pathology which some experts believe the symptoms of those pathology should be considered as a hallucination, like flashes, floaters, and phosphenes. So if you say that these are a kind of hallucination, then we can say that, and especially postgraduate student, you can be asked about visual hallucination in retina. So any pathology which produces traction, irritation, injury, or any disease of the retina can potentially cause visual hallucination, PVD. These hallucinations are never complex. They are simple, like few shapes or a flash of light. The insight is intact. Patient knows that these are all not real phenomena. His mind is making it up, and it can be triggered by Valsalva maneuver. They are generally of variable frequency. It is believed that azure or cancer-associated retinopathy can produce these so-called hallucinations, which are a little more long-lasting than the other pathologies. And all these patients, apart from a detailed fundus examination, should be subjected to formal visual field test and maybe one electroretinogram. So now these are, this is one table where you say that the features, what kind of visual hallucination, what is the likely etiology. A lot of these may not be directly into our specialty, but I thought this was an interesting table where a simple pattern like spots and shapes generally is seen in migraine, epilepsies, or few tumors, while macropsia, micropsia, or metamorphopsia can be seen in epilepsy or CJD, associated with any hallucination associated with sleep, either just before you go into REM sleep or when you wake up from it, are called hypnagogic or hypnopompic, and they're considered as quasi-physiological. We all would have experienced sometimes even that sense of falling, a sense of being suffocated is also part of not really visual, but part of hypnagogic hallucination. Anton syndrome and Charles-Bonnet syndrome we spoke about. A frightening content of hallucination generally seen in delirium, a psychosis, or they are generally drug-induced. If you reverse the table and say that a particular condition, what kind of hallucination that you're likely to see, a migraine typically would produce a hallucination like an aura, which is not disturbing. It lasts for only a few minutes, versus peduncular hallucinosis, which is a well-formed, colorful, vivid images, which can last for a little longer, and it is seen in vascular lesions of brainstem. Dementia and neurodegeneration, they all can produce visual hallucination. Parkinsonism, for example, produces hallucination generally with a moving object. So patient would keep seeing that a particular object, like a lot of them would describe that there is an ant which is moving in the food or in the hand, and they'll just keep trying to clean it up. So that's typical of Parkinson's disease. Dementia, schizophrenia, and delirium, they all can come with formed or unformed visual hallucination. So the question, why do patients get hallucination? Though, again, as I said, it may not have a direct clinical relevance, but it gives you a fascinating insight into how the vision is processed in the brain. There is a network called default mode network, and reticle formation is associated with DMN, where this default mode network on fMRI seems to be active when patient is tired, or when a person is tired or person is sleeping. But it is the activity of DMN is basically suppressed when patient is alert or active. So there is a possibility that people who experience hallucination, visual hallucination, have hyperactivity of DMN. It's like you are dreaming while you are awake, because default mode network is active when person is dreaming. There's also an interplay of neurotransmitters, the four important one being dopamine, the neurons network with these neurotransmitters like dopamine, serotonin, acetylcholine, and GABA. And they usually, a lot of our visual input to the brain is not complete. The commonest example is blind spot. At a blind spot, we don't have vision, but the brain, with the help of these neurotransmitters, fills up that gap. So we don't see a blind spot routinely, even if you close one eye. So the network sort of creates a vision where there is none, or an image where there is none exist. So there is another theory that maybe some of these networks become active and start creating an image where none exist. Whatever may be the cause, the questions that as an ophthalmologist we should be asking when we encounter a patient with visual hallucination is, how did it start? How long typically does it last? Are those images formed or well-formed? Are you just seeing shapes, or you also see a formed image? People, are they disturbing you? Do you have an insight that these are not real? And any other features of early neurodegenerations like tremor, dementia, any emotional event. And there's a huge list of drugs which are hallucinogenic. So to ask for drugs, alcohol withdrawal, and nicotine. So to summarize, visual hallucination is a fascinating topic. A lot of these patients fall into cognitive neuroscience, neuropsychiatry, and neurology department. There are few where we would have a role to play, and we should always be aware of presence of Charles-Bonnet syndrome in somebody who has a profound visual impairment. I thank you for your kind invitation.
Thank you very much, Rashmin Gandhi. Okay, Sreeni.
Yeah, Dr. Rashmin is very popular in Kerala, as Dr. Ramesh is. This presentation has shown that life of a neuro-ophthalmologist is very interesting. And when you basically said you might consider these flashes of PVD as hallucinations. Can see one big trouble that we as phaco surgeons have is this negative dysphotopsia. Can it be written off as one of the hallucinations? Basically, an optical phenomenon, right? But is there a way out in managing these cases?
No, so since you have a physical, so hallucination is where there is no physical cause for what patient is seeing. I mean, he's just, his brain is conjuring up the image. While these coma and other images that you see post-cataract,
they have a reason. Wonderful presentation. It is very interesting. It is. I've not heard a presentation like this. It's excellent. I've heard your other presentations, but this was really interesting. Andrew sir.
Okay, I agree with the Sreeni, wonderful presentation, because he is bringing the topic of psychology or psychiatry into ophthalmology, combination of both, well explained. And the first time, I think I have not much knowledge about Charles-Bonnet syndrome or Anderson syndrome, etc. Is very highlighting, especially for pages. Anyway, you cannot roll out it is a psychology or psychiatric cases. You have to have a detailed examination. So I think Rashmin Gandhi has highlighted. As Sreeni already told you, we have good friends for many years. So welcome to Rashmin Gandhi, and thank you very much. I think we are running short of time.
On to the next topic. Dealing with diplopia by Dr. Ramesh Kekunnaya. He has had his undergraduate graduate training from Karnataka Medical College and PG from Government Medical College, Mysore. He has done his fellowship training in pediatric and neuro-ophthalmology and comprehensive ophthalmology from LV Prasad Eye Institute. Also had training in pediatric and ophthalmology and fellowship from Jules Stein Eye Institute, University of California, USA. His core clinical interests include simple and complex strabismus in adults and children, pediatric cataract, visual development, myopia, amblyopia, and neuro-ophthalmological disorders in children. He has received many awards from American Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology, International Scholar Award and International Education Award from AAO, Honor Award from American Association of Pediatric Ophthalmology and Strabismus Society. And regarding the journals, he is editor in BJO, Current Eye Research, and BMJ Open Ophthalmology. He has published over more than 150 publications and also is author in more than 25 textbook chapters. He has been a speaker at national and global levels and delivered many keynote addresses. His passion is in teaching and is a well-accepted person among his colleagues, and he is also interested in arts, mainly music, and also interested in viewing films. That gives relaxation, I think. So we'll go on to Dr. Ramesh Kekunnaya, dealing with diplopia is the topic. Over to you.
Thank you, Dr. Radha Muralidharan. It's really extensive. Thank you so much. I'm really humbled with your introduction. And thank you for the opportunity, the KSOS and the webinar and the TACO. Thank you so much. I'm going to talk about dealing with diplopia. I'm going to ask 10 questions here, and I'm going to answer to my best of my ability. I know the webinar is going a little bit, slow. So I'll try to catch up with time. With these 10 questions, I will try to cover in 10 minutes. So first of all, everybody should ask whether the double vision, both horizontal, vertical, torsional, is it monocular or binocular? Simplest thing, every one of us can differentiate just by putting a pinhole in the eye. Many times, subtle astigmatism, corneal problems, especially keratoconus, lenticular problem, especially post-subcapsular cataract or early cataract, and sometimes even index myopia. And of course, the holes created in the iris, either by a surgeon or by the trauma, can lead to this monoocular diplopia. So cornea, lens, iris. Look at that first, do a refraction, and most importantly, put a pinhole and send or refer them or before you are evaluating double vision. Because patients confuse double vision with diminution of vision, and sometimes they are confused. So the first step in dealing with diplopia is monocular. What is the solution? Check with pinhole. Second question, is it physiological? 2 to 5% of the patients who come with diplopia have physiological. They typically say, when I'm sitting in the clinic, you are seeing double, but the door behind you is single. So this is a physiological diplopia. Many patients get excited. Okay, I have this, and then they think this is something abnormal. This is a routine physiological diplopia. When you have this effect on when you're concentrating on something far off, the middle objects can look at physiological. And most of the times, what you experience is double vision related to abnormal eye movements. As a PG or as a practicing ophthalmologist, without any sophisticated instruments like slit lamp, OCT, SDOCT, anything, whatever 20 lakhs or 30 lakhs instrument, every one of us have two eyes to pick up, and we have this stereopsis to pick up the subtle eye movement abnormality. In my opinion, in a strabismus evaluation, if somebody can pick up that abnormal eye movements, either it is nystagmus, either it is limitation of the movement, or is it restriction of the movement, this will lead you to the diagnosis. So sometimes it can be sight-saving, sometimes it can be life-saving. Many PGs and residents and ophthalmologists ask me, what is the most important check in strabismus? I tell two things. One is the good history, and second thing is abnormal eye movements. Because of the time factor, I can't show you cases of sixth nerve palsy, third nerve palsy, fourth nerve palsy, all that. But that's the most important thing. The next thing, what is most important is the double vision is worse in some direction. Some people have, okay, when I look at right, I have a double vision. When I look down, especially in superior oblique palsies, most of the times they will come with an explanation that in down gaze, they have diplopia. Or if you are dealing with Parkinson's patients or some patients of progressive supranuclear palsies, they can also have vertical saccadic movement. They can confuse. So which direction it is worse? That's important. And obviously, when they move to your clinic or when they walk into your office, abnormal head posture, all of us know it can be because of horizontally in sixth nerve palsy or Duane syndrome or any kind of fracture. They can also have tilt. They can have also chin up and chin down position. So are the eye movement full or not? Do they have double vision in one particular gaze? That's why they will have this abnormal head posture. These are the three very, very important questions. And along with that, if you can do a cover test in each of this position, you can differentiate what muscle is that. And always, there is a masquerade. Whenever diplopia comes, if it is not fitting into sixth nerve, somebody has ptosis with esotropia, you would not think it is a third nerve palsy. If somebody has exotropia with hypertropia and ptosis, you will think third nerve palsy is the most important. Somebody having a mixed thing in both eyes, you are not figuring out what is happening. Most of the times, it can vary during the day. That is the greatest masquerader in neuro-ophthalmology or strabismus, that is myasthenia. So all your rules of abnormal head posture, limitation, always keep in your back of your mind myasthenia. Myasthenia's disease is the simplest thing to diagnose if the features are typical, like fatigue sign is there, ptosis is there, limitation is there. With the sleep test or ice pack test, it improves. It's pretty easy. But sometimes there are cases, sixth nerve palsy, no history of trauma, no history of brain tumor, no history of any kind of prothrombotic factors like diabetes mellitus or hypertension. Sometimes it can be even due to sixth nerve palsy. Many people don't diagnose, but it can be a possibility. The seventh question is there any recent trauma? Because when there is trauma, there are two things which can happen. One is because of the pressure injury, you can have a head trauma causing various cranial nerve palsies. Second thing is you have to pick up the sign of orbital fractures. There could be enophthalmos, there could be chemosis, there could be crepitus, there could be nasal step or the orbital bone step defects. As Jenil said in his talk, comprehensive evaluation is most important before you come up with any kind of diagnosis. Patients with diplopia will never walk into you saying that I have sixth nerve palsy, please evaluate it. They will always come with double vision. Your question is it monocular or binocular? Prove it. Is it vertical, horizontal, torsional? Then you are looking at which muscle to look for, because I can see the limitation in abduction. Then I am thinking about mostly a sixth nerve palsy. Trauma and previous surgery also is important, because some of the patients who had strabismus surgery, they can have new onset strabismus. Sometimes it can lead to, like, for example, if you do a intermittent exotropia surgery, and if it goes into consecutive esotropia, because they are good fusers, they can have a horizontal diplopia because of consecutive esotropia. So trauma, any kind of trauma because of injury or surgical injury, you need to rule out. The eighth question is there any proptosis? Is there any dystopia? I think all of you know what is dystopia. Dystopia is ocular position. It's not that ocular alignment. Position can be outward deviated, outward proptosis, or enophthalmos, or hypoglobus, or hyperglobus. Sometimes any of the, it could be because of local cysticercosis of the muscle, or it can be because of thyroid disease. They can have diplopia. So again, you need to look at proptosis or signs of orbital mass. But when you deal with proptosis, always there is one more structure to see, that is pupil. Never ever forget to check pupil in all cases of double vision. The 9th and 10th question is more or less classic neurological syndromes. Orbital apex syndrome, cavernous sinus syndrome, idiopathic intracranial hypertension. They will have papilledema, because you say that there is a bilateral sixth nerve palsy, and if you can pick up there is papilledema, then you know that it's mostly neurological syndrome, specifically related to some kind of increased pressure due to various reasons. It can be idiopathic intracranial hypertension, it can be tumor, it can be any kind of hemorrhage in the midbrain or things like that. And the last thing, which is a little bit rare, is what I have put here. Meningitis. If somebody has, you get a call from a ICU, patient is admitted in a neuro ICU. It can be trauma or infection like meningitis. It can be new onset metabolic disease, especially in kids. It can happen. It can be carcinoma, which is spread to brain tumors per se. It can be, in some patients have a recent behavioral change. They can have ataxia. They can even have a pontine tumor. Why am I saying all these possibilities? The double vision is a sign. You need to come into a diagnosis by looking into history, clinical signs, neurological association, and always there are two things we need to do. One is check for other cranial nerves, and also little bit of basic neurological examination. Every resident and every ophthalmologist should be able to do it. And the last thing is, remember, whenever lid is involved, check for eye movements and position. Whenever pupil is involved, check for the other things like ocular movements and lids. If somebody comes with ptosis, always look into these things. Mnemonic for that is LMP or LOP. These things, it takes 30 or 40 seconds to check. But if you incorporate these comprehensive evaluation along with slit lamp and fundus evaluation, of course, correlative visual acuity, you will derive, and your algorithm for diplopia can be better, and you will always lead to some diagnosis for the patient which is relevant. Most of the times you can make that diagnosis, and you could be able to seek help of some specialist if required in some of the cases. That's all I have to share. I have not put any cases here, because if I show the cases, then people will think, okay, even if I show a Duane syndrome, that comes as a diagnosis, referral diagnosis as 6-nerve palsy. Thank you very much. I'm very happy to answer if there are any questions. And most importantly, thank you for this opportunity to share my views on diplopia algorithm.
Thank you, Dr. Ramesh, for the nice presentation, putting it in a very simple way in a very short time. Is there any questions?
Ramesh, nalla presentation.
Thank you.
If you don't know, he's basically Kerala, so he understands and speaks Malayalam. See, you have a cranulopathy and whatever, you have diplopia. When do you actually intervene? It's not resolving. The diplopia is resolving. And what do you do until the time you resolve? I mean, it takes some time. Your MRI, everything is normal. It's just a vascular cause of it. So when do you actually intervene? And see, the patient is actually really troubled in between. So how do you relieve the patient's symptoms in between? I know it's basically a diagnostic algorithm
basically when a patient comes to you with either 6-nerve palsy or the 3rd-nerve palsy, which is related to ischemia, some kind of ischemia, I do 2 to 3 things. Number one, I'll ask them to limit their activities, basically driving, walking alone, all these things. Second thing is I put a sellotape for their glasses so that they are comfortable while cooking or reading or watching, because all this happens in elderly patients most of the times. We don't want one leading to another fracture, orthopedic fracture or something like that. So I always, many people don't like to patch their eye. If they don't, I put a sellotape in between the glasses at the center. You have to demonstrate to them how to do it, because they are happy that nobody is asking why it is. Because diplopia is the most troublesome sign or symptom in ophthalmology, one of the most troublesome. If we have to check it, put a 4-prism vertical and see how difficult it is. That's number one I do, Sreeni. Number two is in a 6-nerve palsy, depending upon the kind of profession, if you are dealing with somebody who is still working, I would offer them something like botulinum toxin for the medial rectus, just so that some temporary relief will be there. There is no guarantee that botulinum injection will make diplopia 0. It might reduce 45 PD to 10 PD. For that patient, diplopia is diplopia. For you, there is a drastic improvement. So these things I explain, and sometimes 6-nerve palsy injection, and they'll come back to you with ptosis. You know, it's one of the side effects. So as such, I wouldn't do anything for the next 3 months to 6 months. 99% of the patients in 3 months, they come back to normalcy. 99% of the patient. Sometimes in superior oblique palsy, 9th month, I remember 3 patients very, very clearly. 9th month, traumatic superior oblique palsy. I just advised surgery at 9th month. They did not take date. They came back at almost 1 year follow-up. Everything is resolved. So if there is an improving trend, I try to wait for some more time. But on an average, if MRI is normal, traumatic or ischemic, I generally say 6 weeks to 3 months, it'll go. In between, some feel-good factor should be there for the patients. I give some vitamins because doctor did not give anything to me. It's like, is he looking at me correctly? All these questions come. And if you relieve the diplopia, it's like optic neuritis patients. Counting fingers to 20/20 with visual acuity, with IVMP, if you give, you're God to them, most of the people. And if you can relieve diplopia, what magic you did, doctor, in 3 months, everything is gone. They are really grateful for this diplopia. But in between, I always caution them, if there is any kind of new symptoms, please come back to me. Please don't hesitate. Because you are dealing with the ischemic body. Things are changing post-COVID. I've seen some of the patients developing stroke. All these things are changing. The whole ecosystem of brain and the eye is changing, and brain and heart is changing. Vascular ecosystem is changing after post-COVID era. So we need to be careful, but I always introduce this word saying that if there is any additional problem, please get back on an emergency basis. Otherwise, straight away 3 months, you will have good result in most of these patients.
Thank you. Like if you don't actually give multivitamin, they might go to an Ayurveda physician. They might give something, and
absolutely,
they say, yeah,
absolutely.
They say, okay, they treated me.
They treated, and somebody can even give steroids. Something I don't like to give is steroids. Many people, even in 2023, I see giving steroids for a typical patients of ischemic. This is something we need to avoid because it increases your diabetes or sugar level, and it's unnecessary. And if you don't give, you're absolutely right. The hero is somebody else. So even if you have a good brain saying that you have evaluated everything, but you need to mix art and science together in medicine.
Yeah, thank you. Madam, you're muted.
Very nicely explained. And one thing I want to tell, I usually patching, Dr. Ramesh has said, and alternate patching also can be tried.
Yes, Dr. Radha, it helps because sometimes the force of abduction can move the eye. You know, they don't have to look at the TV like this. So that also works.
Very nicely explained.
Thank you, ma'am. Andrew, sir.
Thank you very much.
Yeah. Thank you, everyone. Thank you for the opportunity.
We are running short of time. So.
Yeah. Thank you, Ramesh. And we'll move to the next session, which is on optimizing investigations in neuro-ophthalmology. How to choose and use. The chairpersons are Dr. Annie Sridhar and Dr. Arun Thomas. Dr. Annie, Dr. Arun, please take over.
Hello, everyone.
Hi,
Can you hear me?
Yeah, sure. Yeah.
So till now, we have had all the talks focusing on how to examine a patient, how to take a proper history. But now we will see which investigation we should request and for which condition and how to interpret them. So this will give us an advantage of how to clinch the diagnosis. So let's move on to our first speaker is Dr. Abhilasha Parke. Welcome, Dr. Abhilasha. Hope she's here.
Dr.
Abhilasha?
We'll start with Dr. Purnachandra.
Oh, okay. Dr. Arun?
Yeah, good evening. It is my pleasure to welcome Dr. Purnachandra. Dr. Purnachandra is well known in the neuro-ophthalmology circles. He has completed post-graduation from AFMC College, Pune, followed by a long-term fellowship in VR surgery at Narayan Nethralaya, Bangalore, and has undergone additional training in inherited retinal disorders and electrophysiology at Moorfields Eye Hospital, London. He completed a preceptorship on age-related eye disease from Save Sight Institute, Sydney, and has presented several papers on national and international forums. He has published articles in peer-reviewed journals and has won several awards, including the Rama Mohan Award for Best Paper in Retina, Professor Natarajan Award for Best Paper in Vitreoretinal Diseases at AOS, and Best of IGO Award. His areas of interest are inherited retinal diseases, electrophysiology, retinal vascular diseases, and gene therapy. He's a great speaker. Over to you, Dr. Purnachandra.
So thank you, Dr. Arun. Hope I'm audible.
Yes, please go ahead.
Okay, so thank you so much, KSOS and TACO, Dr. Sreeni and Edakhlon for this opportunity. So I'll be talking about electrophysiology, how it can help in some of the neuro-ophthalmic disorders. So I think I know like electrophysiology is something we know even as a postgraduate, even myself didn't give that much of importance because I thought or everyone thinks it's quite complex and volatile, but it's not like that. Once you keep practicing it, it is simple mathematics. Fine. So first to understand the definition of an ERG, it's the mass response of a retina to a luminance stimulus. You stimulate the retina with light or a pattern, there will be biochemical and ionic changes which happens in photoreceptors and RPE, which is recorded as which generates electric potential, which is recorded as an electroretinogram. So just like in ECG, we have PQRS. In ERG also we have some waves like A wave, B wave, oscillatory potential. A wave is from the outer retina, that is photoreceptors, and B wave is from inner retina, that is predominantly from the bipolar cells. So this is very important depending on the kind of wave which is affected. So we can localize the diseases. When it comes to ERG, we need to understand there are different types of ERGs available. So this is important whenever you want to refer a patient or read an ERG report, you need to know what kind of ERG we should order. I'll come to the VEPs later. So first is a fulfilled ERG, which is the response of a luminance stimulus from the entire retina. Okay, so the fulfilled ERG gives information from the entire retina, whereas pattern ERG is predominantly from the posterior pole. In multifocal ERG, we check each and every point on the posterior pole. So this is how a typical fulfilled ERG printout looks like. This ERG printout is from our various machine. These are the standard graphs. The way we arrange horizontally or vertically, it may differ, but these are all the ISO standard graphs, which has dark adapted and light adapted recordings. So the dark adapted ERG is recorded from 20 minutes of dark adaptation. So during these 20 minutes, even if there is a light exposure for even 1 second, that 20 minutes have to be reported. That 20 minutes needs to be repeated. So in this dark adapted state, if you stimulate the retina with a very low intensity of light of 0.01 candela per centimeter square, you get a very big positive deflection, which represents rod activity, isolated rod activity. There is no contribution of cones in this. Once we increase the stimulus to 3 candela per centimeter square, the A wave starts appearing. The cones will also start contributing, which we call it as combined response. That is, there is a contribution from both cones and rods. So these are dark adapted responses. Then coming to the light adapted responses, which is recorded after 10 minutes of light adaptation. In this light adapted state, if you stimulate the retina with 3 candela per centimeter square light, what we get is a predominantly cone driven response. I'm using the word predominantly. In the same status, if you stimulate the retina with 30 Hz flicker, at such an high frequency, the rods cannot respond at all. What we get is an isolated cone-driven response. So this is how we started with a rod-driven response and we ended with a cone-driven response with a spectrum in between. So all we need to look is which component is affected, whether the cone component is affected, the light or the rod component is affected, or whether both are affected. So there is a second type of ERG, which I told is a pattern ERG. The ERG which I showed just now is a fulfilled ERG, which is a response to a luminance stimulus, which is where we're stimulating the retina using a Gansfield bulb. In pattern ERG, we use contrast as a stimulus, not the luminance stimulus. And there is no contribution from the peripheral retina, as I told. So in pattern ERG, there are two waves, P50 and N95. There is one more negative reflection in N35. Don't give much importance to that. For us, the P50 and N95 are important. The P50 gives information about the macula, whereas assessment of retinal ganglion cells, we can conclude by looking at the N95. So basically, it complements VEP to distinguish between an optic neuropathy and a maculopathy. So if you have a patient where P50 is normal, in presence of an abnormal VEP, we are very sure we are dealing with an optic nerve disorder or beyond and not a macular problem. So it always complements fulfilled ERG. Also, as it complements VEP, it complements fulfilled ERG to know whether the disease is just limited to the macula or the entire retina is involved. For example, if we can have problems where the disease is limited to the macula, where fulfilled ERG can still be normal. So the other form of ERG, which I told, is a multifocal ERG, which allows detection even small foci of retinal dysfunction. Here we stimulate the retina with either 61 and 103 hexagonal elements with a central fixation point. At any particular point of time, only 50% are illuminated. And we get a waveforms which corresponds to each and every point on the macula. So because of which we can detect even a small foci of retinal dysfunction. And most of the time we use multifocal ERG when we study drug toxicities. And none of these ERGs should be taken in isolation. It has to be combined with other imaging modality or a VEP. So before I go to the case example, few slides on visual evoked potential. So by definition, it is the electrical signals which generated at the visual cortex in response to the visual stimulation. Impaired VEP is anatomically non-specific. That is something very important. So I'll explain that with a case example. It is used in combination with other comprehensive ophthalmic examination, clinical modalities like visual fields, MRI, ERG, and things like that. VEP results should never be taken in isolation. So let's look at the physiologic origin of this VEP. This is predominantly from the primary visual cortex, referred to as striate cortex, which receives projection from the lateral geniculate body for the way of optic radiation. And these projections terminate in alternate eye specific columns in cortical layer 4. I'm sure you are all neuro-ophthalmologists, you are quite familiar with this pathway. So, but there is something interesting when it comes to the topographical representation of the VEP. Because VEP is dominated from activity of the central visual fold. The fovea are represented disproportionately by a large cortical area in the posterior part of the striate cortex close to the scalp. So that is at least 50% of the cortical neurons will have their receptive field in the central 10-degree field. So whereas the peripheral retina has a lower ganglion cell density, the reason being each ganglion cells in the periphery receives a converging signals from the several photoreceptors. Whereas in central retina, there is almost a 1:1 relation between a ganglion cell and a photoreceptor. So that's the reason the central, the macular part has got a larger representation in the cortical area as compared to the peripheral retina. So clinical recording, modern VEP use contact electrodes, amplifier, signal average computer. I won't go into the technical details of how we record it, but this is how we place the electrodes we need basically 3 electrodes. We use more electrode in case of multi-channel or a multifocal VEPs for a basic VEP. So these 3 electrodes are sufficient, and the locations are as shown in the figure. So we use different types of stimulus in VEP also, depending on which there could be different types of VEP: flash VEP, pattern reversal VEP, pattern onset and offset VEP. In flash VEP is recorded by giving a luminance stimulus. We switch on and switch off the stimulus. Whereas in pattern on off, at one point we'll show the patient a pattern that is checkerboard and is switched off. Whereas in pattern reversal, the patient will be seeing the pattern both the times, first time and the second time, but only thing is the pattern gets reversed. The black will become white and the white will become black. So this is the difference between different types of VEP. So let's try and understand about pattern reversal. As I told, this is elicited by checkerboard-like stimulus by alternating black and white square checks that reverse in irregular phase frequencies. So by VEP, if someone says to me VEP means, it refers like they have done a pattern reversal VEP, because this is the study of choice and it generates relatively consistent response and has a high reproducibility within a subject. And there is a low variability of waveform and peak latency. So study fixation and best corrected near visual acuity are required during testing. That is something very important. So sometimes I get report with an abnormal VEP. So if the technician is new, they must not have corrected the patient. I should always instruct the patient should bring their glasses in case if they're using one for distance vision or whatever. Because sometimes using the trial frame to correct them in case if they have not brought the spectacles is not a good idea, because the trial frame, the metal, can sometimes interfere with the recording of the VEP. So when we ask the patient, when you give an appointment, it's very important that we should give these instructions, like they should bring their glasses, and also we should avoid them against using shampoo for when they wash their hair. So this is how a normal standard pattern reversal VEP looks like. It has got a negative NN75 and a P100 and a N135 negative wave. So the P100 latency prolongation is the most reliable indicator for clinically significant abnormality, the maximum value of which is 115 milliseconds. So in patients younger than 60 years, if the patient is more than 60, sometimes in 120 milliseconds and 125 milliseconds in males and females respectively can be taken as normal. And interocular P100 latency difference should be up to 5 to 6 milliseconds, and more than, if it's more than 10 milliseconds, is considered as grossly abnormal. Amplitude measures from the preceding trough to the peak of interest. So the amplitude of P100 is measured from the trough of N75 to the peak of P100. So it is considered as abnormal if it's below 10 microvolts and abolished if it is less than 3 microvolts. So that's about the basics of VEP and ERG. I will try to simplify everything because each and every topic can be we can discuss for an entire day. So I'll show a few case scenarios where there's an uncertainty about what's happening, what's intended, and what's required. And these are the typical patients who visit retina specialist, neuro-ophthalmologist, neurologist, psychiatrist, and all that. So this is one such patient who was a 26-year-old male who had a night vision problem, had undergone extensive systemic workup and also an imaging workup. As I told, this patient had literally consulted everyone. He then came to us. So vision in the right eye was 6/30, and the near with both eyes it was 6/30. Near vision in the left eye was better, right eye it was impaired, it was N12. Color vision, somehow you could read all the plates, but it was very slow, you could identify all the plates. We examined the fundus, so it was absolutely normal. OCT was also normal, all the layers were quite intact. So we did an ERG. So because and in ERG we had a surprise. If you look at this ERG graph, the blue is the normative one, the black belongs to the patient. The dark adapted responses is almost a flat line. It is unrecordable. and the other responses are also grossly diminished. But this dark-colored rod-driven response seems to be disproportionately affected as compared to the light-adapted responses. Young male presenting with a night vision problem where fundus, OCT, everything is normal. The first thing what we think of is vitamin A level deficiency. We ordered for a serum vitamin A, which was very low, that is 0.02 nanogram per liter. On general physical examination, he appeared malnourished, because this is something we should not forget, that though we are ophthalmologists, we are also general physicians. When a patient comes, we need to examine them comprehensively. When asked some leading questions, he gave history of dyspepsia, frequent loose stools. So because like vitamin A is less, which is explaining the ERG, but our job doesn't end there. Why should a 26-year-old who is a non-alcoholic, why he should have a vitamin A deficiency? We need to find out that cause. After extensive workup, he has to undergo a finally intestinal biopsy, which showed a feature suggestive of intestinal lipofuscinosis, which is an endpoint of any chronic Crohn's disease or irritable bowel syndrome kind of a disorders. Not irritable, sorry, inflammatory bowel syndrome. So we supplemented this patient with 1 lakh unit of daily doses, followed by a 50,000 international daily for 2 weeks. And we repeated the ERG at 1 week, 1 month, and 2 months. So if you look at the ERG as presentation, which is almost unrecordable, just by 1 week, his patient's symptoms started improving. The amplitude of the behavior started improving. By 2 months, the ERG was completely normal. So that is one case which can masquerade as a neuro-ophthalmic or any other psychiatric disorders. And the second case is a normal looking retina with an unexplained visual symptoms. This was again 26-year-old female, recently married, brought by husband because she was quite inattentive to the surroundings and there was no positive family or the past history. And she was giving variable responses because since she was brought by in-laws and she was not ready to accept that she has a vision problem. And anterior segment, posterior segment, everything was normal. OCT, I'm showing you all the cross section. It was an absolutely normal OCT. So newly married, brought by in-laws, where everything is appearing normal. The fundus autofluorescence is normal. The first thing which comes to our mind is malingering. So before labeling any patient as malingering, I keep telling this in all my presentation, we need to subject them for electrophysiological test. So as a protocol, we started with an ERG. For our surprise, when you look at the ERG, the dark adapted responses are completely normal. The light adapted responses are unrecordable. There's a flat line. So that means though her retina is structurally appearing normal, the cones in the entire retina are non-functional. So this is a classic case of achromatopsia, which is a form of stationary cone dystrophy. It's a non-progressive. This is the kind of defects what we see in an achromatopsia, which resembles photic retinopathy. But this patient had an absolutely normal OCT, which is possible in some of the cone dystrophy syndromes. So there is one more thing which I wanted to add. This since neuro-ophthalmology specific, there is something called photopic negative response, what we record. This is a slow negative component of the full-field electroretinogram that has been shown to provide specific information about the retinal ganglion cell activity. So I'll just explain this a case example. This was a 68-year-old female with a poor vision noticed in right eye on closing left eye a month ago, and the right eye vision was very poor, and color vision was also abnormal. Left eye vision was relatively okay, 6/9 she had. However, the color vision was abnormal in left eye also. On field test, she had left-sided homonymous semianopia. MRI did show a presence of suprasellar mass. It is a straightforward case. So we did an VEP where flash VEP appeared normal, but the waveforms were not that reliable. Where pattern VEP was in both eyes, though the left eye vision was 6/9, that was undetectable response. What you are seeing, all this is noise. So this is the photopic negative response of the same patient. I have put the normal on the right-hand side. If you compare the normal in the right eye, look at the 1 Hz and 4 Hz. In 1 Hz, the photopic negative response is okay, but when you increase the frequency to 4 Hz, it is grossly abnormal in the right eye as compared to the normal. The left eye, which had a 6/9 vision, definitely there is an evidence of ganglion cell dysfunction. It is not normal. So this patient, we are when we are interested in repeating this photopic negative response post her intracranial tumor removal, it will be interesting to see to what extent this RG is functionally recovered. So she has not come for the follow-up yet, but it will be that's something new which you can look into. To conclude, I would like to say electrophysiological tests can never lie. So whatever that appears structurally normal doesn't mean it's functionally normal. So do not fit electrophysiology into clinical diagnosis. Try to fit clinical diagnosis into the electrophysiology. Thank you so much. I'll be happy to take questions if any.
Thank you very much, Dr. Purna. It's an excellent talk, and also the very important message of not labeling somebody as malingering unless you have ruled out everything and obviously done the electrophysiological tests. Thank you.
And I think we'll always have to keep vitamin A deficiency in mind. In these 2 or 3 sessions, we have had 1 or 2 cases, I think, of vitamin A deficiency, isn't it? So these are very quite interesting set of cases, Dr. Purna. Now, we are honored to invite Dr. Shikha Rajesh Basi, who is the Deputy Director of Neuroophthalmology at Changranetralaya. And she has a reviewer of many national and international publications. And she has won the prestigious SD Attawale Award at APAO, AIOS, and also the IRSI Best Poster Award. And she has published papers on optic disc drusen's and anomalies of OCT in papilledema and pseudopapilledema. Welcome, Dr. Shikha.
Thank you, ma'am. Thank you for the kind introduction. At the outset, I would like to thank. I'm not able to share the screen. Am I sharing the screen?
Yeah.
Am I sharing the screen?
It's come. It's come.
Yeah. 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 At the outset, I would like to thank KSOS, TACO, Dr. Matalia for inviting me to talk about OCT neuroophthalmology. So OCT neuroophthalmology is used to image the tip of the afferent pathway, that is the optic nerve head, and give us reproducible and quantifiable measurements in terms of peripapillary retinal nerve fiber layer thickness analysis and the macular ganglion cell inner plexiform layer thickness analysis. It also gives us cross-sectional image of the optic nerve head. We can reach right up to the lamina cribrosa. The actual power of this technology is in giving us the cross-sections of the optic nerve head in using a non-invasive and non-contact technology. We'll look at a few conditions where these cross-sectional images can give us so much of insight into these neuroophthalmological problems. This is a case of morning glory disc. We all can diagnose morning glory on the fundus examination, but if you look at the finer details the cross-section of the OCT is giving us, we can see the evolution of 2 different pathologies from 2 different layers of the retina. The outer retina is is the reason for formation of the CNVM, and the forms are originating from the inner layers of the retina. You can see the prolapsing axons in this case. And we all know CNVM forms more frequently in the temporal area of the disc, in the temporal peripapillary area. And you can see that it's active here with the cystic spaces seen around, which can be seen in the cross-sectional image. Here we can see in the colorful depiction how 2 different pathologies are originating from 2 different layers. Another place where the cross-sectional images can give us A deeper understanding is in cases of pseudopapilledema. Pseudopapilledema can be because of optic nerve head drusen, which can be seen in adults by, you can do a fundus evaluation. If they are superficial, you can pick them up by fundus evaluation. On ultrasound, they can be picked up, and OCT description has also been given. But it doesn't happen this way in case of pseudopapilledema in children, where in many cases it's the forms. You don't get these classic drusen. What you get is forms and a little bit of basal elevation of the peripapillary retina. And sometimes horizontal hyperreflective lines in the deeper layers can be noticed in case of pseudopapilledema. Similarly, we can glean a lot of insight into true papilledema by looking at the cross-sectional images in the OCT. This is a case of chronic papilledema, and you can see that inward denting of the Bruch's membrane and retinal pigment epithelium complex. And this can be clearly seen in cases of true papilledema. Similarly, here, this is a case, the upper images A and B are from the cases of true papilledema, where a triangular subretinal hyperreflective space is seen, which is very different from that of case of pseudopapilledema in a child, where there's just a subtle nasal elevation and actually only a forms there. Now, this was about the cross-sectional images. Now we'll come to the quantifiable images, what knowledge we can get from quantifiable images. Before we go to the quantifiable images, we need to know how to acquire these images. So quantifiable details on OCT. So we should know about the OCT protocols. The first one is about peripapillary retinal nerve fiber thickness analysis, which can be acquired by getting a circular cross-sectional retina scan, which is obtained at a diameter of 3.4 to 3.5 millimeters centered around the optic nerve head. In spectralis is the OCT. This is how you get the printout. You get the averages in the 4 quadrants. And in case of Cirrus HD OCT, the lower one is from the Cirrus HD OCT. Again, you get the averages in 4 quadrants and also in 12 clock hours. For getting the macular ganglion cell in a plexiform layer thickness analysis, the retinal layer segmentation is required. Different OCT manufacturers use different methods to do so. In spectralis machine, this is how you get the printout, and you can get exclusive ganglion cell layer thickness. Whereas in Cirrus, you get a combination of the ganglion cell layer with the macular IPL layer thickness as well. The printout in Cirrus machine is like this. It's an oval area projected, whereas in case of spectralis, it's a circular area shown. Now let's see how to read these quantifiable data. So this is the retinal nerve fiber layer thickness map, where the warm colors, that is the yellow and the red, are showing thicker areas of the RNFL, and the colder colors or the blue color here is showing where it is thin. The RNFL deviation map shows us how different this map is from the normative data. We also get extracted horizontal and vertical tomograms, where you can look at the pathology, and we also get RNFL circular tomogram, which is nothing but the cut section of the retina along this circle. Along with this, we get the averages, as I said before, the averages in the 4 quadrants and the 12 clock hours. This is the printout from the Cirrus machine of the GCC at the macula. Again, warm colors are showing that just around the fovea, GCC is the thickest, and the colder colors are showing where it's thin. And along with that is the comparison with the normative data, which is the deviation map. And here we get the averages in 6 sectors along with the tomogram of the macula. Now, before we start analyzing this data, we have to look for the artifacts. If the artifacts are present, then it becomes null and void. So a poor tear film can cause artifacts. Motion artifacts can be there. In uncooperative patients, children, it may become difficult. So you have to be very careful while analyzing that data. There could be segmentation error. Mirror artifacts can be seen in myopic eyes. Now let's see how can OCT be used in cases of optic neuritis. We know in optic neuritis there is inflammation of the optic nerve. Whether it is seen on fundus examination, that is whether the patient has papillitis or not, does not make a difference. Even if the back part of the optic nerve is inflamed, it's going to cause exoplasmic cholestasis, which is going to show up on the OCT as a thickened peripapillary RNFL. Over a period of 4 weeks, this thickening settles into peripapillary retinal nerve fiber layer thinning. And the pattern of thinning is exclusive involvement of superior and inferior quadrants in case of NMO spectrum disorder. And in case of MS optic neuritis, it's usually the horizontal quadrants that are involved. One important thing is that the RNFL thickness does not correlate exactly with the visual function. What correlates with the visual function is the visual acuity and the visual fields, and it takes about 2 weeks' time for it to become evident on the scans. In case of acute optic neuritis and multiple sclerosis, there is thickening. This is a case of acute optic neuritis. There is thickening of 2 quadrants and there is thinning in the other eye because of the past subacute attack. Now, this is very important because it is giving a neurologist an evidence of dissemination in time and space. Very recently, the neurologists have acknowledged this as a tool for monitoring cases of multiple sclerosis. And in case of NMO spectrum disorder, as I said before, the vertical quadrants are more involved. This patient, we all know NMO spectrum disorder, optic neuritis is a very severe involvement of the vision, and here in one eye the patient couldn't do the OCT because the eye was nearly blind. Now we can also monitor, the neurologist can monitor the RNFL thickness and tell whether the patient has activity of MS or not. Now coming to the GCC layer at the macula in the same 2 patients of multiple sclerosis optic neuritis and NMO spectrum disorder optic neuritis. In the acute phase, it is till 2 weeks, nothing happens to the GCC in acute optic neuritis. You don't get any information. But after 2 weeks, this patient has had a previous attack and you can see a lot of yellow, red and green. This is the GCC layer in a case of MS optic neuritis. Now compare it with that of NMO spectrum disorder where it's all red and there is a severe GCC loss. You also can get microcystic macular changes in retinal OCT in patients where they've had severe optic neuritis. It may be because of NMO spectrum, more common, or also in MS optic neuritis. It occurs because of the loss of the Muller cells, and these are actually small hyperreflective spaces which are seen in the inner nuclear layer in the parafoveal region. Now, an important thing is that in multiple sclerosis, the RNFL thinning is progressive, just like any other degenerative disease of the brain like Alzheimer's and Parkinson's. Whereas in NMO spectrum disorder, it is attack related. Now, one more thing, can RNFL thickness analysis be used to diagnose a visual pathway tumor? I'm not too sure about this. Look at the information given by the RNFL, which is normal on one side and just a little bit is thinned out in the other eye. And the visual fields giving us a lot more information. GCC correlates better with the visual fields. It's wiped out here in one eye and here it's a 3-quadrant and there is a hemianoptic defect on the visual fields and the similar hemi-GCC loss on the OCT. And this is a deviation map and it's correlating very well. So GCC thinning occurs even before the visual field changes occur, barring a few situations which we shall discuss later. Now, so OCT can be used to monitor these patients who have visual pathway tumors. This is my last slide. Optic neuropathy and maculopathy. A very, very confusing diagnosis, that is visual loss of unknown reason. OCT really helps us where you can pick up diseases like a ZOOS and HCQ toxicity by doing OCT. And this is obviously along with the MFERG, you can clinch the diagnosis. So that was my last slide. Thank you.
Thank you, Dr. Shikha, for making OCT clearer to us. Okay, now I think we are running out of time, so we'll go on to the next speaker, Dr. Abhilasha Pake. Is she on?
Hello, ma'am. Am I audible?
Yeah, okay. She did her fellowship in pediatric ophthalmology. I'll just do a quick introduction on neuroophthalmology from Narayana Nethralaya, Bangalore. And she was further trained at the Wilmer Eye Institute in Baltimore and Wills Eye Hospital, Philadelphia, USA. And interestingly, you have been trained in ocular genetics also. So she's a key speaker in Vision for Child program, TTRC. I didn't understand what the program was. And she works with Maitri, an NGO in the Melghat tribal area. Where is Melghat tribal area?
So it's in Maharashtra and
Okay.
border. It's we used to work for malnourished kids.
Okay. Oh, that's very interesting. And she, in addition, she loves to draw and paint too. So we'll go on to hear her talk.
Let me share my screen. Hello, everyone. A warm good evening to everyone. Thank you for the opportunity to all my mentors, Dr. Jyoti Matalia. Thanks, TACO, and all the organizers. I hope to do the justice to this topic. So my topic is visual fields and perimetry. I'm Dr. Abhilasha Pake, working at HV Desai Eye Hospital, Pune. So coming to why fields. So as we all know that various forms of visual field assessment is an immensely important in afferent visual pathway assessment. So why fields are important? Because it's being used as a non-invasive marker in early detection of neuro-ophthalmological conditions. It also helps in localization of the lesion and lateralization of the defect. It also, because of its partial effect in both the eyes, it gives a differential diagnosis between two diseases. It helps in monitoring of the diseases like IH, that is idiopathic intracranial hypertension, thyroid eye disease, pituitary adenoma, and also helps in guiding the treatment in remission of such diseases. It helps in revealing hidden vision loss, especially peripheral vision loss go unnoticed and central vision loss patients are very symptomatic. So it helps in peripheral vision loss patients. So before getting into details, let's get to the basics. So what all methods do we have? So we have confrontation method, we have Amsler grid, we can use tangent screen. We all know that kinetic perimetry, that is Goldman perimeter, is a gold standard. Though it is very accurate, it is little time consuming and it needs really trained perimetrist. It is very subjective and customized, so it takes care of if patient is fatigued or patient is drowsy, which doesn't happen in automated perimetry. But because it is time consuming, it is nowadays available at very few centers. Basically, we will be talking today about confrontation and automated perimetry. So in which patients we should do this test? So in all patients, some form of initial assessment of visual field has to happen. And that's why for each patient, we have to do some form of visual field assessment, regardless of their presenting symptoms. Coming to the confrontation test, it's a very simple, flexible bedside test, which offers a fast assessment and gives a gross value, which is very valuable. A variety of stimuli can be applied here. As we can see, 4 visual quadrant has to be assessed. So a lot of examiners use double simultaneous finger assessment in all 4 quadrants, whereas some use wiggling of the fingers. So like this, from periphery to center, we can wiggle the fingers. So those strategies have changed, instrumentation have changed. Basic principle is pretty same. That is, we are checking the detection of sensitivity from periphery to the center, using a small target against a background, plain background. After the periphery, central field also has to be assessed. Same can be repeated with the red object with color perception difference in both the eyes, and it detects quite early hemianopic fields. By using various combining procedures, more than 70% field defects can be identified on confrontation test, that is mere clinical assessment. And this is how we can plot, and this is how we can plot the confrontation test. Before diving further, let's get to some ground rules. There are a couple of ground rules. Excuse me for a second. So always do confrontation first and plot it on the paper. Second, whenever possible, always do fields for both eyes, because even if patient is symptomatic for one eye and we are getting optic neuropathy or any field defects for one eye, other eye is very important to diagnose the disease. Keep both printouts as if you are a patient. So keep right printout in your right. So here we can see it looks like a bitemporal hemianopia, but here right eye is kept at left side, which is wrong. So we have to keep right field on our right side or in our right hand and left field in our left hand. So this is basically binasal hemianopia. Always check reliability indices, because it's been said that machine is automated, perimetry is automated, but the patient is not. So in a dark room, patient can feel drowsy, patient might be fatigued. So we have to check reliability indices. Always look for any rim artifacts or droopy eyelid artifacts. So if there is a field defect, so let's go to the stepwise approach so then we can localize the disease. So this is step 1. First, see, is there a field defect? So we have kept the right field on right side and left field on the left side. So always look for the grayscale, that is area of depression. As neuro-ophthalmologists, we are always keen on grayscale, unlike a glaucoma specialist. But by looking at the grayscale, we can see that right eye has a field defect. So if one or both fields are abnormal, then we can go to the next step. That is whether field defect is unilateral or bilateral. If it is a unilateral field defect, as we can see here, the right eye is showing inferior altitudinal defect, whereas left eye seems pretty normal. Sorry, this field is, I think. So if it is only unilateral field defect, it basically localizes to the anterior to the chiasm, that is retina or optic nerve. And patient needs a detailed optic nerve assessment in such cases. So in our case, we can see that patient has this disc edema. So basically this was a patient of ischemic optic neuropathy, known case of diabetes. This was an inferior altitudinal defect. Coming to step 3, if fields are bilateral, we need to see whether it respects vertical meridian or not. Here we can see the fields are respecting vertical meridian. And if they are respecting vertical meridian, we need to see whether they are affecting same side or same fields. If they are affecting same fields, like in this case, both temporal fields are affected. So this is bitemporal hemianopia, and we all know that this happens because of damage to the bilateral nasal fibers. And bilateral nasal fibers decussate at chiasma. That is why this lesion localizes only to the chiasma. That is bitemporal hemianopia localizes only to the chiasma. Coming to the same fields, if it is binasal hemianopia basically localizes to, could be due to ischemic optic neuropathy, it could be due to glaucoma, drusen's, or large IC aneurysms. We all are aware of this diagram since our medical school days. So this is the optic pathway, and this is the pituitary adenoma as seen in bitemporal hemianopia patients. Coming to the step 4, earlier we have seen same fields, now we are coming to same side. If fields are respecting vertical meridian and same side, we call it as homonymous hemianopia. So this is basically left-sided homonymous hemianopia, which is due to left occipital lobe, right occipital lobe, sorry. If hemianopia is homonymous, we need to see whether it's complete or incomplete. What do you mean by complete? Complete means whole hemianopic field is affected and it doesn't have any further localizing value. So it can be basically optic tract through LGB, through optic radiation or occipital cortex. It could be anything. So it doesn't have any localizing value. Whereas if fields are incomplete, like this, where one eye, we can see that not the whole portion of the hemifield is affected. So these are the incomplete. We need to ask further question whether fields are congruous or incongruous. What do you mean by congruous? Congruous is both the affected fields are mirror images of each other. So here fields are incongruous. That is, one eye is affected more extensively than the other. That is incongruous. And incongruous field defects basically localizes more anterior pathway, that is most likely optical tract or genicular. If it is incomplete and congruous, as we can see here, that both these field defects are pretty mirror images of each other. So it is congruous right homonymous, which is dense inferiorly. And it was basically due to left occipital lobe infarct. So more congruous field defects localizes or points toward more posterior lesion and occipital lobe lesion with or without macular sparing, depends on the which blood vessel is affected, territory is affected, whether it's PCA or MC. We also need to see if there is a quadrantanopia. So in this case, there is a right inferior quadrantanopia, which we call pi on the floor, and it localizes basically contralateral parietal lobe lesions. Sorry, I had to take this image from the Google stock images. So here we can see that right superior quadrantanopia is there. That is pi in the sky, and it correlates with the contralateral temporal lobe lesions. So I've seen a lot of time residents get confused between this, what is pi in the sky and pi in the, on the floor, and they keep repeating this mnemonic. So basically, parietal lobe is up, temporal lobe is inferior, and inferior retinal fibers, inferior goes to inferior, that is temporal, and it affects the superior. That is temporal lobe basically affects the superior field. This is how I remember. So I would like to summarize all these steps, and after that we will see a couple of cases. So to begin with, we need to see, is there a field effect? If yes, if it is, whether it's unilateral or bilateral. If it is unilateral, it is due to retina or optic nerve diseases. If it is bilateral, we need to see whether it respects vertical meridian or not. If not, it is again, it could be retina, optic nerve, or in rare cases, junctional scotoma. If it respects vertical meridian and hemianopia, it comes in two forms, that is heteronymous and homonymous. In heteronymous, it could be bitemporal, which is in chiasmal lesions, or binasal, which could be retina, ischemic optic neuropathy, optic nerve, or glaucomitis. In homonymous, we need to see whether it's complete or incomplete. If it is complete, there is no further localizing value, and we can just say that it is a retrochiasmal lesion. Whether incomplete, we need to see whether it's incongruous or congruous field defects. If it is more congruous, it goes to the posterior, that is occipital cortex, and incongruous, it could be optic tract, sector anopia, whether due to affection of lateral genicular body, and quadrantenopia. If quadrantenopia is inferior, it could be contralateral parietal lobe, and if it is superior, it could be contralateral temporal lobe. After this, I would like to share a couple of cases. So this was an interesting case, 25 years male who had a history of RTA, that is road traffic accident 5 months back, and complaints of diplopia since then. His vision was 6.6 in both eye, other eye was 660. Confrontation test suggested bitemporal hemianopia. So we got on the fields and it was bitemporal hemianopia. His MRI, as we can see here, that CT scan suggestive of extradural hematoma along right frontal convexity and pneumocephalus. So this was basically hemislide phenomenon secondary to bitemporal hemianopia. So this hemislide phenomenon occurs because patient is not able to fuse the fields in the presence of normal retinal correspondence. So this also occurs if patient has a sequential superior altitudinal and inferior altitudinal defect in opposite eye, patient cannot fuse. And so for this patient, we gave prism of 6 bays in front of right eye and 4 bays up in other eye with the reading stereotyposcope. Though he is comfortable, his diplopia is not relieved permanently. Coming to the case 2, the 43 years old male patient complains of blurring of vision since 2 to 3 years, known case of hypertension on treatment. There's a chronic tobacco chewer and alcoholic, and as we can see, both eye temporal pallor can be seen. On examination, vision was 612, and we can see color vision had strong RG defect, that is red-green defect. Confrontation test also suggested central defect. And here we can see both high central defects. So this was basically toxic amblyopia. Coming to the case 3, 50 years old female came with the blurring of vision and progressive weakness of the limbs. So vision was 624, 636, non-improving, ill-sustained pupil, strong red-green defect. Confrontation test suggested was central defect. So we basically advised vitamin B12 levels with the working diagnosis of nutritional optic neuropathy. Patient reviewed with the really low vitamin B levels, as we can see here. Hence, we referred the patient to neurophysician in view of weakness in the limbs and imbalance while walking. So afterwards, as we can see, central scotoma here, afterwards, the patient was diagnosed with the subacute combined degeneration. Coming to the case 4, this was a 29 years old female complains of blurring of vision since past 2 to 3 months. History of tinnitus, headache, weight gain. Vision was 6.6, pupil 1 oris, anterior segment was within normal limit. And as we can see in these fundus photographs, there was a disc edema and patient had this enlarged blind spot in her left eye. A similar case of IIH, that is idiopathic intracranial hypertension, who got diagnosed with and was put on the treatment for past 4 months. Baseline fields were normal. Sorry for this image where it is not well illuminated. On follow-up, repeat visual fields were suggestive of this early nasal step and inferior arcuate defect. And I have put these OCT images also where we can see that in right eye, superior GCC thinning is well correlated with this inferior defect in this patient. So monitoring of the disease and upscaling of the treatment or whether patient should go to surgical intervention or not, fields can immensely be valuable in this decision. So I would like to conclude with a very small story that I saw one lady, the 60-year-old patient, around 5 to 5:30 when hospital was about to close, and very dear friend, a very great clinician, teacher's relative she was, and he brought the patient. She had difficulty of vision while reading. So she visited a couple of opticians and changed her glasses and got done her diabetic dilated evaluation. Everything was normal, but she was not able to read. So, when my teacher was sitting next to me, he's a great ophthalmologist, I did the evaluation and I did confrontation test, which was inferior right quadrantopia. And I plotted the plot on the paper, and I said we should get done the MRI because I think lesion would be here. And we can do formal fields tomorrow and then MRI. So he said, no, I'm very happy with your clinical assessment and we can go ahead with the MRI. And afterwards, she got diagnosed with the left occipital lobe lesion. And the neurologist messaged, what an accurate diagnosis. So why I'm sharing this, I always share this with my students. So these are the clinical perks you need to derive from your busy OPD schedules and throughout a busy long day. These clinical perks always push you to the clinical evaluation, no matter how many tests you have available. So thank you so much for this wonderful opportunity. I hope I did justice to the topic. Thank you.
Thank you, Dr. Abhilasha. So it's very important when the patient comes with a defective vision and you don't see anything, you take a field. So that is the take-home message for the PGs, I think. And you have clearly explained the very even the PGs could understand how the different visual fields can be localized to different areas of the brain. Thank you, Dr. Abhilasha.
Thank you. Thank you so much.
Now go to the next speaker, Dr. Arun.
Good evening. Our next speaker is Dr. Naveen Jayakumar, who is currently the president of Indian Neuroophthalmology Society. And we indeed honored to have you here. Naveen sir is presently the director of Darshan Eye Care Chennai, and is also the Journal of Neuroophthalmology member on the editorial board. And he's also, and as I said previously, he headed the neuroophthalmology services at Shankar Nethalaya for 14 years, from 1991 to 2005. He done his neuroophthalmology training with Dr. Neil Miller, Dr. Alfredo Sadun, and Dr. Joel Glazer, who we all know are legends in the field of neuroophthalmology. And he also is a visiting scholar to the Chinese University of Hong Kong. Over to you, Dr. Naveen Jayakumar.
Thank you very much, sir. And I hope all of you can see my slide.
Yes, sir.
Yeah, great. So thanks to Jyoti for inviting me and KSOS in particular. I have had many fruitful and very meaningful meetings with the KSOS. So my talk today is neuroimaging for ophthalmologists. This is going to be an extremely basic talk. If you do not know anything on neuroimaging, I hope this helps as a start. So I thought I'd start with the opposite question, as normally for neuroimaging, we think of CT and MRI. So my question is, when is CT or MRI not absolutely essential? So take a look at this patient. This patient has a swollen disc. Actually, it was a swollen disc in both eyes. This is the left eye I'm showing you. And you can see there on the high gain of the ultrasound, very hyper echoic spot there on the B scan. And below that, in the yellow arrow, the corresponding high spike on the A scan. But what happens when we lower the strength or the gain of the ultrasound? And here you can see everything else disappears detail-wise, but you can actually see that hyper-echoic spot there still present with a very high spike, indicating that it is calcium, which is very highly reflective of ultrasonic waves. And this turned out to be an optic nerve head drusen, and therefore this patient does not need any further neuroimaging in that sense. Okay. Here are some other cases of proptosis of different varieties. All these are acute patients with proptosis presenting with sometimes with pain, sometimes without much of pain. So in the first one, you can actually see a thickening of the extraocular muscle in the yellow arrow with relative sparing of the tendon in the blue arrow, and this is thyroid ophthalmopathy. The second one is an acute proptosis with some pain, a very bulging out eye, and this worm-like structure that you see there in the ultrasound behind the eyeball is a dilated superior ophthalmic vein, which tells you SOV, it should be not SOF, dilated superior ophthalmic vein in CCF, caroticocavernous fistula. The third one is a painful proptosis with some limitation of extraocular movement. And this is that extraocular muscle in question. And what is interesting is within the substance of the extraocular muscle, you can actually see a very hyperechoic spot, again, calcium. So this happens to be the scolex of a cysticercosis involving the extraocular movements, extraocular muscle. So here are some examples where a simple ultrasound in your clinic will help you to clinch the diagnosis. Of course, you may further go ahead and do a CT or an MRI as the case may be, but to make a diagnosis, quite often ultrasound itself can help you. Coming to structures involving bone and calcium, I think all of you know that the image on the left is your CT and the image on the right is an MRI. How do we know that? Because CT uses X-rays and a bone is a great attenuator of X-rays. So that's what it is. Whereas on an MRI, which totally depends on hydrogen, protons, and water, and you know, bone does not contain much of water at all. So you don't get any signals from calcium-related structures, such as the teeth here that you see in the arrow. Because you don't see much of bone at all, what you can actually see in this MRI is a lot of detail of the base of skull. So for example, this is where, for example, MRI comes in very, very useful when you need to study soft tissue in the presence of a lot of bone. And we'll come to that in a few slides later. Calcium can, of course, be present in the orbit, as you can see here in both eyes in this child with retinoblastoma. And here is another child with a severe proptosis, so much so that you can actually, while you can see the right eye, you actually can't see the left eye because it is pushed outwards so much. And this is the retrobulbar area full of a soft tissue swelling, which is eroded all the walls of the orbit, the roof, the floor, the medial wall, and externally out the lateral wall to the temporal space. And this is a malignancy. This is rhabdomyosarcoma. This picture, of course, looks a little different from the previous ones that you see here. Here you saw a lot of soft tissue. Here in this picture, you can't see much of the soft tissue at all. It's looking very dark and blurred out. The contrast is gone and everything is a kind of dark gray. But what stands out very clearly here is the bone. Okay, and not only just the bone, look at the bone here. It's all white, and look at the bone here. You can actually see the interior structure of the bone. So these are forms of CT which is focused towards evaluating bony lesions. Okay, so these are called bone windows. Let me show you on the opposite orbit. Okay, here you can see the fracture of the medial wall and a fracture of the floor here. You can see the trapdoor of the floor of the orbit broken downwards. Okay, this is a trauma. And the red arrow, of course, shows you the detail of the interior of the bone. In contrast, here you can see a normal CT would show you like this. Now, here in the normal CT, you can see the optic nerve and the 4 recti muscles, but the bone looks a uniform white. So these specialized scans focused on the bone are called bone windows. We won't go into the physics of all that. That's for another day and another talk. Bone can also be imaged in 3 dimensions as 3D CT. Here you can see craniofacial anomalies. Here you can see an asymmetric closure on the right side of the coronal suture. This is a child with Crouzon's disease. This is very useful for surgeons who are craniofacial surgeons for reconstructions, etc. Coming to this very dicey area of the orbital apex, and next to it, the superior orbital fissure, and a little behind them, the cavernous sinus. These are very small structures, okay? And they're quite often surrounded by a lot of bone, and these areas are difficult to image. So here is both on comparison CT and MRI. And what may strike you here on the CT is there's so much bone that you really cannot see the orbital apex very clearly. Okay, and that's because of a phenomenon called volume averaging. If you have a certain volume of tissue, and in that, most of it is bone and a little bit of it is the optic canal where the optic nerve is going through, the CT averages all the attenuations there, and the bone overpowers the soft tissue area, and the whole area looks whitened out. Okay, so that is called volume averaging. It is a disadvantage when we are trying to look at small areas where there's too much bone and too little soft tissue. I told you earlier of the base of skull, where the MRI is far more useful to the CT because there's a lot of bone at the base of skull, which is not imaged on the MRI. So here also you can see on the MR, you can see the optic nerve going all the way back to the optic chiasm, and there's no bone imaged at all. So you can see the entirety of the soft tissue. And this side also, you can start to see the edge of the superior orbital fissure. And going forward, this yellow arrow shows you the lateral wall of the cavernous sinus. And you can even see the inside of it, which is the internal carotid artery. I'd like to draw your attention to this part here on the CT, where you can barely see anything at all. It's all a uniform gray here. Okay. So MRI is definitely more useful than CT when you're imaging small lesions in the superior orbital fissure, the cavernous sinus, and the optic canal. As far as optic neuritis is concerned, MRI is more diagnostic and prognostic. So here you can see one thing that stands out here is the fat on the right side here is quite darkened out. And that is because the signal is suppressed, because normally fat would look very bright on a T2 image. And what you can see very clearly here is a optic nerve, which is looking hyper intense. So this is a patient with optic neuritis. And you can see here with contrast as well, it is all brightened up there, the optic nerve in the mid-orbit, okay, all the way backwards. Also useful is coronal views. In coronal views, you can see here the arrow showing the optic nerve, which is hyper intense, it's enhancing with contrast. You see the corresponding area on the opposite side here, and you can barely see anything at all. This is a normal optic nerve. Okay. We can also, so we saw fat suppression. Okay, those are called stir or spur images. Now we're going to suppress water. Now in this T2 weighted image, you can see the water, the ventricles looking all very bright and barely anything wrong in it at all until you magically switch off the lights on all the water. So it looks dark. And now you can see an MS plaque there when you suppress the signals from the water. Okay. So this is an example of a flare image where fluid is suppressed or fluid attenuation. Okay. These spur and flare images are called inversion recovery sequences to allow a better contrast to see. And this is another flare image. Of course, this is a sagittal view. Over the corpus callosum, you can see all those white patches seen in patients with MS. These are called Dawson's fingers, help you to confirm the diagnosis of multiple sclerosis in a patient with optic neuritis. As far as papilledema is concerned, are we dealing with a tumor or IIH? Always, apart from checking the blood pressure to make sure it's not very high and not, malignant hypertension, please also, when you order an MRI, do an MR venogram also. In IIH specifically, here is a normal transverse sinus, and here you can see in IIH a hypoplastic or sometimes stenosed sinus, dural venous sinuses, which will help you to make the diagnosis of IIH. As far as cranial nerves are concerned, please, this is a patient with pupil involved third nerve palsy with aberrant regeneration and a sixth nerve. And you can see on the left side here, you can see the aneurysm of the internal carotid artery within the cavernous sinus. Here, for reference, is a normal internal carotid artery on the right side. If you do an MR angio, which you should do in every patient with a cranial nerve palsy, you can see that same LICA aneurysm, a giant aneurysm at back. You can also see very fine cranial nerves if you use this kind of imaging called CIS or Fiesta images. They are like super bright T2 images. And within that huge, bright, glowing CSF, you can see these thin structures, which are the cranial nerves. Here it's from the pontine area. You can see the abducens nerve. And you can see here the internal auditory meatus with the seventh nerve going into it. And this is a patient with hemifacial spasm. And you can see an anomalous vascular loop in contact with that seventh nerve. So this is that seventh nerve. And just below that here, you can see that anomalous vascular loop irritating the seventh nerve, producing the hemifacial spasm. So MRI can help you with this kind of diagnosis also. For chiasmal lesions, do you do CT or do you do MRI? So here's a patient on CT. You can see the calcification of this chiasmal lesion, all those white patches on the left image here. In the middle image is the MRI. You can see the axial extension and the posterior extension. And here on a T1 image, you can not only see the superior extension and pre-pontine extension, but it is looking extremely bright on T1. So one of the things which look bright on T1 is, apart from blood and melanin and methemoglobin and contrast, is fat. And fatty, oily appearance inside a chiasmal lesion is usually a craniopharyngioma. Okay, so both CT and MRI can help you in such cases. So in conclusion, I am going to specify here the word primary. Okay, what would you do first? Okay, between CT and MRI. So there are only two issues where I would say maybe you can get away doing a CT, which is an orbit and paranasal sinus disease, and chiasmal lesions. If you have a pituitary adenoma, which is very big, you can see it also on the CT scan. Okay, but as far as MRI is concerned, you can use it for everything with certain specific additions. Okay, so in optic neuritis and in cavernous sinus, orbital apex, and SOF, we can add contrast to it. Okay, in papilledema, we use MR venogram. Nowadays, we do MR venography with contrast also. In cranial nerve palsies, never forget to do an MR angiogram to rule out aneurysms. Okay, and any vascular lesion would also obviously require an MR angiography. One of my neurosurgeon colleagues, when I asked him this about 20, 30 years ago, how do you choose whether to do a CT or an MRI? So he came up with a very short, pithy answer. If you want to study the container, you do a CT. If you want to study the contents, you do an MRI. Thank you very much for your attention.
Thank you very much, Dr. Naveen, and especially that last two statements, that was really, really wonderful. And thank you for giving the very clear short list of what to choose. I think it clears a lot of confusion that we all have.
Thank you, sir.
And also the beautifully illustrated with the special sequences as well. Thank you. Thank you very much.
Thank you.
Thank you. With that, we come to the end of this session and handing over to for the next session. Thank you.
Thank you all.
Thank you. Thank you.
It was a wonderful, great presentation by Dr. Naveen. And we'll move on to the next session, which will be chaired by Dr. Babu Krishnamar and Dr. Bastin. Bastin, can you please take over?
Thank you. Dear Dr. Bastin, moderator of this session, Dr. Sreeni, Scientific Committee Chairman, KSOS, Dr. Roland, President, TAC of faculties and delegates. Happy that we are back to online CME. That was always the only way during COVID years. Advantage of it is we can get faculties from all over India and world outside. That too, you can join from the comfortable of your home. Now we are entering the fourth session of NEUROPHILIA OPHTHALMICA, a CME on neuroophthalmology, jointly organized by TACO and KSOS. We have 5 faculties from across India to update you on management paradigms, what is current. Dr. Neena R. will be talking on optic neuritis. She is the senior consultant and HOD, pediatric ophthalmology, strabismus, and neuro-ophthalmology, Giridhara Institute, Kochi, now. She had her MS and DO from RIO Trivandrum, DNB from National Board of Examinations. She had Sir Ratan Tata Fellowship from Shankara-Nethralaya, Chennai, fellowship training in pediatric ophthalmology and strabismus from Shankara-Nethralaya, Chennai. Worked in Shankara-Nethralaya, Kolkata as an associate consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology. Participated in several CMEs, presented and published papers, organized workshops and webinars at state, national, and international platforms. Winner of many awards at Drishti's, AIUC, SPOSI, AAPOS. She has 20 years of teaching and clinical experience. Welcome, Dr. Neena.
Thank you, sir, for the kind words of introduction. I hope I'm audible and visible. Is my slide visible?
Yes,
yes.
Yeah. So first of all, let me thank Dr. Jyoti Matalia, TACO, and KSOS for this opportunity. And my talk is on optic neuritis, what is current. So there has been dramatic changes in the field of optic neuritis, and the terrain of optic neuritis is constantly transforming, thanks to the revised diagnostic criteria, the discovery of new antibodies, the availability of latest investigations, and the development of new immunosuppressants and monoclonal antibodies. So all this has improved our understanding and prognosis of the disease and the associated systemic conditions. So let us understand the types of optic neuritis before I go on to the management part. Optic neuritis can be simply classified into a typical or demyelinating optic neuritis or an atypical one. The typical one can be further classified into isolated syndrome or the one associated with multiple sclerosis. Atypical can be associated with infections or inflammatory conditions. So infectious causes can be viral, bacterial, and others. And the atypical inflammatory optic neuritis can be any one of these diseases which I have mentioned here. It could be NMOSD, MOGAD, chronic relapsing inflammatory optic neuropathy associated with systemic vasculitis, paraneoplastic, autoimmune optic neuropathy, or recurrent inflammatory optic neuropathy. So when we talk about a typical optic neuritis, what comes to our mind? A patient who comes to you with sudden onset of unilateral vision loss, pain on eye movements, RAPD, and usually a young female in the age group of 20 to 45 years. So the most common presentation is retrobulbar neuritis, and literature says Caucasians are more affected, and it is more seen in higher latitudes with temperate climates. And the most common cause in Western world is demyelination associated with multiple sclerosis. What about the Asian scenario and Indian scenario? So a lot of literature on this, and many studies have shown that there is low prevalence of multiple sclerosis in East Asia, and atypical optic neuritis is more common, with NMO being more prevalent. So the same is the case with Indian scenario, with papillitis being more common, atypical presentations and poorer prognosis are more typical in Indian scenario. So how do we identify an atypical optic neuritis? So anything that is not typical of the optic neuritis, which I described earlier. So first one would be an atypical age. Patient is either too old or too young to be fitted into the typical optic neuritis category. A patient who presents with very poor vision at the outset itself, lack of pain on eye movements, bilateral involvement, presence of severe optic disc edema, extensive hemorrhages, either on the disc, on the retina, presence of macular exudates, associated uveitis, progressive or recurrent disease. So all this would fit into an atypical optic neuritis, and you would be, keeping all these red flags in mind before you investigate the patient. So what is the significance of optic neuritis, and what is the association of optic neuritis with MS? So this is because about 20% of MS patients have optic neuritis as the first episode of demyelination. And 50% of the MS patients will develop optic neuritis during the course of the disease. So to diagnose MS, we have this McDonald's criteria. This was revised in 2017. All the clinical presentations are listed here. But what is surprising is the MRI lesions in the optic nerve in a person who's presenting with optic neuritis have not been so far included in the criteria for diagnosis. So you need to have different lesions to confirm or to be classified as MS. So as Dr. Naveen Jaikumar beautifully explained the MRI findings in optic neuritis, they are very characteristic. So you can see here there is a thickened and hyperintense left optic nerve. Post-contrast enhancement is also seen. This is a flare axial section. So what is characteristic in MS is the presence of these typical ovoid lesions, which are, which can be classically seen in the interventricular, periventricular region or infratentorial region, or sometimes seen even in the juxtacortical and subcortical areas. So these are here, these are called as the Dawson's fingers, and some of them can be also seen in the cortex. So they're usually discrete ovoid and more than 3 millimeter long. But when you come to the spinal cord, the lesions in MS are shorter and they are involving less than 3 vertebrae. So this is a case of MS, which you can see nicely on this MRI. So what image to order is that is already explained. It is a MRI brain and orbits with flare and fat suppressed sequences. Coming to NMO spectrum disease. So what is NMO? Neuromyelitis optica is considered now to be a distinct entity, and it constitutes about 1 to 3% cases of optic neuritis. So what it presents is, it can present either as unilateral or bilateral optic neuritis with simultaneous or sequential transverse myelitis. And NMO spectrum disease is found to be more common in Asians and Africans. The importance is that it has a higher mortality rate, it's more common in females, and occurs in older age group, 30 to 40 years, as compared to the younger population being more involved in MS. And vision loss is often very profound, rapid, with poor prognosis and frequent relapses, and they often have other coexisting autoimmune conditions. So when you have suspecting an NMO spectrum disease, you have to test for aquaporin P for anti-IgG antibody. And if that is positive, you classify it as a seropositive NMO spectrum disease. This is seen in 80% of the patients. But sometimes you have an anti-aquaporin P4 negative disease with clinical features of NMO. You classify it as a seronegative NMO spectrum disease based on your clinical and MRI findings. So here again, you can see this contrast enhanced fat suppressed T1 and T2 images showing the enhancement of the optic nerve. What is more pathognomonic in NMO spectrum disease is the involvement of the chiasma, as you can see in these images. So what happens in NMO spectrum disease? So aquaporin P4 is a water channel which is located at the foot processes of the astrocytes, and it is responsible for the movement of the water across the cell membrane. So when there is an antibody to that, it activates the complement system and leads to damage of the astrocytes and leading to demyelination. So this is the pathogenesis of the disease. Another entity which is distinctively recognized is the MOGAD, or the anti-myelin oligodendrocyte glycoprotein immunoglobulin disease. Now, these MOG antibodies again are directed against the glycoprotein which is located on the oligodendrocyte and myelin sheath, and therefore they can also produce demyelination. So the anti-MOG disease also has some characteristic features. Important is that the age group falls in between MS and NMO spectrum disease. The female to male ratio is almost similar, and 80% may present only with isolated optic neuritis. Bilateral severe profound vision loss, painful vision loss is the presentation. Papillitis is more common in MOG disease. And the important and the good thing is that the visual prognosis is excellent with very good recovery. But the bad thing is that they're more prone for high recurrence rates. And in children, this is supposedly the most common type of optic neuritis seen. So again, you can see here, the MRI has some characteristic features which help you to distinguish from MS and NMO spectrum disease. You can see that there is enhancement of the optic nerve, not just the optic nerve, but also the perineural sheath. So this is very pathognomonic of MOG disease. So this table, which I've taken from this wonderful article by Swati Phuljale and Rohit Saxena, tells you the differences between MS-associated optic neuritis, NMO, and MOG-associated optic neuritis. So other rare conditions like the glial fibrillary acidic protein IgG astrocytopathy, I'm not going into details due to lack of time, but CRYON needs a mention because this is chronic relapsing inflammatory optic neuropathy. Of course, this is the diagnosis of exclusion, but the characteristic thing is it is steroid dependent and has an excellent prognosis, responds very well to steroids, but once you stop the steroids, it comes back again with recurrences. So you need to keep the patient on long-term steroid therapy and eventually shift the patient to an immunosuppressive therapy for longer prophylaxis. We saw during the COVID-19 pandemic, a lot of cases of optic neuritis, even it could be due to vaccination or the infection directly. And the activation of the immune system was responsible for these immune-mediated complications. And patients with MS, they were prone to have possible relapses during that time period. A word about pediatric optic neuritis. Compared to the adult optic neuritis, the incidence is much less, only 0.15 to 0.57 per 100,000 persons per year. But it's more common in older children and non-white children, bilateral in almost 50% cases. Papillitis is a more common presentation as compared to retrobulbar neuritis, which is seen in adults. Orbital pain is not so common. What is more important in pediatric optic neuritis is more than 50% of the children will present with very poor visual acuity at the time of presentation. And as I mentioned already, MOGAD is the most common cause of optic neuritis in children. and will also be responsible for 50% of acute demyelinating events in children. 25% of the children with optic neuritis may be eventually diagnosed with MS, so it's a good idea to keep them on regular follow-up. Okay, so I have given you an overview of the different types of optic neuritis and now how to approach. So an excellent history is very important. A meticulous clinical examination is the next step, and then you do the imaging. And of course, these are ancillary tests which we will do as and when required. So once the diagnosis of optic neuritis is made, you give IV methylprednisolone for 3 to 5 days followed by oral steroids. And if the patient does not make an adequate recovery, definitely you have to go for a neurology consultation and do a CSF analysis along with serological tests for anti-NMO and anti-MOG disease. And if there is recurrence or relapse, you may have to consider if the patient is an MS patient, putting the patient on disease-modifying agents. If it is NMO or MOG, PLEX or IVIG, and for longer prophylaxis, you may have to consider immunosuppressants in NMO or MOG. So I'll come to that in detail. So this flowchart, again from the same article by Swati Puljale and Rohit Saxena, gives you an idea about how you can approach the acute optic neuritis. So what are the investigations which you must do and which you can do? So these are the must investigations in a typical optic neuritis. CSF analysis is optional in typical optic neuritis, but when you have an atypical optic neuritis, along with an MRI orbits, brain and orbits, with spine if you're suspecting an NMO disease, serology is required to differentiate NMO and MOG. And CSF analysis is also important to differentiate infectious causes, sometimes to confirm MS with a CSF OCB study. If you're suspecting a systemic vasculitis, do the relevant investigations. And also infectious causes need to be ruled out with specific serological tests. So otherwise, most of the investigations are only before to rule out just the bare investigations for you to start steroid therapy. MRI brain and orbits with contrast is definitely a must. So our serological tests needed, I already mentioned. Yes, they are required in atypical cases to differentiate the disease, but the type of test and sensitivity is very important. Order a cell-based assay test because that's more sensitive than an ELISA. And the other tests are all depending on the case to case. So CSF analysis, I think I already mentioned this. So most of our understanding of the management of optic neuritis comes from this landmark study called as the Optic Neuritis Treatment Trial, or ONTT. And what it said was that giving IV methylprednisolone fastened the recovery rate, but at the end of at the final outcome or the long-term visual outcome did not change with either placebo or IVMP or oral steroids. So how do we go about treating optic neuritis? So if you have an acute optic neuritis, IV methylprednisolone 500 to 1 gram per day for 3 to 5 days, followed by oral steroids. So if it is an atypical optic neuritis, then the steroids are given for a longer period of time, depending on the cause. If there is no response to steroid, early immune therapy in the form of plasmapheresis or IV immunoglobulins. In case of multiple sclerosis, if the diagnosis is confirmed and there is a recurrence or relapse, you need to offer the patient on some therapy to slow down this relapses or recurrences. So they can be in the form of disease-modifying drugs like beta interferons, immunomodulators like glatiramer acetate, dimethyl fumarate or fingolimod, or monoclonal antibodies like natalizumab. In case of NMO and NMO spectrum disease, immunomodulators are not indicated. They may in fact worsen the disease. And what you need for long-term prophylaxis is immunosuppressants like azathioprine, methotrexate, MMF, rituximab. So some newer therapeutic options like antibody against LINGO and erythropoietin and phenytoin are currently being evaluated. But otherwise, pretty much this sums up the treatment of the optic neuritis. So take-home points, I would say, is that optic neuritis is a clinical diagnosis, but you do need the MRI, which is the most important ancillary test to confirm your diagnosis, rule out the masquerades, and to prognosticate the disease. MRI brain and orbits with contrast, flare and fat suppressed sequences is the imaging modality of choice. And CSF study, serology, MRI spine in atypical cases, VEP, OCT are not mandatory for diagnosis, but they can give you valuable clues regarding the prognosis of the disease as Dr. Shikha Basi already mentioned. And atypical optic neuritis needs treatment in conjunction with a neurologist with ancillary tests like CSS study, antibody assay, and MRI spine. So if we have time, I can show you some cases, or should I stop sharing my screen?
Yeah, Nina, I think we are running short of time.
Thank you very much. I will not share this cases for the lack of time, but thank you once again for the opportunity.
Thank you, Dr. Nina. It was a comprehensive talk on optic neuritis. Well done. Now, next talk is on ischemic optic neuropathy. Dr. Pratibha Panman will be talking on this topic. She is a consultant pediatric ophthalmology, strabismus in pediatric ophthalmology, strabismus and neuro-ophthalmology at Narayana Nethralaya, Bommasandra. She is qualified DO from Padmasri D.Y. Patil Medical College at Mumbai and DNB from KJ Somaya Medical College, Mumbai. FPOSN from Shankara Nethralaya, Bangalore, FICU. She has several publications and presentations at state, national, and international arena. She has work experience of 10 years in her specialty of pediatric ophthalmology, strabismus, neuro-ophthalmology, and visual rehabilitation of children with cortical visual impairment. Welcome, Dr. Pratibha Panman.
Thank you, sir. So I'll be sharing my screen. I hope my screen is visible.
Not yet.
No, not yet.
Not yet. Okay. Is it visible now?
No.
Okay.
You can unshare and please try again.
Yeah, I think I'll do that.
Your presentation is already open, right?
Yeah, it's actually already open. It's not visible?
No.
No, you're not sharing now. Let's keep it open and then share.
And then just close and start once again. So
okay. Is it visible now?
It's only black.
Oh, is it? Because I can.
Yeah. That's a problem with sharing. We'll do one thing. We'll
do the next speaker. Maybe I can come back.
Yeah.
Later.
Yeah. Ankit, you can please help out, and Dr. Swati is there. Goes next, right?
Dr. Bastin.
Yeah, Dr. Swati is there.
Yes, I'm already here.
Yeah. So we have the next talk by Dr. Swati, additional professor from AIMS, New Delhi. She did her MBBS from Pandit Jawaharlal Nehru Memorial Medical College, Raipur, and MD Ophthalmology from AIMS, New Delhi. She has 70 peer-reviewed publications and 25 chapters in various books. Her area of interest are strabismus and neuro-ophthalmology. Today, she is going to talk about traumatic optic neuropathy. Welcome, Dr. Swati, and over to you.
Thank you. Thank you for that introduction. And I would like to thank KSOS and Dr. Sreeni for giving me this opportunity to be here and share this platform with one of the big neuro-ophthalmologists of the country. I will try to be brief as much as I can, although we all know there's nothing much new in traumatic optic neuropathy to speak about. But yes, we all need to know the basics, and still, if anything we can do to save these eyes. Right? I hope my screen is visible and my voice is clear.
Yeah.
Right. So it's a vision-threatening condition that can be caused by ocular or head trauma. We all know that, and the incidence is rising day by day, specifically in close trauma, since the incidence of RTA is increasing day by day. The mechanism of injury includes either it can be a direct injury to the optic nerve or an indirect injury. So direct injuries are the ones which involve the anatomical disruption of the optic nerve itself. So these are the injuries which occur at head, face, and orbit. So the force from the face, head, and orbit is transmitted to the optic canal, which is very closely situated with the sphenoid bone or in the lesser wing of the sphenoid. And then it is transmitted there. So the fracture of the optic canal can cause direct compression of the optic nerve, leading to the direct optic nerve injury. Or it could be secondary to the projectiles like, gun pellet injuries or any other pellet which can directly get into the orbit and lodge at the optic nerve. It can also be associated with the penetrating trauma of the globe, but for that, the trauma has to be severe enough and the penetrating foreign body has to be big enough to injure the optic nerve. There can be direct transaction of the optic nerve in such cases. The indirect injury, where you do not have any anatomical disruption or where you do not have any direct injury to the optic nerve, it is basically a transmitted force to the bony orbit. And because of the tight adherence of the optic nerve dural sheath to the periosteum at the optic canal, the optic nerve becomes fixed at the canal. And as a reason, whenever there is a transmission of a force there is a mechanical shearing of the axons that leads to this irreversible process of neuronal loss. So that's the reason the indirect optic neuropathy is hardly recoverable. So the most common site for the injury is intracanalicular or intracranial. There is a possibility that during the trauma, there is because of the pellet injury or the penetrating injury, there can be hemorrhage because of the perineuronal blood vessels, arteries, or veins, which can rupture during the trauma, and there is an hemorrhage within the sheath of the optic nerve. And this is one condition where when can be intervened can be helpful. Similarly, there can be hemorrhage within the orbital cavity leading to the compression of the optic nerve. So the clinical features include, there will always be a history of blunt trauma either to the forehead, brow, or to the face. But we have to be careful because many a times, it happens that trauma may be not on these mentioned side, but somewhere in inferior orbit or somewhere on the jaw and somewhere on the posterior part of the face and posterior part of the head, and it's still misdiagnosed as a traumatic optic neuropathy. So it has to be very clear that the trauma has to be on the forehead, in and around the brow, so that the force get transmitted to the optic nerve canal. The visual acuity in these patients is severely affected, and many of these patients may have vision as poor as PL negative to begin with. If the visual acuity is better, there will certainly be loss of color and contrast sensitivity. And as with any other optic nerve disorder, there will be presence of relative afferent pupillary defect. I believe this has been covered in the first session of this program. Right. If there is orbital hemorrhage, there will be presence of proptosis along with disc edema. So if you have a traumatic case where there's proptosis and disc edema, please do think of the orbital hemorrhages in these cases, because these are the condition. This is an emergency condition, and intervening in such a condition may really be helpful for patient. If the injury is anterior, for that matter, it will cause optic nerve avulsion, and which appears as a ring of hemorrhage in the retina. Then if the injury is posterior, the fundus may be absolutely normal to begin with, and this pallor will develop usually around 6 weeks. So many a times patient will come to you. By the time the patient comes to us, or being a tertiary care center, already 6 months, 6 weeks to 2 months or 3 months have been passed. So most of the cases that present to us have already developed this pallor. Coming to the investigation. So one important investigation we need to do in cases of traumatic optic neuropathy is to do a high resolution CT scan with the orbit cuts very fine cuts of optic nerve, because we want to rule out if there is any bony fragment there at the level of optic canal, which is compressing directly the optic nerve. Coronal images are better for looking for the fracture as well as optic nerve sheath hemorrhage. MRI of the orbit may be complementary to CT if we want to rule out any, localized edema of optic nerve or optic sheath enhancement of the can be seen as in cases of inflammation. Other investigation which may help in prognosis of the case, or which may, help us to understand how severe the injury is VP, which when less than 50% of the normal eye is critical or is a sign of poor prognosis. Similarly, if the electroretinogram is absent, it is associated with poor potential for visual recovery. So management till date remains controversial. We still don't know what is the best modality to manage these patients. It can vary from observation to the surgical decompression, and people have tried all these kind of modalities to manage a case of traumatic optic neuropathy. So it has been reported that around 25 to 50% of patients will improve on their own in cases of indirect traumatic optic neuropathy. But that depends on what is the baseline vision. So the baseline vision is probably the best indicator of the prognosis. In patients with traumatic optic neuropathy, especially if there is canal fracture and have other orbital fractures, is associated with poor visual recovery and poor prognosis. So multiple studies have been done to understand that what is the best treatment for the cases of traumatic optic neuropathy. The two most prominent studies is National Acute Spinal Cord Injury Study and CRASH trial. So where the mega dose of 30 milligram per kg was given, followed by the 5.4 milligram per kg for next 24 hours. And it showed that a significant improvement was there in visual outcome. However, it should be noted that, the steroids have to be given very early in the day, so within 72 hours, and best results were seen within 6 hours. But most of the time, rarely there is an equation where patient will present to you within this period. So by the time, patient presents to us, this golden period is already lost. The next trial is called CRASH trial, where again the mega dose of roll-off steroid was evaluated within the 48 hours of injury. But then it showed that, in cases of traumatic brain injury along with the optic nerve injury, these giving mega dose of steroids may actually be detrimental and may lead to mortality in some of the patients. So there was another study which tried to look at the role of decompression in cases of traumatic optic neuropathy. So they divided patient into 3 groups: the observation group, high dose steroids group given within 7 days of injury, and optic canal decompression done within 7 days of injuries. So at the end, they concluded that it's neither the timing nor the type of the treatment that can affect the outcome. Still, there are certain conditions where the treatment may help patient and has an important role, like orbital hemorrhage, where there is constant compression of the optic nerve, and it can be easily relieved by lateral canthotomy and cantholysis. So this is one condition where we actually can save the patient's vision. Similarly, retrobulbar hemorrhages, if drained on time, may help in saving the vision of patient. In cases of patients where there is impacted impacted bony fragment, which is directly impinging of the optic nerve, probably doing a decompression of the canal will help. However, studies have shown that that has to be done within a specific period of time, say within 72 hours, but still the results are not very convincing. Sometimes intra-sheath blood, if very sure, if convincingly demonstrated, in these cases, probably optic nerve sheath fenestration may be helpful in relieving the optic nerve compression. Thank you for the patient listening, and thank you for the opportunity.
Thank you, Dr. Swati, for that excellent presentation. And we'll go to the next talk. And shall we go to Dr. Jaspreet or to the previous speaker? Sreeni?
I will go to Dr. Jaspreet then.
Okay. So the next talk is by Dr. Jaspreet, professor from PJ Chandigarh. Dr. Jaspreet was trained at Great Ormond Street Hospital, Moorfield Eye Hospital, King's College Hospital, London. He is also the president of Chandigarh Ophthalmological Society and joint secretary of North Zone Ophthalmological Society. He has more than 120 publications in peer-reviewed journals and have also contributed chapters in various books. He is the associate editor of Acta Ophthalmologica, and he has various honors like All India AOS International Heroes Award in 2021, runner-up at annual conference of British Pediatric Ophthalmology and Strabismus Society, DOS International Star Award in 2021, Orbis International Gold Medal at ESCRS, and also Best Video at ESCRS, Om Prakash Award in Pediatric Ophthalmology by AIOS in 2020, Dr. Prem Chandra Award by North Zone Ophthalmological Society, Professor Anumanda Reddy Award and Gold Medal by IRSI. He is an invited speaker at various international and national pediatric ophthalmology and strabismus conferences, and he's the reviewer for many of the international and national journals, and then evaluated for various papers and theses and videos at AIOS. So today, Dr. Jaspreet will be talking about ethambutol-induced optic neuropathy. So over to you, Dr. Jaspreet.
Very good evening. And am I audible and are my slides being seen?
Yes.
Yes, you are audible. Your slides are also seen.
Thank you very much, KSOS and Dr. Jyoti, Dr. Sreeni, for inviting me in this wonderful neuro-opthal series of webinars. I won't take much time. There is what is going on in ethambutol is been there for ages. I mean, nothing you can say substantial new has been added to it, but it's a very important aspect considering the Indian scenario. So I would be talking something about ethambutol-induced optic neuropathy. And one second. Yeah, so just a few slides about what it is. Ethambutol, it's routinely being used in so many tuberculosis cases in India. It's a bacteriostatic agent, and because almost you can say 2 million people in India are affected by tuberculosis and are on ethambutol, the prevalence still is much less. It's just 1 to 2% how it affects the optic nerve. And the important thing is it's dose dependent. So if you have a patient with less than 15 milligram or 15 milligram per kg, the chances are much less of developing a neuropathy. Whereas as the dose increases to 35, the incidence also increases to 18 to 33%. So it's a dose dependent. It's not a cumulative dose. It's a daily dose dependent optic neuropathy, what we see with ethambutol. However, there is no true safe because even less than 15 milligram develop an optic neuropathy. And is because of the idiosyncratic reactions sometimes when you see in maybe 2 to 3 weeks, which a person develops when on ethambutol. And to add to this, if the patient has a nephropathy or an advancing age, is hypertensive or a diabetes, probably more are the chances that he is going to be at a higher risk for developing ethambutol-induced optic neuropathy. So how it acts, basically ethambutol acts on both the bacilli, whether the intracellular or extracellular. Of course, rapidly proliferating bacilli are affected and inhibits the enzyme coded by the MB gene in the cell wall of the mycobacteria, and that's how it acts on the mycobacteria. So what really happens in the optic nerve? So it's basically what happens, it's a metal chelator. So it chelates both the zinc and the copper. Now, if you see here, what's happening is it's affecting the mitochondria and it would affect the myelin also. So in the initial part of the RGCs, probably when within the eye, they don't have myelin, but as they cross the lamina fibrosa, they become myelinated. So chelation of zinc can cause disruption of myelin, which is here, and chelation of copper disrupt oxidative phosphorylation and mitochondrial function, which is this part. And with this, there's a release of reactive oxygen species. The ROS is released, which leads to cell death, which is the apoptosis, what we call. And because these mitochondria are congregated in the papillomacular bundle, you have a temporal pallor, because it is that bundle which is affected because of, you can say, a small caliber of the nerve fibers, a high surface area to volume ratio, and you have more mitochondria there. And this is insufficiency of mitochondria, which leads to a toxic optic neuropathy later on. However, remember, we don't see all the patients with toxic optic neuropathy going into loss of vision. It's a reversible. So because remember the pathogenesis, there is a sick phase during this apoptosis. It's a window of reversibility. Mitochondrial impairment does not cause axons to die immediately. There is some recovery which takes place, and those who recover, those who are caught early, would benefit from this. So the current recommended regimen in worldwide is, if the patient hasn't received an ATT, it's 15 milligram per kg per day. But those who have received ATT or who have like the avian mycobacterium, avian infections in the Western countries, like they would give it for 25 milligram per kg per day for the intensive phase, and then followed by 15 milligram per kg per day. Remember, the excretion is by the renal route. So anybody with a nephropathy, one has to be very careful when advising this drug. The ocular symptoms, which we are bothered about, develop within 3 to 12 months after initiation of ethambutol. That's the most common time when they develop. Now, coming to India, we have the revised National TB Control Program guidelines. Now, what they have done is, earlier what did we have? We had an intermittent regime. Now we have to give it daily. Earlier, ethambutol was just part of the intensive, that is the first 2 months of the therapy. Now it's all gone into the continuation phase. Fixed dose combination as per weight band. Earlier, there was no fixed dose combination. So with this fixed dose combination comes the loss of flexibility when we have to stop the drug. It's because if you see in the intensive phase, at the first 2 months, you have ethambutol, which is 275 milligram. Although it is all weight banded, so that does help in decreasing toxicity. But what really happens is, we don't have flexibility to just stop this drug. We would have to just stop all the medicines which are there in one tablet. And in the continuation phase, it's again 275 milligram. What decreases is the pyrazinamide, which is decreased, which is 150 milligram. The rifampicin decreases is the same 150. You can say the INH is also 75. Even the ethambutol is 275. So it goes on for 6 months. So that is the problem now, that the patient is going to take this fixed dose combination for 6 months. Earlier, there was flexibility to just stop it. And of course, this is come out in a beautiful article by Rohit Saxena, the expert consensus guideline on primary prevention in people who are taking ethambutol. So what are the clinical features? Basically, what is the main thing? What happens is, you have a subacute bilateral painless symmetrical loss of vision. So it's an insidious onset. The patient really doesn't come to know about it. And the visual symptom would start about 2 to 8 months after initiation of therapy. So it can be early as 2 months and even as late as 8 months also. And then there is dyschromatopsia, that's loss of color vision, which is one of the earliest features of ethambutol optic neuropathy. When the patient comes to you, when you do a visual field testing, it could be, we have a central scotoma, which is quite common. So if you have central fibers which are affected, it will lead to a central scotoma. But if you have peripheral fibers being affected, if you have a chiasmitis, you can have a bitemporal defects or a peripheral field constriction. Because it's a bilateral symmetrical loss of vision, the pupillary abnormalities are very subtle unless there is an asymmetric involvement. Fundus usually is normal, but in the acute stages, because I told you, there's a lot of mitochondrial swelling. The disc could appear swollen. There could be some hemorrhages. It could be hyperemia in the early stages. And yes, temporal pallor does develop later on if it's not controlled early. Well, we have new tools for it. The OCT, it quantifies the loss of retinal nerve fiber layer as a sign of early toxicity. So the ganglion cell would be the one which is to go early, followed by the RNFL. And this OCT and visual field can be used to monitor these patients. VEP, yes, abnormalities in the amplitude and latency are detected where you have a doubt when you want to differentiate this condition from optic neuritis. So the risk factors for this are increasing age. The older the person, the higher the risk of toxicity. Prolonged duration, if you're giving, not really, but yes, some studies have shown. What is important is higher dose. So the daily dose of ethambutol is one of the most important factors guiding this toxicity. Other risk factors like hypertension, because it's treated by the kidney, so poor renal function, diabetes affecting the kidney, and of course, if you have amblyopia because of other factors like tobacco, alcohol, concurrent optic neuritis, or Leber's hereditary optic neuritis, all these are risk factors for poor visual recovery. So what baseline tests we have to do once the patient presents to you? Everything has to be tested for optic neuropathy. So what are the indicators for optic neuropathy? Visual acuity, the most important. Snell's visual acuity is very important. Check for pupillary reactions. Check color vision. You have a blue-yellow defect or a red-green defect. That's very important. Contrast sensitivity decreases when you have optic neuropathy. Fundus examination is very important. You might have a normal looking fundus, or you might have some other features which might mimic other conditions. Then ancillary test, OCT, if you have one, is a very good tool as a baseline. So baseline OCT is very important because you might have a loss earlier, or you might have some other pathology there, which if you don't do and do it on when the patient comes to you, might give you a false picture. So OCT is very important as a baseline and also for monitoring the progression. Visual field examination, as I told you, is for a central scotoma, and on follow-up, one can do a visual field examination to know how the improvement in the visual field. For home testing, one can give an Amsler grid for early detection. Ask the patient to look at the grid. A red grid is the most sensitive. So all high-risk patients, remember, examine every monthly. Patients who are asymptomatic can be monitored at 3 and 6 months, but they have to have a baseline examination before starting ethambutol. So what are the biomarkers for subclinical toxicity? Now, clinical is when the patient has decreased vision. So he's already come to you with decreased vision. But what can you do before that? Can you do something? Yes, OCT, as Dr. Shikha has very nicely discussed, the temporal RNFL change initially will be increased. As I told you, what happens in the initial phase, there is mitochondrial swelling, there is mitochondrial aggregation in the axon, which causes an increase in the RNFL. It will be followed by a decrease if there is a loss of retinal nerve fiber layer, along with a ganglion cell loss. A VP, when you're in doubt, shows a delayed latency as well as an amplitude, and contrast is also decreased early. So contrast sensitivity is one of the important indicators of an optic neuropathy. So what treatment? There is nothing which has been done over these years. The one and only thing is stop ethambutols. Vitamin supplements may be given because it is known that you have deficiencies of vitamin B and vitamin E. So can be given concurrently. What you have to do is watch for 6 weeks for improvement. If there is still deterioration, we would have to stop the INH because that's also known to cause optic neuropathy. And remember, the recovery is variable in this. It's not that every patient is going to improve and when he will improve. So lesser the visual acuity at presentation, lower are the chances of a good recovery. More the neuropathy, again, lower are the chances of a good visual gain. So the picture at presentation really would help you prognosticate and counsel the patient. Remember, deterioration can progress over a month after stopping. So 6 weeks is a fairly good time. However, it has been shown that recovery can take up to 3 years. Mostly it happens within 1 to 6 months, but it's seen that up to 3 years recovery can occur. And remember, if detected early, about 30 to 60% show some recovery with an average of 2-line improvement. So that's the importance of catching them early. The take-home message here is that it's a dose dependent. The toxicity of ethambutol is dose dependent. Remember, there is no safe dose. The high risk factors which one has to take into account while prescribing, because what happens in tuberculosis with time, there is some weight loss. So initially you might start the dose, but then there is a weight loss because of tuberculosis, and then the ethambutol has to be titrated. Early detection and baseline screening are the key to prevent deterioration because the recovery is dependent on early detection. Subclinical toxicity, you have OCT, you have contrast. One can, it's a helpful tool, but remember, everything has to be taken into account. The visual acuity has to be taken in, the pupillary reaction, and the visual field has to be taken into account when if you want to stop, because it's not just OCT which is going to guide whether you want to stop the drug or not. That's why I say its validity and the reproducibility needs to be studied in more detail. Monthly screening for high risk and 3 months for asymptomatic patients. Amsler grid, very important for home monitoring, for early detection. And the only treatment available for this at the moment is stop the offending drug. And recovery is variable. If detected early, chances of recovery are much better. Thank you all for a patient hearing at this time.
Thank you, Dr. Jaspreet, for that. Dr. Sreeni, anything to be asked?
Yeah. Dr. Jaspreet, how many patients have you seen in your experience who have actually recovered at least 2-3 lines post-stopping ethambutol? And see, we were seeing quite a few number of ethambutol-induced loss of vision. Now, probably because the pulmonologists are aware and they're making sure that the screening is being done. Recently, it's come down a little bit, but still, has there been any discussion on the need to monitor and the need to decrease the dosage to prevent the blindness in these cases? And see, when we talk to them, they said, "Wait, the patient is not alive. What's the point in the patient having vision?" Because it's sort of a catch-22 situation. So, your comments on this?
Yeah. So, thank you for that question. It's very important. The risk-benefit ratio is very important. I have seen close to maybe now 100 patients or maybe a little more who are on ethambutol. But what we found out from our audit is that most of them recover vision. Now, that recovery of vision is like about 60% did recover about 2 lines, where the rest were like maybe just from hand movement to maybe a little counting fingers, or there were some who did not recover vision. So those are the ones probably who presented with optic pallor or who had some other risk factors. But it's very important to know that, as you're saying, that the pulmonologists are now aware. So we do get patients for screening, but that baseline screening is still not being done. They are put on ethambutol and then they are sent to us. So for those patients, basically, it's very important because we don't know the patient. When we do all our investigation, we find something, we are unable to comment whether it was present before that or whether it's present is because of ethambutol. So this is one very important thing. Now, coming to the dose, I think there is no safe dose, as I told you. So anybody can get. No doubt the toxicity increases with the increasing dose. So if you do a proper baseline evaluation and the person with risk factors are screened early, I think we'll be able to pick up and prevent the occurrence of a severe neuropathy.
Yeah, I understand that any dose it can happen, but this we are seeing it after the new regimen has started. So, dose definitely it should be playing a role.
Yeah, it should. I mean, this fixed dose combination now going on for 6 months. I mean, it's something which even the expert panel is looking at. The INOS is, trying to see how things can be modified in this, because it was really a concern, and probably it has Rohit Saxena and all. The information and has been given to the government of India about all these things, that the health ministry, that what is happening with these, and we need to do something because of the lack of flexibility, that we are unable to stop just ethambutol, but you'll have to stop each and everything, and then there would be a flare up of the other thing. So it's a kind of solution is still to be worked out.
Yeah. I've spoken to Rohit about it. He said he has raised it and he's following it up, but sort of nothing is happening. Yeah,
we still have to work out.
Bastian, anymore?
Yeah, no, I think what is more important,
we have to do something.
The pulmonologist and the treating physician about the toxicity, and to make more patients for screening, like we are doing screening for the diabetic retinopathy endo. Yeah, thank you, Dr. Jaspreet. Any more questions? So we move on to the next talk. Next talk is by Dr. Remya, our own member from Cooperative Hospital, Payyanur. She did her MS Ophthalmology from Bangalore Medical College and Research Institute, fellowship in Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology from Narayana Nephalaya, Bangalore. She received her FACO in Pediatric Ophthalmology, and she has presented various papers in the national and state conferences. So welcome, Dr. Remya, and today she's going to talk about acute ophthalmoplegia. So over to you, Dr. Remya.
Am I audible and is my slide visible?
Yeah.
Yes, Ramya.
Okay. Thank you, sir, for the kind introduction. And first of all, let me thank KSOS, TACO, and Dr. Jyoti Matalia, my mentor, for giving me this opportunity. So I will straight away go to my topic, that is acute ophthalmoplegia. So in a case of acute ophthalmoplegia, first of all, we should know, is there a lesion at all? If it is yes, then we should know where is the lesion and what is the lesion. So in this talk, I am going to tell about that. So ophthalmoplegia could be external or internal. External ophthalmoplegia is due to the paralysis of the 6 muscles that hold the eye in place and control its movements. And internal is due to the paralysis of the intrinsic muscles that helps in focusing and accommodation. That can lead to loss of accommodation and dilated and fixed pupil. So the symptoms could be diplopia, drooping of eyelid, difficulty in tracking objects, etc. And these are the associated signs that you should look for in each and every case, so that you can get an accurate diagnosis. The cases could be at the supranuclear level to the muscle level, and I will be dividing it into 3 parts. First is supranuclear and internuclear, then nuclear and infranuclear, then neuromuscular junction and muscle disorders. So this is first supranuclear and internuclear lesions. Just observe this his eye movements. When he is looking to the left side, the left gaze is looking normal. But carefully observe when he is looking to the right side. The left eye is not adducting properly, and you can see the right eye has an abducting nystagmus. So this is a case of internuclear ophthalmoplegia. So we'll just brush up the anatomy. The pathway is similar for both saccades as well as pursuits. And the only difference is the saccade is initiated by the contralateral frontal eye field and pursued by the ipsilateral parieto-occipital temporal region. From the horizontal gaze center is the pontine paramedian reticular formation. From here, the neurons reach the ipsilateral lateral rectus, and via the MLF, it goes to the opposite side medial rectus and initiate the gazes to the same side. So it's both equal, it's same for saccades as well as pursuits. So in case of internuclear ophthalmoplegia, your MLF is getting affected. So your adduction will be absent. On abduction, other eye abduction will be, there is nystagmus. Here, the importance is the convergence will be present. It could be due to any lesion like hemorrhage, infarct, or demyelination. See this case, it's not very evident. You can see the eye is means bilaterally the eye looks abducted. It has a wall-eyed appearance. And when he is looking to the right side, the right eye is not, right side, left eye is not adducting, and on the other side, other eye is not adducting. Both eye abduction is present. So this is a bilateral INO or Weber syndrome. So in a horizontal gaze palsy, you can get only PPRF lesion that leads to ipsilateral horizontal gaze palsy. Only MLF, internuclear ophthalmoplegia. If your PPRF and MLF gets affected, it leads to 1.5 syndrome. Only the abduction will be present in the other eye. Similar things can happen with the vertical gaze pathway also. The vertical gaze center is located at the thalamo-mesencephalic junction, just rostral to the superior colliculus. It is a group of nuclei. The major one is the rostral interstitial nucleus of medial longitudinal fasciculus. From there, the fibers goes to the nuclei at the level of the superior and inferior colliculus. That is our 3rd and 4th nerve nucleus after decussating at the level of the posterior commissure. So the
Dr. Devnya, you are not audible and visible also.
She has probably lost the connection.
Yeah, I think she lost the connection, I think. Try to contact her. Meanwhile, we have one more talk is pending now, Dr. Pratibha.
Dr. Pratibha, I think.
I'm here. Can I please screen?
Yeah, but Ramya has to stop sharing.
Yes. Okay. So I'll just try to contact her once again.
Yeah.
Pratibha has come.
Yeah, Pratibha has come.
But
I think Dr.
Can I share the screen?
It's not visible.
Connection is lost. I think. Let Pratibha continue, start.
Yeah, yes. Dr. Pratibha, can you share your screen? Yes. Now
My
it's
screen visible?
Yeah.
Yes,
visible.
yes.
Yeah.
Okay.
Visible, audible, everything okay.
Yeah, good evening. So I would like to thank KSOS and Taco and Dr. Jyoti for giving me this opportunity. So I'll be presenting on ischemic optic neuropathy. So let's begin with a case. This was a 59-year-old male patient who came with blurring of vision on waking up in the morning in the right eye since a week. He was a known hypertensive since 10 years, recently diagnosed with diabetes. His vision was 612 N8 in the right eye and 68 N6 in the left eye. He had right RAPD. Color and contrast was reduced in the right eye. So this is how his disc looked like. There was disc edema in the right eye, and the left eye, you can see that the CD ratio is very small and it is crowded. So this, we know that we are looking at a case of an ischemic optic neuropathy. So ischemic optic neuropathy can be classified into anterior and posterior based upon the location of the lesion. It can be further classified into non-arthritic and arthritic based upon the pathophysiology. And non-arthritic is the most commonest. So let's look at the blood supply of the optic nerve here. So optic nerve can be divided into the optic nerve head, orbital part, canalicular, and the cranial part. So the intraocular part of the optic nerve is where, which is the most commonest reason for anterior ischemic optic neuropathy because of its tenuous blood supply. It is majorly supplied by the posterior ciliary artery, which supplies the prelaminar region, and the circle of Zinn and Haller, which supplies the lamina cribrosa region. So NEIN can occur because of the transient non-perfusion or hyperperfusion of the optic nerve head circulation, and rarely because of embolism to the arteries or the arterioles, like you can see in the picture here, and the corresponding choroidal hyperperfusion on FFA. So there are several risk factors and no age is immune. However, we commonly see in patients more than 50 years of age. Disc at risk is another structural risk factor which we should be looking at. Disc drusen can also cause NEIN by compression of the blood vessels on the disc surface. Systemic risk factors like hypertension, diabetes, nocturnal arterial hypotension, hyperlipidemia, sleep apnea should be considered. Hyperhomocystinemia, coagulopathies, and prothrombotic factors should be considered in patients, in young patients with NEIN. Again, 1 second. My slides are not moving. Am I audible?
Yes, you are. You are audible.
Yes, audible.
Yeah, but I'm not able to move my slide. That's a problem.
You're presenting from the
Yeah. Now I got it, yeah. Look for history of medications like sildenafil, interferons alpha, and amiodarone. So after COVID-19, it has also been implicated as a possible cause of NEIN because of its hypercoagulable and hyperinflammatory state, which causes microangiopathic and thrombotic events. Again, there have been case reports post-COVID-19 vaccination of NEIN. However, whether this is just an association or just a coincidence is something which is doubtful. But as an ophthalmologist, one should be aware of this association and elicit a detailed history. So coming to the treatment, oral prednisolone has been tried. However, studies done by Rohit Saxena et al. And this meta-analysis have shown that there is not much improvement in the visual acuity post oral prednisolone. Again, aspirin has been used by ophthalmologists and neurologists in the treatment of NEIN. However, study done by Here et al. And IONDT have shown that there is not much visual benefit of this. Intravitreal triamcinolone, bevacizumab, and ethropoietin have also been tried. However, there's sparse data. IO and DT have also assessed the safety and efficacy of optic nerve head decompression. However, it was not ineffective, but rather has proven to be harmful. So we know that there is no known treatment for NEION, and steroid can be given if you're looking at an incipient NEION. Management should be directed at evaluation and treatment of the underlying vasculopathic risk factor. Potent antihypertensive should be avoided at bedtime. Rule out OSA wherever indicated. All patients should be asked for, especially in men, rule out history of use of drugs for erectile dysfunction. So coming back to our case 1, so we noted that there on visual fields, there was an inferior altitudinal defect in the left eye. So this was more like a left inferior quadrantenopia, and hence it required a thorough evaluation. So when patient was evaluated, we noted that there was a deranged blood sugar and lipid profile, and his MRI imaging revealed right occipital lobe infarct. Coming to case 2, this was a 65-year-old male patient who came with sudden onset blurring of vision in the right eye since 3 to 4 days. He had a similar event in the left eye 5 years back, and his vision was 624 N12 in both the eyes. He had right RAPD, color and contrast was reduced in the right eye. So his disc showed swollen hyperemic optic disc with flame-shaped peripapillary retinal hemorrhage, and there was disc pallor in the left eye. So on visual field assessment, you can see that there is an inferior altitudinal defect in the right eye and a centrocecal scotoma in the left eye. So this was a case of a right NEION and the left disc pallor status was NEION. He was evaluated, and we noticed that there was raised BP along with deranged triglycerides. However, on carotid Doppler, it revealed 50% luminal stenosis in the proximal ICA, and hence this patient also had to be evaluated by a cardiologist. Incidentally, this patient was diagnosed to have high degree blockages and had to undergo CABG. So by sharing these 2 cases, I just wanted to emphasize that even if there are no clinical data which say that NEION, even if there is no clinical data which says that NEION poses any risk to subsequent myocardial infarction or cerebral infarction, but most of the NEION patient will at least have one possible vascular risk factor, and hence there is a need to possibly think about systemic vascular risk factors in such patients. So coming to the prognosis, in the affected eye, vision tends to worsen over 2 weeks, may remain stable thereafter. Visual acuity does not appear to worsen once the disc edema has resolved. And recurrence is seen in less than 5% of the cases as per the IONDT trial. Involvement of the other eye can be seen in 50% of the patient within 5 years, and it is more commonly seen in younger patients. Bilateral NEION is more common in men and in young patients with diabetes. So this was a 72-year-old male patient who came with sudden loss of vision in the left eye since 2 days. He had history of headache preceding the vision loss, known diabetic since 2 years. His vision was hand movement close to face in the left eye, had tenderness over the left temporal area. There was left RAPD. This is how his disc appeared. So the patient had pallid disc edema in the left eye. So this was a case of arthritic AION. His CRP was raised, and in view of suspected GCA, he was started on high-dose steroids and underwent temporal artery biopsy, which revealed granulomatous inflammation and giant cells. So GCA is a systemic vasculitis. It involves a medium size and large arteries. It has a special predilection to involve the PCA. Other causes of arthritic would be polyarthritis nodosa, SLE, and herpes zoster. It commonly occurs in late middle age and elderly people, and females are more commonly affected. You can see symptoms like amaurosis fugax, diplopia, variable vision loss, and RAPD. Systemic symptoms like headache, scalp tenderness, jaw claudication, malaise, anemia should be looked into. So typically in arthritic, we see a chalky white pallor with disc edema, and post-resolution, you'll see cupping. You may also see associated cotton wool spots, central retinal artery or cilioretinal artery occlusion, choroidal ischemia. FFA will reveal PCA occlusion, and temporal artery biopsy is diagnostic. So such patients should receive high dose of systemic steroids until ESR and CRP is stabilized. Coming to posterior ischemic optic neuropathy, this is ischemia of the posterior portion of the optic nerve. It's a clinical diagnosis of exclusion, characterized by acute painless loss of vision in one or both eyes. Vision loss is typically over hours, may worsen over days to weeks. RAPD will be seen in unilateral and bilateral asymmetric cases. Normal fundus pallor sets in after 6 to 8 weeks and commonly seen in vasculopathic age range. So again, it can be divided into arthritic, non-arthritic, and perioperative, which is commonly seen after cardiac and spinal surgery. The risk factors for perioperative would be postoperative facial edema, prolonged intraoperative arterial hypertension, postoperative anemia, and raised intraocular pressure. The diagnosis of PION remains challenging. MRI with diffusion-weighted imaging would reveal hyperintensity in the infarcted intraorbital optic nerve. VEP, although non-specific, can still help in distinguishing from retrobulbar optic neuritis. In retrobulbar optic neuritis, you may see increase in the latency, whereas in PION, you may see reduction in the amplitude. The changes in PION are permanent and irreversible as compared to optic neuritis. Coming to the treatment part, arthritic, you will need to start on IV steroids. Non-arthritic and perioperative, there is no established treatment. So only prevention can help. So opting for a minimally invasive spine surgery, staging of complex procedures, improved anesthesia, maintaining blood pressure and hematocrit, avoiding long surgeries, and early correction of hemodynamic abnormalities could be useful in such patients. Thank you.
Thank you, Dr. Pratibha. Any questions?
Ramya, ready? Ramya?
Yeah, ma'am, can you please unshare your screen?
Sure.
Is it visible, sir?
No, your screen is not.
Seen, no?
No, not seen.
Not seen, huh? Okay.
Then you can close and just reopen.
Okay.
Yeah.
Okay.
Yes.
Okay. I will be starting from the place where I ended. Sorry that for the that is due to some internet connection problem. So I think I have INO was done. So here in this video you can see when the patient is looking to the right side, the left eye is not adducting, and when he is moving to the left side, the right eye is not adducting. In bilateral, then there is bilaterally abduction nystagmus. So this is the bilateral Webeno or bilateral INO or a Webeno syndrome. So if you have only PPRF affected, it can lead to an ipsilateral horizontal gaze palsy. Only MLF, it leads to internuclear ophthalmoplegia, and PPRF plus ILF, MLF lesion leads to 1.5 syndrome. So like this, you can also get a vertical gaze involvement. So the vertical gaze center is lying at the thalamo-mesencephalic junction, just rostral to the superior colliculus. It is a group of nuclei. The main one is the rostral interstitial nucleus of medial longitudinal fasciculus. From there, the fibers goes to the nuclei at the level of the third superior and inferior colliculus. That is our third and fourth nerve nucleus. And the nucleus after decussating at the level of the posterior commissure. So if you have a vertical gaze center involvement, that is known as Parinode syndrome or the dorsal midbrain syndrome. So it can have supranuclear upgaze palsy, convergence retraction nystagmus, light near dissociation, and lid retraction, the components. Why there is supranuclear palsy? Because the vertical gaze center is involved. Since the down gaze is usually bilateral, only a very large lesion can involve a down gaze palsy, produce a down gaze palsy. And here the inhibitory neurons are affected. So that leads to superior rectus and inferior rectus co-contraction. That leads to retraction and convergence retraction nystagmus. Convergence, why? Because your medial rectus is overacted than the lateral rectus, that leads to convergence on upgaze. And light near dissociation, here why light reflex will be absent, near reflex will be present, because near reflex fibers are situated more ventrally compared to the light reflex fibers. And there will be lid retraction, that is due to the inhibitory neurons, the LPS inhibitory neurons are getting affected. So that leads to a bilateral lid retraction. So this is the axial T2 weighted image at the level of the midbrain, where this blue circle shows the area involved in Parinaud syndrome. So coming to the nuclear and infranuclear level, so I'll be mainly going through the 3, 4, and 6 nerves that causes ophthalmoplegia. So look at this patient, 55-year-old male, presented with a double vision and drooping of lid. You can see the right eye is ptotic and it is exotropic, and there is a hypotropia. And all the eye movements like elevation, depression, and adduction are involved. Only abduction is present. So this is the case of third nerve palsy. So in a case of third nerve palsy, you should know is the pupil is spared. Is it a complete third nerve palsy aside from pupil sparing, and is it isolated? Depending upon that we should send the patient for a neurological investigations, including MRI or CTA. So I'll just brush up the anatomy, because it's very important to know the anatomy. Only then you can localize the lesion. So third nerve nucleus is present at the midbrain. The fascicular portion is just adjacent to structures like a red nucleus, cerebral peduncles. Then it enters the subarachnoid space, where it is associated with the major blood vessels like a posterior communicating artery, posterior cerebral artery, and internal carotid artery. Then enters the cavernous sinus, where it is associated with the other cranial nerves. And then enters the superior orbital fissure, where it divides into two. The superior part supplying the superior rectus and LPS, and the inferior part supplying the other muscles. And via the ciliary ganglion, it supplies the sphincter pupillae. The third nerve nucleus is important because it is like a nuclear complex. You have a central caudate nucleus which supplies bilateral LPS muscle, and your superior rectus nucleus supplies the contralateral superior rectus. So in case of a nuclear third nerve palsy, you will get a complete third nerve palsy along with bilateral ptosis and a contralateral superior rectus weakness. And fascicular, depending upon which part of the brainstem is involved, you can have different syndromes like Benedict's Weber's, Northern Angels, etc. And another important area where you get an isolated third nerve palsy is the subarachnoid space. The most important one is the PCOM aneurysm, that is posterior communicating artery aneurysm, and other causes like meningitis, demyelination can also occur. Cavernous sinus, usually we get a multiple cranial nerve palsy, and the causes could be inflammation like a Tolosa-Hunt syndrome or a CCF. This patient with a ptosis and exotropia and hypotropia, third nerve palsy. So this patient, you can see in this, there is a posterior communicating artery aneurysm with a blood in the subarachnoid space. So here the pupil is involved. The pupil is usually mid-dilated and non-reactive pupil. This is a 50-year-old male with a double vision, more so in the down gaze. You can see this patient has a right-sided face turn and a head tilt. So in the primary position, there is left hypertropia. And on right gaze, the left hypertropia increases. On left tilt, the hypertropia is more. So this is a case of left-sided fourth nerve palsy. So the nucleus of the fourth nerve is also located in the midbrain at the level of the inferior colliculi, ventral to the sylvian duct. The nerve then has a unique course. It posteriorly curves around the aqueduct and the decussate at the anterior medullary velum, and then the trunk leaves the brainstem. And then it enters the subarachnoid space between these two arteries, superior cerebellar and the posterior cerebral arteries. Then enters the dura, then cavernous sinus and superior orbital fissure, and supplies the superior oblique muscle. Why it is important? Because in trauma cases, you can get a bilateral fourth nerve palsy because it decussates at the anterior medullary velum. And the most common cause of an acquired fourth nerve palsy is most commonly due to an ischemia, like in diabetes mellitus and hypertension. This is a 52-year-old patient, came with a double vision, and he has a right esotropia and a right face turn. And here you can see the abduction is -3. And the secondary deviation was more compared to the primary deviation, and there were floating saccades. So the sixth nerve nucleus is located at the pons, ventral to the floor of the fourth ventricle. It is closely in relation to the horizontal gaze center, that is pontine paramedian reticular formation. It is also surrounded by the seventh nerve vesicle, producing a facial colliculus at the floor of the fourth ventricle. So sixth nerve, if there is a nuclear palsy, it is never isolated. There will be some associated seventh nerve palsy or a ipsilateral gaze palsy. And the basilar part then enters the cistern. It has a double angulation, one at the cerebellopontine angle and one where it enters the Doral's canal under the petroclinoidal ligament. Then it enters the cavernous sinus in close association with the internal carotid artery. So if you have an internal carotid artery aneurysm, you can get a sixth nerve palsy along with the postganglionic Horner syndrome. Then it enters the superior orbital fissure and supplies the lateral rectus. So as I told, nuclear level, you will get a horizontal gaze palsy and seventh nerve palsy. Vesicular, you can get different syndromes. Subarachnoid space, because of its protracted course, increased ICP and meningitis can involve. That is known as a false localizing sign. And basilar lesions, Gradenigo syndrome, petrositis also can cause, and cavernous sinus, you'll get a multiple cranial nerve palsy. See, here is a 24-year-old obese female with headache and double vision. On examination, her vision is 6/6, both eyes, pupil, color vision, everything is normal. And she has a very small esotropia with a mild abduction deficit in both eyes. But you look at the fundus, you can see there is bilateral disc edema. That's the papilledema. So suspecting an increased intracranial pressure, we have sent the patient for a neurological evaluation. So the CSF opening pressure was found to be more than 300 millimeters of water. And here, the important thing is you have to do an MRI and MRV to rule out a cortical venous sinus thrombosis. So that was normal. So this patient is diagnosed as a case of primary IIH. So the treatment includes the lifestyle measures as well as acetazolamide. So in a case of acute isolated sixth nerve palsy, if it is ischemic, we can observe. And but if you are suspecting a cavernous sinus lesion, brainstem infarct, pituitary apoplexy, etc., you have to do an MRI. Then indications of neuroimaging in a cranial nerve palsy, if the patient is more than 50 years of age, is there an acute onset, multiple cranial nerve palsy, associated brainstem signs, no improvement in 3 months. These are the indications for a neurological imaging. This is a 6-year-old girl. She came to me with an acute onset double vision preceded by a viral illness. And she had esotropia and abduction deficit and dilated fixed pupil on both eyes. And her tandem walking test was positive, suggestive of ataxia. Her MRI was normal, CSF was normal. And suspecting Miller, it's like a ophthalmoplegia with ataxia, so like a Miller-Fisher syndrome, but the reflexes were normal. So it's like a limited form of Miller-Fisher syndrome. We have sent the patient for anti-GQ-A1A antibody that also came to us negative. So it's like an encephalitis with a Miller-Fisher syndrome. So Miller-Fisher syndrome is a variant of Guillain-Barré syndrome. It's ascending demyelinating polyneuropathy. It's a triad of arefluxia, ataxia, and ophthalmoplegia, usually preceded by infections like Campylobacter jejuni diarrhea. CSF analysis, there can be albinocytological dissociation. Another important cause of ophthalmoplegia is Wernicke's encephalopathy. It's due to thiamine or vitamin B1 deficiency. It's usually typically seen in a patient with alcohol abuse or anything that reduces the intake of vitamins or reduces the absorption can produce Wernicke's encephalopathy. It's usually bilateral. There can be acute or subacute form of Nystagmus. Any type can occur, but most often it is up or down beat. Any type of ophthalmoplegia can also occur in this patient, and there will be change in consciousness, ataxia, and mental status. So the treatment here is IV thiamine. We can send the patient for a neurological evaluation, but we should not wait until the MRI report comes, because there is no point in there is no harm in giving IV thiamine in a suspected case of Wernicke's encephalopathy. So MRI will show an increased signal density in the mammillary bodies, dorsomedial thalami, and the tactile plate in the periductal area around the third ventricle. Coming to the neuromuscular and muscle disorders. So these you can see bilateral ptosis and ophthalmoplegia. And the first this video shows the fatigue test. There is drooping of the lid, and the other video you can see this patient with ophthalmoplegia and ptosis improved with after neostigmine test. So ocular motility that doesn't fit into any specific pattern, you should suspect a myasthenia, and there will be fluctuating defects. The one which is seen by today will not be the same after 2 weeks. And myasthenia, as you know, it does not affect the pupil clinically. And so if we have a bilateral acute ophthalmoplegia that is painless and pupil sparing, we should consider myasthenia gravis. Why it is important? Sometimes it could be associated with a generalized myasthenia that could be an emergency. So it's an autoimmune disease. Here, anti-acetylcholine receptor antibodies and anti-MuSK antibodies are seen. And generalized myasthenia can be seen associated with the ocular myasthenia. Pupil will be spared, and these are the tests to diagnose. And another important cause is botulism. That is, it's a neurotoxin from the spores of Clostridium botulinum. It blocks the presynaptic release of the neurotransmitter acetylcholine at the NM junction. So it leads to reversible chemical denervation of the muscle fiber, leading to paralysis. And there can be a fixed dilated pupil, drooping of the lid, and double vision, dry mouth, and even it can lead to respiratory paralysis and even death. So here is a mnemonic courtesy by Dr. Andrew G. Liu. BMW care. That is B for brainstem and botulism, M for myasthenia gravis and Miller Fisher, W for Wernicke's encephalopathy, then C for cavernous sinus syndrome and carcinomatous meningitis. So the take-home message is ophthalmoplegia can occur from lesions in the brain stem to the muscle. Clinical examination is the key to diagnosis. We should always look for associated neurological features. Always remember the anatomy and tailor your investigations according to the anatomical localizations. Management includes a teamwork with your neurologist, radiologist, and oculoplasty fellow. Thank you so much.
Thank you, Dr. Ramya, for that excellent presentation. And she tried to simplify the more complex topic. And as she said, it is very important to know the anatomy to diagnose the lesion and treat it. Okay, that was the last topic of today's CME. And Sreeni?
Yeah, Dr. Jyoti has explained Ramya really well. Nice presentation, Ramya. And I thank TACO for taking the challenge of having this virtual CME. Special thanks to Dr. Latika and Dr. Jyoti for helping me out with the CME. And so, I mean, still, it's 10 o'clock now. 1 hour we have overrun, but still there are a lot of people watching on YouTube now. So that's thanks to the wonderful collection of faculty and wonderful selection of topic. Roland, Bastin, final words, and we can conclude now. People have to go for dinner.
Just one line, Sreeni. Like it was actually Sreeni's idea to make this program, and I need to acknowledge the help of 3 persons. Like one is Dr. Latika, who actually made these topics, and Dr. Tanu, who was helping me to make out the brochure, these flyers and all. And Roland, of course, was collecting all the data about the speakers and arranging this program. And thank you all. Thank you very much.
Thank you, Ankit. Thank you.